guys, what's up? It's Stephanie. Welcome back to my channel. So in the video today, I'm going to be doing an OB-GYN end of rotation exam review. I know I already did a previous video and I uploaded one, but that was more concise, kind of a video for those of you who are like in the last week or last 2 weeks and are wanting to cram. That would be a perfect video for you. But the video today I kind of wanted to do was more in depth, so it's going to be involving a lot more information for those of you that really want to understand the information and just want to ensure that they cover everything in regards to what is on the OB-GYN end of rotation exam. The other one does cover the key points, right? But it's just the key points, what you need to know. This one is just a lot more in depth, that it's going to cover a lot more. So if you are interested, just follow along. So why don't we start with our amenorrheas, right? Amenorrhea. So we have primary amenorrhea, and then we also have secondary amenorrhea. So whenever we think about primary amenorrhea, right, we're going to think about a patient that has never had menstruation before. So it's going to be a woman, a girl that has never menstruated before. Versus secondary amenorrhea, it's going to be a patient that has already started the menstruation, they've been menstruating, but they stopped menstruating for some reason. And so in regards to second amenorrhea, the most common cause by far is going to be pregnancy, right? Woman becomes pregnant, they stop menstruating. So why don't we go into our primary amenorrhea? So primary amenorrhea, we have different types and different causes. So the first one's going to be your Mullerian agenesis. This is going to be 15% of your primary amenorrhea. And in general, like I said, primary amenorrhea is going to be an absence of menarche by the age of 15, right? And usually with primary amenorrhea, they're going to have presence of normal growth and secondary sex characteristics. So going back to Mullerian agenesis, this is going to be a congenital absence of the vagina, cervix, uterus, and fallopian tubes, but the ovaries are present. What they really like to test on this one is the karyotype. So just know that you know and familiarize yourself with the female karyotype. So it's going to be 46XX. Usually these patients are going to have a short or absent vagina, and they're going to be presenting with that primary amenorrhea, right? Because it's a cause of primary amenorrhea. And some of the signs that you're going to see on your physical exam is going to be a small vagina opening with a bland pouch, normal secondary sex characteristic, and renal abnormalities. For diagnostic tests, you want to make sure you do a TSH, which is going to be normal. You're going to do a pelvic ultrasound. You're going to see normal ovaries and absence of the uterus and cervix. And then you can also do a karyotype, and this is where we're going to see what? That 46XX. Renal ultrasound, also what we're going to do, and that's going to help us check for any renal abnormalities which are going to be present in this patient. So what's going to be the treatment for these patients? We'll usually do the McLindo procedure, which is going to be a skin graft to create an artificial vagina. And that's usually going to be the treatment for these patients with Mullerian agenesis. So the next one's going to be your androgen insensitivity syndrome. Usually these patients, we think about the hermaphrodites, right? Because they are phenotypically female, but inside they're males. So these patients are usually going to have no uterus. They're going to have a testes. So they're going to have testes that are going to be present. The karyotype for these patients is going to be 46XY. And what happens is that testes cause your MIF secretion, which leads to no Mullerian structures, right? So your Mullerian inhibiting factor. So testes cause that Mullerian inhibiting factor secretion that leads to no Mullerian structures that are resistant to testosterone due to a defect in the androgen receptor. And what happens is that these patients fail to develop male sexual characteristics. And this one's going to be an X-linked recessive disorder. How is this patient going to present? They're going to have symptoms of primary amenorrhea, normal breast development, and signs they'll be very tall, blind vaginal pouch, and little to no axillary or pubic hair. Diagnostics, you're going to do a TSH level, so it's going to be high. Testosterone level is going to be high also. The pelvic ultrasound, you'll see normal ovaries, but absence of the uterus and cervix. And then, of course, you're going to do the karyotype, which we're going to see what? 46XY. Treatment for these patients is going to be a gonadectomy. So this one's required to prevent gonadal neoplasia. And then surgery, also, we tend to delay this until the patient has gone to puberty, right? Because tumors can develop after puberty and during the growth spurt. Prognosis for this is that these patients have an increased risk of malignancy. So that's why, like we said, we remove the gonads after puberty, and testes should be excised after puberty, once again, because of increased risk of testicular cancer. The next one's going to be imperforated hymen. This is going to be another cause of primary amenorrhea. Usually what you'll see and what happens is that there's lower genital tract malformation. So at birth, due to vaginal secretions that are stimulated by maternal estradiol, causes a bulging introitus, right? This patient is going to be presenting with primary amenorrhea, cyclical abdominal or pelvic pain during adolescence, back pain, pain with defecation, or difficulty urinating. On your physical exam, you're going to see a perirectal mass, also known as your hematocolpus, which is a bluish mass that is pushing through the labia. And that's usually what you'll see on your pictures. If you do get pictures, it's going to be that perirectal mass, that bluish mass. It's pushing through the labia. Usually, what it'll say on the question stem is that there's difficulty inserting a speculum, right? And these patients are going to have normal secondary sex characteristics. The first thing with these patients, what we want to do for diagnosis is that we want to rule out pregnancy, right? So we're going to do a beta HCG. And what's going to be the treatment? Usually it's going to be surgical correction, right? It's usually preferred during infancy, post-puberty, or pre-menarche. The next one's going to be your secondary amenorrhea. So like we discussed, secondary amenorrhea, it's going to be in a woman that has already had a period before. So they've already menstruated. So it's the absence of menses for 3 months in girls or women who have previously had regular menstrual cycles, or 6 months in girls/women who had irregular menses. Most common cause by far is going to be pregnancy, and that's the first thing that you need to think about. Other causes can be polycystic ovarian syndrome, functional hypothalamic amenorrhea, and hyperprolactinemia or other causes. So let's get into each one. So when we go into PCOS, right, or your chronic anovulation with estrogen, with these patients, what happens is that they have a higher GnRH, which is going to cause higher androstenedione, and testosterone and estrogen, which is going to cause your higher luteinizing hormone. And what happens is that since you have so much estrogen, right, that's going to decrease your FSH, so you won't have any LH surge. And that's what usually occurs with menstruations, right, when we think about the physiology. Insulin resistance is also another cause of chronic ovulation. So what happens is that there's direct insulin stimulation of the theca cells, also chronic anovulation, very commonly found in your pubertal woman. And some of the risk factors is if the patient has a first-degree relative, like their mother suffered from PCOS, it's very common that this patient will also get PCOS. And usually what you'll see is ovaries that they contain multiple follicular cysts that are just inactive. So it's just going to be an ovary with so many cysts that are inactive. Symptoms, this patient is going to be presenting with menstrual irregularities, amenorrhea, and then even menorrhagia. Infertility, so like we said, ovulation induction yields increased risk for multifetal pregnancy. Hirsutism, why? Because your peripheral androgen excess, metabolic syndrome like diabetes or insulin resistance, hypertension, central obesity. Signs on your physical exam, you might see male alopecia, you might even see those male characteristics, right? Like that coarse facial hair, hirsutism. This is usually a diagnosis of exclusion, so we want to rule out pregnancy in these patients. We want to get a thyroid function, and we're going to see a TSH, which is either normal or high. And the free T3 is usually going to be high, and the FSH is going to be low. So your follicular stimulating hormone is going to be low. We also want to look at the gonadotropins, which the luteinizing hormone is going to be high. Why? Because it's responding to that increased amount of estrogen. The LH is going to be a lot higher than FSH, and that's a key for this one, right? So like we discussed, the FSH is going to be decreased, but the luteinizing hormone is going to be very, very high for these patients. The prolactin can be normal to increase. Another key for this one is going to be your androstenedione and your DHEA are going to be increased. So once again, for repetition, LH is going to be a lot more increase than FSH, and your androstenedione and DHEA are going to be increased. If you do progesterone administration, right, where you insert progesterone just to see if the uterus is functioning and it's responding to that progesterone, you will have bleeds because the uterus is responding. The definitive diagnostic test is going to be your ACTH test, right? You can also do a pelvic ultrasound. So the treatment for these patients, its first line is going to be oral contraceptives. So oral contraceptives is going to help them control their amenorrhea. It's going to help them prevent them from becoming infertile. It's going to help them from creating more cysts on their ovaries. The second line could be Clomid, like clomiphene citrate. This is especially important in your patients that want to have children, like if they're infertile because of PCOS and they want to become fertile, you want to think about clomiphene. And the thing about clomiphene citrate is that it induces ovulation. Another thing that you want to do, a lot of these patients are diabetic, so they have insulin resistance. Control their diabetes, so give them metformin. And then, of course, you can also do your potassium-sparing medications like spironolactone. Of course, what are some of the complications of this if it's not treated? Endometrial hyperplasia and cancer, because you have unopposed estrogen. Once again, you have all this estrogen that is just building in that uterus wall, and you don't have progesterone coming in there that's evening, right? So you're going to have an abnormal growth of that uterine wall, which makes the patient more prone to getting these cancers, right? Like endometrial hyperplasia and cancer. And just for the diagnosis for these patients, we usually think about the Rotterdam criteria, which requires 2 out of the 3. So the patient either has to have hyperandrogenism, either clinical or biochemical, oligo or amenorrhea, so oligomenorrhea or amenorrhea, and they have to have polycystic ovarian syndromes or polycystic ovaries, 12 or more on the ultrasound. So they have to have 2 out of 3, that's the Rotterdam criteria, to be diagnosed with chronic anovulation or PCOS. So the next one's going to be your hypogonadotrophic hypogonadism. This is a chronic anovulation with estrogen that's absent. It's also known as your functional hypothalamic pituitary amenorrhea, right? It's an inherited hypothalamic abnormality where there's lack of normal pulsatile secretion of the gonadotropin releasing hormone that leads to decreased stimulation of the pituitary gland to produce FSH and LH, which leads to anovulation and amenorrhea. So once again, what happens is that you have the result of ovarian failure or follicular resistance to gonadotropin stimulation. Some of the causes of this is going to be disorders of the anterior pituitary, right, like pituitary adenomas, drugs like weed, psychogenic, anxiety, anorexia nervosa is one of the big ones when we think about hypogonadotropic hypogonadism. Functional abnormalities like weight loss, obesity, excessive exercise also, and chronic debilitating diseases. So what's going to be usually the history that you're going to see for these patients? You're going to have excessive exercise, stress, anorexia nervosa, or significant weight loss. They'll have anovulation, amenorrhea. Usually with these patients, they're going to have normal, right, external genitalia. And these patients are going to be presenting with dyspareunia. So dyspareunia is going to be painful sexual intercourse, right? Why? Because they have vaginal dryness. Why? Because they don't have estrogen, so estrogen deficiency. With these patients, the first thing that we want to do is rule out pregnancy, right? So we want to do a beta HCG. We also want to do a prolactin, just to rule out things like a prolactinoma, which is usually going to be normal in these patients. Do a thyroid test, just to make sure that the patient's not hypo or hypothyroidism. So the TSH is going to be normal. And then we're going to look at their FSH and LH levels, which are going to be decreased, right? And usually the FSH is going to be, FSH and LH is going to be decreased with these patients. We can also do a hemoglobin A1C just to rule out diabetes, right? And then usually with progesterone withdrawal tests, it's going to be no bleeding. So no bleeding once you do the progesterone with these patients. And then, of course, we can do an MRI with contrast just to rule out that the patient has a pituitary adenoma. So the first thing that we're going to do in regards to treatment is to treat the underlying cause, right? If it's a prolactinoma, do a bromocriptine. If it's a patient that lost a lot of weight because they're anorexic, weight gain. Reduction in exercise if it's a patient that's exercising too much. A resolution of illness or emotional stress if it's due to anxiety, right? Another thing that we can do is estrogen replacement therapy. This is actually going to be for women that want to continue exercising and they are not wanting to become pregnant, right? And the thing about estrogen replacement therapy, it's going to help these patients prevent osteoporosis and heart disease. And then we can do exogenous gonadotropins for women that want to become pregnant. So the next one's going to be your Asherman syndrome, which is going to be your intrauterine adhesions, right? This is going to be usually what happens is that there's intrauterine scarring, right? So it's any type of damage to the uterus that is caused that causes your secondary amenorrhea. So with these patients, like I said, it's going to be some type of uterine instrumentation, like a DNC, right? That the patient has some type of surgery or damage to that uterus, even after having a vaginal delivery or pregnancy termination. Also, if the patient has a history of endometriosis. So this patient is going to be presenting with secondary amenorrhea and infertility. And what we're going to do for these patients in regards to diagnostics is that we're going to do the progestin challenge. And when we give the patients progesterone, right, the uterus doesn't work, so the patient's not going to have any withdrawal bleeding because they have damage to that uterine wall. If we administer estrogen and progesterone, once again, the patient's going to have failure to bleed with these patients. And then the confirmatory diagnostic test is going to be a hysterosalpingogram. So we're going to go in there and look at everything just to make sure that everything looks good. And that's going to be the confirmatory. We'll usually see like a webbed pattern for these patients. The treatment's going to be your excision of synechia, so your scars using a DNC, getting rid of those scars, especially for those patients that want to have children in the future, right? Another thing we can do is long-term high-dose estrogen like Premarin or IUD, just to make sure that we're stimulating that growth of the endometrial tissue. The next one's going to be your Sheehan syndrome. This is one of the most common causes of amenorrhea after pregnancy. And Sheehan syndrome is usually postpartum hypopituitarism, which causes necrosis. So there's some type of necrosis that goes on to the pituitary gland that makes a patient amenorrheic. So usually it's due to blood loss and hypovolemia shock after and during childbirth. And what happens is that this severe blood loss that is happening when the patient's giving birth or after birth leads to the death of the pituitary. So it leads to pituitary apoplexy. So this patient is going to be presenting with amenorrhea, breast atrophy, loss of pubic and axillary hair, hypothyroidism, ACTH insufficiency, and failure to lactate. In regards to what we want to do with these patients for treatment-wise, in diagnostics, we want to rule out pregnancy. That's the first thing, right? If we do a thyroid test on these patients, the T4 is going to be low and the TSH is going to be low, which makes sense, right? Because they've infarcted their pituitary glands. In addition, like everything's going to be low with this patient. The estrogen is going to be low, the LH surge is going to be absent, the FSH is going to be low, although it can be normal, but the majority of the case it's going to be low. The cortisol is going to be low, the prolactin is going to be low, and when you give this patient progesterone, they're going to have withdrawal bleeding, right? Because it's not something that's structural, it's something more up here with the hormones, because the uterus is, hey, give me hormones, I'm working, but nothing's working up here. So treatment for these patients, right? Usually these patients are just going to need lifelong hormone therapy, right? Repleting everything that they lost. So the next one's going to be your prolactinoma. This is the most common pituitary tumor causing amenorrhea. Some of the symptoms the patient's going to be presenting with is amenorrhea, galactorrhea, which is going to be that nipple discharge, like milky nipple discharge. Visual field defects is another one, which makes sense right where it's located. It can actually obstruct the nerves that are going to the eyes, right? So they're going to be presenting with the bitemporal hemanopsia, and these patients are going to have normal secondary sex characteristic. Diagnostics, we're going to do a prolactin level. It's going to be increased. Why? Because they have hyperprolactinemia. Why? Because they have a prolactinoma. When we look at the thyroid releasing hormone, it's going to be increased, the TSH is going to be increased, and the T4 is going to be decreased. So these patients are going to have hypothyroidism. And then treatment, of course, is just removing the prolactinoma, right? The next one's going to be dysfunctional uterine bleeding. This is what this is a diagnosis of exclusion. So this is going to be your last diagnosis once you've ruled out everything that we discussed and this patient is still amenorrheic. So it's going to be exclusion of all possible pathological cause of abnormal bleeding, like we discussed. So what are some of the etiologies for these patients? So usually these patients are going to have an absence of any type of anatomic lesion, right? It's usually due to a problem within the hypothalamic pituitary ovarian axis, where the hypothalamus is sending signals to the pituitary, and the pituitary is sending signals to the ovaries. So it's going to be a problem with that. It occurs after menarche and during perimenopause because of an increase in ovulatory cycles. And then, of course, there's other causes of dysfunctional uterine bleeding. When we think about PCOS, obesity, adrenal hyperplasia, usually very commonly found in your perimenopausal woman, and also common in young women, but usually most commonly found in your perimenopausal woman. How is this patient going to present? Abnormal uterine bleeding, and you do a physical exam, everything's normal. Diagnostics, once again, do a beta HCG to rule out pregnancy. And that's the thing, for all these amenorrheas, first thing you should do is a beta HCG, just to rule out the patient is not pregnant. Because like we said, the most common cause of secondary amenorrhea is what? It's going to be pregnancy. Labs you want to do like a CBC, iron study, PT, PDT, TSH, progesterone level, prolactin, FSH, and LFTs. We can do a progesterone trial if bleeding stops and we've diagnosed anovulatory cycles are going to be confirmed. And then a pap smear and then a pelvic ultrasound also. You can do endometrial biopsy, hysteroscopy if you just cannot find the cause of it. And so what's going to be the treatment for these patients, right? If it's an adolescent, we can give them oral contraceptives, right, for these patients. If the patient has been bleeding like a lot and like their hemoglobin level is really low, then in these patients, we would do something like an IV high-dose estrogen. Then we can do medroxyprogesterone for 7 to 10 days. If the patient's premenopausal, then we're going to do hysteroscopy, right, and an endometrial biopsy just to make sure that we rule out cancer. And then we can also do a DNC. Usually we do DNC last line if the patient is not being controlled on contraceptives, right, if they're anemic, and if it's really affecting their life. All right, so now that we've gone into that, why don't we just discuss real quick menstruation and how the FSH, ultrasound findings, what you're going to see for testosterone are going to present on each one of the primary amenorrheas that we discussed, okay? So for gonadal dysgenesis, the serum FSH is going to be high, and then the next thing we want to do for these patients is going to be a karyotype like we had discussed, right? Mullerian agenesis, the FSH is going to be normal. The ultrasound findings, we'll see an absent uterus like we discussed, and the testosterone level is going to be normal. The next thing we want to do for these patients is going to be a karyotype. For androgen insensitivity syndrome, the FSH is going to be normal. The ultrasound findings, it's going to be an absent uterus, right? And the testosterone level is going to be usually in the range for men, right? It'll be high. And the next thing we want to do is karyotype. Remember with the androgen insensitivity syndrome, we think about hermaphrodites. And then we have your hematoculpus, right? The serum FSH is going to be normal, and ultrasound findings will see blood in the vagina for these patients. So I just wanted to go over those because I know there's a lot of confusion in regards to the causes of primary amenorrhea. So next thing I wanted to go over is just how do you manage dysfunctional uterine bleeding? Like what is going to be your treatment for these patients? So if it's a patient that's coming in and they're having an acute bleed and they have a hemoglobin less than greater than 12, with these patients, what we're going to do is just monitor their menses, right? Give them iron, give them NSAIDs, because this can actually help reduce the flow. And then we can also consider oral contraceptives if the patient is sexually active and they don't want to have children, right? Now, if they have a hemoglobin of 9 to 12 with dysfunctional uterine bleeding, then these patients get oral contraceptives twice a day until the bleeding stops. And you're going to continue them for 21 days after that. If it's severe, which is dysfunctional uterine bleeding less than 9, these patients get admitted, especially if they have a hemoglobin less than 7, right? Or if they're unstable hemodynamically, like they're hypotensive, right? They're tachycardic, bradycardic. And another thing we can do for these patients is going to be conjugated estrogen. So we're going to give them 25 milligrams IV every 4 hours for up to 48 hours with these patients. So that's going to be for acute. What if it's long-term treatment for a patient that has mild dysfunctional uterine bleeding? So mild is going to be anything greater than 12. Once again, just monitor the menses and their hemoglobin and have them follow up in 2 to 3 months. If they have moderate long-term dysfunctional uterine bleeding, iron, monitor the hemoglobin. We might need to give them twice-a-day oral contraceptives, especially if the bleeding persists. And if the bleeding is controlled, then we can give them oral contraceptives, right? Usually like the 28-day pack, which is a month pack. And then just continue that for about 3 to 6 months after that. If it's severe, long-term dysfunctional uterine bleeding, like their hemoglobin's less than 9, like we discussed, they get iron, and we make sure that we look at their hematocrit with these patients. Just monitor that. So the next one we're going to go into is dysmenorrhea. So dysmenorrhea is just women that have pain with their menses, right? So painful menstruations for dysmenorrhea. And the thing about dysmenorrhea is that we have two different types. We have primary dysmenorrhea, which is no organic cause, right? We can't find a cause of the painful menstruation, versus secondary dysmenorrhea, where there is a cause, like endometriosis, for example, that is causing the painful menstruations. So primary dysmenorrhea, like we said, has no cause, no organic cause. And this patient is going to be presenting with those painful uterine muscle activity. Why? Because there's an excess of prostaglandins. And that's why NSAIDs are the best treatment for these patients, because NSAIDs are antiprostaglandins. And what happens in primary dysmenorrhea, you have an excess amount of prostaglandins. Very commonly found in your teenagers, and usually that's how it's going to be in the question stem. It's going to be a teen. They're going to be in their early 20s. And these patients will not have any type of uterine abnormality or pelvic abnormality. Some of the risk factors are going to be if they have menses before the age of 12, nulliparous, they've never had a child before, smoking, family history, obesity. How is this patient going to present? Pain with menstruation, so they'll have that low abdominal pain, labor-like pain. It really does feel like you're going into labor. It's very, very painful. I've had it before. Usually during the first to 3 days of the patient's menses, nausea and vomiting, diarrhea, headache. And then on your physical exam, it's going to be a normal pelvic exam, right? So with these patients, the first one's going to be NSAIDs, like we said, because why? These are going to be prostaglandin inhibitors, so that's why these are the best ones. And then, of course, the second thing we can do is going to be oral contraceptives. So second one's going to be secondary dysmenorrhea. Like we said, this has a pathological cause. This is more commonly found in your older patients. So these patients are going to be presenting with painful menses that has a cause, like it has a pathological cause. So some of the causes, like we discussed, fibroids, polyps, endometriosis, adenomyosis, an IUD. Does the patient have an infection? Tumors, adhesions, and very commonly found in your older women between the ages of 20 to 40 versus primary dysmenorrhea is usually teenagers, right? This patient is going to be presenting with pain with menstruation. It begins mid-cycle and it increases in severity until the end. And diagnosis, we just want to rule out STDs, right? So GC and chlamydia we want to get. And treat whatever is the underlying cause, surgery, antibiotics, cervical dilation, NSAIDs, oral contraceptives. So whatever is causing the dysmenorrhea, you want to treat it. So the next thing we want to go into is going to be menopause. But before we discuss menopause, you really need to understand what's going on in menopause, right? So what happens in menopause is that there's a change in your hormones. So in postmenopausal women, there's a reduction in the amount of androstenedione to approximately 50% of the concentration found in a young woman. So this is why there's an absence of follicular activity with these patients. The levels of the adrenal androgens like DHEA and DHEAS are going to be reduced by 60% and 80% with these patients. They're also going to have a decrease of estradiol, and this usually occurs up to 1 year after the patient had their last menses. And another thing that's going to occur with these patients is that they're going to have loss of ovarian function, and that's the key, right? In menopause is that loss of ovarian function. So what is menopause? What is the diagnosis of menopause textbook-wise? Menopause is going to be 12 months of amenorrhea. So 12 months of amenorrhea with no pathological cause. So no menses for 12 months. If a patient has not had menses for 3 or 4 months, they do not fall under the criteria of menopause. They have to have had no menses for 12 months. And usually what happens is that the oocytes that were responding to the gonadotropins, they disappear from the ovary. And so you start getting fewer and fewer of those oocytes. And then, of course, you have your induced artificial menopause. This is usually where a patient gets cessation of menses, so they go into menopause. Why? Because they get some type of surgery, like they get their ovaries removed, right? Bilateral oophorectomy or ablation of the ovarian function through chemotherapy, radiation. And then we have perimenopause and menopause transition. This is usually the changes in hormones and menstrual cycles that occur a few years before and 12 months after the menstrual period that result from natural menopause. Okay. And then we think about premature menopause. This is going to be a patient that got menopause before the age of 40. So at the age of 40 or before the age of 40 is considered premature menopause. And once again, menopause has to be no menses for 12 months. And then we were talking about perimenopause or the menopause transition. So you're transitioning into menopause. Women, usually they'll have an abnormality with their periods. They're super heavy. Sometimes they miss them, and just like those symptoms, right, of going into menopause. So in menopause, the average age is 51. It ranges between the ages of 44 to 56. And some of the risk factors are going to be smoking, cancer therapy, right, genetics, some of the risk factors for early menopause. So this is what can make a patient go into menopause earlier. So how is this patient going to present? The most common symptoms by far is going to be those hot flashes, right? And with these patients, you're going to be presenting with menstrual irregularities like we discussed, night sweats, problems with sleep, irritability, mood disturbances, vaginal dryness is one of the common ones. So they're going to be complaining of dysmenorrhea, which is painful sexual intercourse, which makes sense, right? Because these patients are not producing estrogen anymore, and estrogen is what causes that lubrication. They don't have that anymore. It's going to be very painful sexual intercourse. On your physical exam, you're going to see vaginal atrophy, right? Loss of skin elasticity. And then in late menopause, since these patients are not producing that estrogen, that progesterone, estrogen is protective. I mean, it protects you against so many things. It's cardioprotective. So if you're not producing that estrogen anymore, these patients are going to be prone to what? Cardiovascular disease, right? Osteoporosis is a big one. Macular degeneration, periodontal disease also. They'll have memory problems like Alzheimer's disease. And diagnosis for this is going to be, once again, 1 year of no periods after the age of 40 with no pathological cause. The thing that they really like to test for this one is in regards to the hormones that are going to be decreased and elevated. So the FSH is going to be elevated, right? Because the FSH is like ovaries respond, but the ovaries are like slowly shriveling away. No one's responding. The oocytes are disappearing. So that's why FSH is like respond, and no one's answering, right? Calling, no one's picking up the phone. The estradiol is going to be low, less than 20. And this is usually what establishes the diagnosis of menopause, right? It's going to be that low estradiol because it's going to tell you the status of that ovary. With these patients, the luteinizing hormone is going to be elevated also, and then you may have normal or decreased androstenedione. Treatment for these patients, we can do estrogens, but once again, it's going to be, estrogens. These are going to be used to treat hot flashes. And the thing about estrogen is that we do not use estrogen alone in a patient with an intact uterus. Why? Because the patient has increased risk of endometrial cancer. So best treatment for hot flashes, right, it's going to be estrogens. But we tend to avoid any hormone by itself because, once again, a woman in menopause is not producing those hormones. So if you only give estrogen, which is going to be building that uterus, building it, there's not going to be that progesterone that comes in and equalizes that uterus. So it's just going to be building it. Nothing's going to come in to equalize it. So that's why estrogen use in patients that still have a uterus, right, and they're menopausal is not used, because you can make these patients prone to getting endometrial cancer because you are adding estrogen to that uterus. That uterus is going to be prone to being atypical, right? That atypia. Progesterones you can use for hot flashes, but these patients have increased risk of breast cancer. SSRIs and SNRIs are usually one of the good ones and the best ones used for hot flashes, right? Hormone replacement therapy only if the patient has severe menopausal symptoms, right? We want to make sure that we start with the smallest dose with these patients. So next one we're going to go into is premenstrual dysphoric disorder, right? This is basically severe PMS with functional impairment. So with premenstrual dysphoric disorder, this is going to be, so you have premenstrual dysphoric disorder and then you have premenstrual syndrome, right? They're very similar, but the thing about premenstrual dysphoric disorder is that this one's very severe, and it's actually going to be the more disabling form and extension of PMS, of your premenstrual syndrome. Premenstrual dysphoric disorder, very, very severe. Usually it affects the patient's daily life that they can't even function. So that's how you think about these. So this is going to be a type of depression where the patient is depressed, they have anxiety, they have anhedonia regularly, and the key about these is that they only occur during the luteal phase of the menses. So once again, they only occur during the luteal phase of the menses. Some of the risk factors that the patient has had is going to be previous anxiety, depression, and how is this patient going to present? So usually with these patients, it occurs in most menstrual cycles during the past year, and they have to have 5 or more of the symptoms that were present most of the cycle and during the last week of the luteal phase. So what are these symptoms that we were discussing? So they have to have at least one of the following, has to be either 1, 2, or 3, or 4 that we discussed. So they have to have disturbance that is markedly interferes with their work, school, social activities, and relationships. So it's markedly interfering with their daily life. Disturbance is not merely an exacerbation of the symptoms of another disorder like depression, panic, dysrhythmia. And like I said, these symptoms have to be confirmed during at least 2 consecutive symptomatic cycles. So they have to have these symptoms for at least 2 periods. First line for these patients is going to be SSRIs. So what is going to be the criteria for premenstrual dysphoric disorder? So these are going to be the criteria. They have to have depression, anxiety, tension, feeling of being on edge, right? Feeling sad, persistent or marked anger, irritability, those angry outbursts, poor concentration, lethargy, fatigability, marked lack of energy, marked change in appetite, like they're overeating or they're craving a lot of foods, they're sleeping too much or sleeping too little, so hypersomnia or insomnia, feeling overwhelmed. Somatic symptoms that they'll have is going to be breast tenderness, abdominal bloating, headache, joint pain. So these patients have to have these symptoms to be diagnosed with premenstrual dysphoric disorder. So let's go with premenstrual syndrome. Like we said, this one's going to be the less severe form. Premenstrual dysphoric disorder affects the patient's daily life where they just cannot function. So premenstrual syndrome is going to be a cyclic occurrence of symptoms that are sufficient severity to interfere with some aspects of life, right? So some aspects of life. And they are related to the patient's menses, right? The symptoms, once again, are going to be during the luteal phase, right? With these patients. And usually with these patients, they're going to be presenting with headache, breast tenderness, pelvic pain, bloating, premenstrual tension, irritability, dysphoria, mood. They can also present with abdominal discomfort, clumsiness, lack of energy, sleep changes, mood swings. In regards to behavior, they can have marked changes in appetite, increased crying, changes in sexual drive, sleep changes. And usually the ACOG criteria for premenstrual syndrome is going to be that they have to have at least one effective and one somatic symptom during the 5 days before they get their menses in the last 3 cycles. So they have to have symptoms that are relieved within 4 days of onset, symptoms that are reproducible during any 2 cycles. And so treatment for PMS is going to depend on whether the symptoms are mild, moderate, or severe. So if the symptoms are moderate, usually we're going to educate them, and that's usually first line, right? So give them something like telling them, limit caffeine, right? Limit the amount of alcohol, how much you smoke, and limit the amount of chocolate that you take for these patients. And then stress management, like cognitive behavioral therapy, aerobic exercise. If the patient has moderate symptoms of premenstrual syndrome, first line is going to be SSRIs, and we tend to give these 14 days prior to the onset of menstruation and continue them through the end of the cycle. So SSRIs, we can give something like fluoxetine, citalopram, right, paroxetine, sertraline. If the patient has severe symptoms of PMS, then we can give them something like oral contraceptives. We can give them something like drospirenone, right? GnRH agonists like Leuprolide. We can also give them something like danazol, especially for the mastalgia, which is going to be the breast tenderness. And then definitive treatment for severe symptoms is just getting rid of the ovaries, right? So that bilateral oophorectomy. So what is the criteria for PMS? So the behavioral criteria is going to be depression, anxiety, angry outbursts, irritability, confusion, changes in libido, social withdrawings, food cravings, poor concentration, loss of motor skills. The somatic symptoms are going to be breast tenderness, abdominal bloating, diarrhea, constipation, swelling of extremities, headache, and fatigue. So why don't we go discussing our infections like our cervicitis. So this is where we discuss chlamydia, herpes simplex virus, HPV. So chlamydia is the most common bacterial STD by far. Out of all the STDs, going to be the most common one. This is going to be a gram-negative obligate intracellular. This is something that they really like to test in regards to what is the bacteria, gram-negative, gram-positive. Chlamydia is going to be a gram-negative obligate intracellular. Some of the risk factors is going to be any patient that lacks condom use, right? Lower socioeconomic status, living in an urban area, having multiple sex partners, most commonly found in females between the ages of 15 to 19 and between the ages of 20 to 24. And the thing about chlamydia is that it's an independent risk factor for cervical cancer, so just make sure that you know that. Why? Because usually these patients are very prone to being promiscuous, very prone to getting HPV, which is a cause of cervical cancer. So with these patients, how are they going to present? Usually they're asymptomatic. For men, they're going to have that purulent urethral discharge, that painful urination, itching, scrotal pain, fever, swelling. Women, it's going to be that purulent urethral discharge. They'll have that intramenstrual or postcoital bleeding, dysuria. And on your physical exam, you're going to see that friable cervix for women, and you're going to see that mucopurulent discharge from the cervical os. Diagnostics, we'll do a nucleic acid amplification test. This is going to be the most sensitive. So in AAT, you can also do a culture and a wet mount. Treatment for this is going to be 1 gram of erythromycin. It's just 1 dose. Or you can give doxycycline for 7 days. Usually, since a lot of these patients are not very compliant with their medications, we tend to prefer that 1 dose versus that 7-day course of doxycycline. If the patient is pregnant, then we can give them azithromycin, 1 gram, or amoxicillin for 7 days. And we want to make sure that we treat all partners that the patient has been with if they have chlamydia. So once again, chlamydia is going to be the most common STD. Next one's going to be herpes simplex. This is usually lesions on the genitalia. This one's transmitted through sex, right? And the thing about herpes simplex is that once you get it, it likes to stay there. It likes to stay in the body. So it's going to stay in the sacral region, especially herpes simplex virus 2, right? And with these patients, how are they going to present? So they're going to have usually fever, headache, malaise, painful vesicles is going to be one of the big ones. So you'll see pustules or ulcers on the genitals, very itchy, painful urination. There's going to be multiple. They're going to be bilateral. You'll see tender vesicles that are progressing to tender superficial small ulcers on an erythematous base. That's usually what you'll see in the questions, right? It's going to be those teardrops on an erythematous base, right? So those vesicles. And the thing about these patients is that once they get herpes for the first time, they're going to have very severe symptoms. It's going to be prolonged and it can last up to 3 weeks. But if they have like a reoccurrence, like they've got it and they just have an eruption again later, usually it's mild. It doesn't last so long. It usually goes away in 10 days. So how are we going to diagnose this? The Zank smear, right? Zank smear is usually what we'll do for these patients. So we're going to culture the lesion. Treatment's going to be oral acyclovir for these patients. And it's really important that we treat them because, herpes can go anywhere. It can cause meningitis. We think about our viral meningitis or aseptic meningitis, right? Keratitis, so it can go to the eye, blepharitis, and keratoconjunctivitis. HPV is going to be the next one, human papillomavirus. So the thing about HPV is that we have different types, and you really need to know which ones are going to be your high-risk type and your low-risk types. But for this one, we're going to be discussing only the ones that cause your genital warts, which are going to be your low-risk type, which are going to be HPV 6 and 11. Also known as your condyloma acuminatum, right? Condyloma acuminatum. Condyloma latum is something else. So this one's going to be condyloma acuminatum. Usually with these patients, it's the most common viral STD in the US. And with these patients, sometimes they're asymptomatic. On physical exam, you're going to see these flesh-colored papillary exophytic lesions on the genitalia. So once again, flesh-colored papillary exophytic lesions on the genitalia. This includes the penis, the vulva, the scrotum, the perineum, even the anus, right? You can also see external warts. These are going to be the common ones that you see, right? The ones that are flat, verrucous, or pedunculated. Most common sites in women is going to be the vulva, the perianal area, and the vagina. And then in men, it's going to be the penis and the scrotum. So diagnostic is usually with the RPR-VDR. We want to rule out syphilis, right? So it's going to be usually a clinical diagnosis. We want to test them for all the other STDs like HIV, HPV. Usually what's going to confirm the diagnosis is going to be a shave or punch biopsy, but we really don't do this, right? Because it's very painful. So treatment for these patients, usually they tend to go away by themselves. So usually we give them treatment to improve the symptoms, not necessarily to remove the warts. So we can give them something if needed, like if they just want it because it's cosmetic, give them something like podophyllin or trichloroacetic acid, so your TCA. You can also give them podophyllics cream, right? And then surgery is like last line, like cryotherapy, just surgically excising it or electrocautery. And then how do we prevent these patients from getting HPV? Gardasil, right? Gardasil. And the newer one, Gardasil 9, which protects you against a large amount of your HPV types. So remember we were talking about your HPV types. Whenever we think about 6 and 11, that's your warts. The really bad ones are going to be 16 and 18. These are the ones that are known for causing cervical cancer. So just make sure that you know that, because it's something that's very commonly tested. 6 and 11, warts. 18 and 16, it's going to be your cervical cancer. So the next one's going to be cancroid. So cancroid, we usually think about gram-negative Haemophilus ducreyi, right? It's going to be the most common organism, and this is going to be a gram-negative coccobacilli. Very commonly found in your younger patients between the ages of 15 and 19. And the thing about this one is that there's going to be a painful canker. So it's going to start as a papule, a pustule, and then it's going to go into a pustule, and then it's going to develop into an ulcer. This patient's going to be presenting with painful lymphadenopathy, which leads to a bubo formation. They're going to be presenting with dysuria, which is going to be your painful urination. Dysmenorrhea also with these patients. On physical exam, you're going to see multiple painful punched out ulcers with undermined borders. And diagnostics for these patients is just testing them for syphilis, right? Because this looks very similar to syphilis. So do an RPR or VDRL, and we're going to culture and gram stain that lymph node or ulcer for Haemophilus ducreyi. So once again, Haemophilus ducreyi is what? It's a gram-negative coccobacilli. Treatment is just going to be with 1 gram of azithromycin. If they have any type of lymph nodes that are like fluctuant, right, then we want to IND them because we think about abscess in these patients. The next one's going to be lymphogranuloma venereum. This is actually a serotype of chlamydia. So most common cause is going to be chlamydia trachomatis, right? Primary infection of the lymphatics and lymph node. Very commonly found in your patients are sexually active, especially males that have sex with males. History, they're going to be presenting with symptoms of, so there's different stages. So you have your first stage, your second stage. On your first stage, there's going to be a painless genital ulcer, and this tends to happen 3 to 12 days after the infection. The second stage is going to be 10 to 30 days after the ulcer, and usually with these patients, you're going to see unilateral lymphadenitis or lymphangitis with tender inguinal or femoral lymphadenopathy. Also like grooves, that's another way I've seen this described on question stems. You're going to see enlarged nodes that are called buboes, and these are very, very painful. And once again, we're going to make sure that we are ruling out syphilis, so we're going to do an RPR VDRL. And with these patients, we're going to drain those buboes or abscesses with an IND, and doxycycline is usually the treatment. Doxycycline 100 milligrams twice a day for 21 days. The next one's going to be PID or pelvic inflammatory disease. This is an infection that comes from the cervix or vagina, and it goes into the endometrium, and it involves the endometrium and the fallopian tubes. The most common cause is going to be your STDs, right? Neisseria gonorrhea, chlamydia. And with these patients, usually they're going to be presenting with that mucopurulent malodorous vaginal discharge. So it's going to be, once again, mucopurulent malodorous vaginal discharge. They're going to have abdominal pain. You can actually also have abdominal vaginal bleeding, and sometimes it'll progress to bilateral lower abdominal pain and pelvic pain. And usually they'll also have nausea and vomiting. Urethritis also can present, especially with these patients. So what are some of the signs you're going to see on your speculum exam? You're going to see yellow endocervical discharge that is easily induces bleeding. On your bimanual exam, you're going to feel that uterine or adnexal tenderness and swelling. That's actually one of the ones that's key for this one, is going to be that uterine or adnexal tenderness and swelling. Cervical motion tenderness also is another thing that you'll feel. Rebound and guarding, abdominal tenderness. And then also when we think about pelvic inflammatory disease, there's usually that Chandelier sign that the patient has so much pain that whenever you do your exam, like they'll get up and reach for the chandelier. So that's why it's called that chandelier sign, because that's how much pain the patient is in. So what's going to be our diagnostic test for these patients? So usually with these patients, we're going to do a transvaginal ultrasound, right? We're going to do also labs. On transvaginal ultrasound, you're going to see those enlarged fallopian tubes. For your labs, you're going to see, of course, increased leukocytes, right? You want to do your NAAT to rule out chlamydia and gonorrhea, since it's very commonly associated with PID, gram stain, and then an ESR. Laparoscopy is going to be like the last line, just to rule out things like appendicitis or ectopic pregnancy. And it's really important that we treat these because these patients can become infertile. It can become into an abscess, and these patients are very prone to getting ectopic pregnancies, right, or recurrent salpingitis. So it's really important that we treat PID. So the treatment for PID is going to be depending on whether the patient's outpatient or inpatient. And then, of course, that's going to be depending on how is the patient presenting. If the patient just looks sick, right, they're like hypotensive, like they're like shivering, like very high fever, then these patients get admitted. Okay, so it depends on how the physical exam is going to be of the patient. If the patient's outpatient, we're just going to give him a shot of ceftriaxone, right, plus doxycycline for 14 days. If you suspect the tubular ovarian abscess, which is commonly associated with PID, then in these patients, we tend to give them flagyl orally for 14 days. And why flagyl, metronidazole? We want to make sure that we cover those anaerobes, right? Inpatient treatment is usually we want to hospitalize them once again in these patients. And we want to hospitalize them if the patient's pregnant, if there's a pelvic abscess, right? If they're severely ill, like we said, with these patients, if they're immunosuppressed, if they failed to respond to outpatient therapy that we gave them. And usually for these patients, we're going to give doxycycline plus IV cefotein or cefoxetine for 48 hours. Then oral doxycycline for 14 days. Another thing we can do is clindamycin plus gentamicin. And then, of course, after that, oral doxycycline for 14 days. So the next one's going to be syphilis. Syphilis is caused by a spirochete. And the spirochete is called Treponema pallidum. It's transmitted through sexual contact with the lesions. And this patient is going to be presenting differently depending on what stages they're in. So you have your primary stage, your secondary stage, your latent stage, and then your tertiary stage. So your primary stage is going to be a canker. It's going to be your indurated, painless, crater-like lesion with a clean base appearing on the genitalia 3 to 4 weeks after exposure. They will heal in about 14 weeks, but these are very, very highly infectious, right? And this patient is going to be presenting with inguinal lymphadenopathy. So primary is going to be that canker. It's going to be a painless, right, ulcer, and they're going to have that inguinal lymphadenopathy. Your secondary stage is where the patient is very, very contagious. So this is where they have those flu-like symptoms, headaches, sore throat, malaise, and this tends to develop after the canker went away. So the canker went away, 4 to 8 weeks later, the patient has this maculopapular rash that starts in the sides of the trunk, right? And this is going to be your secondary stage. These patients can also present with hepatitis, right? Aseptic meningitis. And then you have your latent phase. So with latent phase, usually these patients are going to be presenting with positive serological tests, but they won't have any clinical symptoms or signs. They tend to remain asymptomatic, and it's called early latent if the serology is positive for more than 1 year, and it's called late latent if the serology is positive for 1 year and the patients are contagious, right? And then you have your tertiary phase. This is like years after the patient developed the primary infection. And these patients are going to be presenting like really sick. So you'll have your neurosyphilis, cardiovascular syphilis, GUMAs, which is going to be, or gummas, or subcutaneous granulomas, neurosyphilis, which is going to be the patient with dementia, tabes dorsalis, which is going to be that posterior column degeneration. So they won't be able to coordinate well. But this one's very rare because we treat it, because now we have penicillin. Back then there wasn't penicillin. I had a patient that had a history of tertiary syphilis, and he had a mentality of a 6-year-old. It was really sad. So diagnostics, the gold standard is going to be your dark field microscopy. So that's going to be the gold standard. But what are you going to start with? You're going to start with your RPR and VDRL. This is going to be good for screening. Once again, so see what the question asks you. If it tells you what's the next thing you're going to do, you're going to do your RPR and VDRL, right? What does RPR stand for? Your Rapid Plasma Reagent. VDRL stands for Venereal Disease Research Laboratory. So this is what you're going to start with. Okay, start with these two. Now, what's going to help you confirm it is going to be your treponemal test. So these are specific to the treponema, right? To the spirochete. So these are going to be specific. We're going to do our fluorescent treponemal antibody absorption test, or your FTA-ABS. So once again, the best screening is going to be your RPR-VDRL. The best diagnostic that's going to confirm it is going to be your FTA-ABS. And then the gold standard is going to be your dark field microscopy. And then make sure that we test all these patients for other STDs, because if they have one, they're very common to maybe to have HIV or the other ones. So what's going to be the treatment? So once again, early syphilis, penicillin, penicillin G. So penicillin G, benzathine, 1 dose intramuscular. If it's late or tertiary syphilis, then we're going to give penicillin, 3 doses of penicillin for 1 month, 1 week apart. If it's neurosyphilis, we're going to give IV penicillin for 14 days. And with this one, there's really no such thing as allergies to penicillin. It's because penicillin is really good at treating syphilis. So if the patient is allergic to penicillin, then we're going to desensitize them before we give them penicillin. And it's really important that with these patients, once we've treated them, we want to repeat the test, right? Just to make sure that the patient has been treated and we've gotten rid of all that spirochete, we've gotten rid of the treponema. So the next one we're going to go into is the different causes of vaginitis. So let's start with trichomoniasis. Trichomoniasis is caused by a parasite, by a protozoa, and that's really gross, right? They look so pretty under the microscope. They look like kites. So with these patients, they're going to be presenting with increased vaginal discharge and odor, dysuria, frequency, dyspareunia, vulvar irritation, itching. On your signs, you're going to see that diffuse, thin, yellow-green to gray, frothy discharge in the vagina. It's going to be a malodorous, musty, amine odor. You're also going to see a friable cervix. You'll see that strawberry cervix. You'll see some petechiae. On your wet mount, you're going to see motile trichomonads, and that's usually what's pathognomonic for this one is going to be those motile parasites, the protozoan. And another thing about this one is that the pH is going to be basic versus the other ones. Usually it's acidic. This one's going to be basic, so it's going to be a pH between 5 to 6.5. Treatment's usually going to be with metronidazole. How I think about it, anything that's protozoa-like, metronidazole is going to be the best treatment. So 2 grams of metronidazole, single dose, right? Another thing that you can give is tenofovir, which is from the same class of medications. There's debate on whether tenofovir is better than metronidazole because there's becoming so much resistance. So just keep that in the back of mind. The thing about metronidazole, though, is that you need to educate patients that they cannot drink alcohol for 48 hours, because if they don't, they're going to get this disulfiram-like reaction where they get very intense nausea and vomiting. So that's the thing that you need to educate these patients. And then, of course, ensuring that we treat the patient's partner. The next one's going to be BV, bacterial vaginosis. This is the most common cause of vaginitis, and it's caused by Gardnerella. So it's going to be caused by Gardnerella. This one is not an STD, and what happens with these patients is that they just have a disruption of the normal flora in the vagina, right? And what happens is that this allows proliferation of anaerobic bacteria. So with these patients, usually some of the risk factors is going to be frequent douching. That's why we tell patients, women, not to douche, because they're disrupting, once again, that good vaginal bacteria, that vaginal flora. Usually these patients are going to present asymptomatic. If they do present with symptoms, usually it'll be that vaginal discharge, painful sexual intercourse, so that dyspareunia, dysuria. Fishy discharge is going to be one of the big ones after sexual intercourse. No itching, though. And what you'll see on your physical exam is going to be a fishy odor, right? And that thin, ivory, homogeneous gray discharge. Diagnosis, we think about the Amstel criteria, where the patient has to have 3 out of 4 of the following to be diagnosed with bacterial vaginosis. So they have to have this thin, gray, homogeneous discharge, the positive whiff test, so the KOH test is going to be a positive amine odor, and clue cells on the wet mount, right? Clue cells. Another way I've seen this asked is like epithelial cells. So just make sure that you keep that in mind. So it'll be epithelial cells that are surrounded by bacteria. Because once again, the PANS and like the EORs are moving away from the buzzwords. So if you see anything that says your epithelial cells that are surrounded by bacteria, then think about your clue cells, which are associated with BV. Treatment for this one's going to be metronidazole 500 milligrams for 7 days, or you can just give him vaginal metronidazole. And once again, this one is not sexually transmitted. This is just because there's some type of disruption to the normal flora of the vagina that causes an overgrowth of the bad bacteria. Next one is going to be your atrophic vaginitis. So this is very commonly found in your postmenopausal woman. What happens is that there's a thinning of the epithelium that covers the vagina after menopause. Why? Because we were discussing the patient's not producing any more estrogen, which would usually coat that vagina. This patient is going to be presenting with dyspareunia, painful sexual intercourse, thin vaginal discharge. Usually it'll be clear or even serosanguinous. Vaginal itchiness, burning, and soreness. Some of the signs that you'll see on your physical exam is going to be those signs of an atrophic vulva. So you're going to see a smooth, shiny, pale, dry, or thin epithelium. So the vulva is going to be looking like that. You might see some vaginal petechiae that's going to be scattered. The patient may be presenting with a discharge, and if it is, it's usually a clear color or a brown discharge. Clinical diagnosis, we can do a vaginal cytology, and this is where we're going to see greater percentage of parabasal cells, which means that there's more atrophy going on with these patients. And the pH is usually going to be between 5 to 7. Treatment for these patients, just give them lubricants, right? It's going to help with that dyspareunia. We can also give them topical vaginal estrogen like Premarin. Next one's going to be candidiasis, also known as your yeast infection. This is going to be the second most common cause of vaginitis. Remember that the most common cause of vaginitis in general is going to be BV, bacterial vaginosis. The second most common cause is going to be Candida albicans specifically. Very commonly associated with your patients women that just finished an antibiotic course, if the patient's pregnant, if they have any type of immunodeficiency, usually we think about diabetics. If it's a diabetic woman that's coming in with this, or an undiagnosed diabetic woman that's coming in with their third yeast infection of the year, think about maybe they might have diabetes, right? Also very associated with oral contraceptives, tight-fitting clothes. How is this patient going to present? They're going to have that itching, burning, and external dysuria, which is going to be that painful urination. Dyspareunia, which is going to be that painful sexual intercourse. And on physical exam, you're going to see that odorless, thick cottage cheese curd-like discharge. It literally looks like cheese. You'll see erythema of the vulva and vagina, excoriation because the patient's going to be squashing since it's very, very itchy. Diagnosis, you're going to do a wet mount. You're going to see that budding yeast. And if you do a gram stain, you're going to see that pseudohyphae or tangle, so it's spaghetti and meatballs. And the thing about this one, right, is that this one's very, very acidic, so the pH is going to be less than 4.7. Treatment's going to be fluconazole, so you can do a treatment of 150 milligrams of fluconazole once, right? So next one we're going to go into is going to be breast cancer, so it's going to be your neoplasms. So with breast cancers, they're usually invasive carcinomas that are composed of malignant epithelial cells that infiltrate the breast stromal tissues that are associated with the tendency for tumor metastasis to regional and distant sites. In situ carcinomas are usually confined inside the ductal lobular system and are not capable of producing metastatic disease. Versus in situ carcinomas, right? These actually do give rise to invasive carcinomas. So what's the process of the cancer invading the breast? So what happens is that there's infiltration of tumor cells through the basement membrane that surround the ducts, the lobules, and there's loss of the myoepithelial cell layer. So let's go into each one. So breast cancer, right? Some of the risk factors for breast cancer in general is going to be age, sex, first-degree relatives. Also, if they have BRCA1 or BRCA2 positive, they're very prone to getting breast cancer, which is going to be a gene mutation. Other factors that are associated with breast cancer is going to be nulliparity, so a woman that has never had a child. That's why having children is protective against a lot of cancers. Early menarche is another one. Late menopause is another one. So having your menses earlier and having your menopause later. Why? Because you're having more menstruations during that time. So you're having more exposure to hormones. Also, another thing is going to be radiation exposure, advanced maternal age at the first time that the patient had their baby, because once again, you're getting more exposure to your periods, which is more exposure to hormones. And another thing that keep in mind is going to be the types of cancer. So HER2 positive is usually going to be all invasive lobular carcinomas, and 2/3 of ductal carcinomas are HER2 positive or estrogen receptor positive. So how is the patient going to present that has cancer, your breast cancer? So usually it's going to be that single non-tender, firm, immobile mass. It tends to occur more commonly in the upper outer quadrant, right? And it can occur even under the nipple and areola. Usually the patient's going to be presenting with nipple discharge. These are rare signs, retraction, dimpling, right? We usually think about that peau d'orange because it looks like an orange. You know how oranges have dimples. Breast enlargement, shrinkage, skin thickening, eczematous changes, right? Breast pain, fixed mass. It can even enlarge the axillary lymph nodes. That's why whenever we do our breast exam, we're also feeling for that tail of Spence, right? Ulcerations, arm edema, and also palpebral supraclavicular node. So why do you get that arm edema? Because if those lymph nodes are being obstructed, you're getting all that lymph that's coming back and causing that edema. So diagnostics, we usually do fine needle aspiration for these patients, especially if we have a very high suspicion that the breast mass that we're feeling is breast cancer. Also genetic testing for any patient that has a very strong family history of breast cancer. And then axillary lymph node staging with sentinel lymph node biopsy is another one. So the treatment for these patients is going to be with tamoxifen. With these patients, usually we use this for women with ER positive disease and postmenopausal women. Chemotherapy is another way. Lumpectomy with sentinel node lymph node biopsy. So once again, right, with these patients, if we need to remove the breast, we're trying to be as breast conservative as we can. So always keep that in your back of your mind when you're choosing the question stems. You're trying to preserve as much breast as you can. So if you can only remove the lump in addition to the lymph node, just to make sure that it has not metastasized anywhere else. If you need to remove the entire breast, then that's going to be your last line. We're trying to conserve as much breast as we can. And we also always want to make sure that we always get the lymph node, the axillary lymph node, because that's going to tell us whether the cancer is invasive or whether it's metastasized. So always keep that in mind. So we discussed that's breast cancer. Why don't we go into our next topic, which is going to be our cervical carcinoma. So cervical carcinoma, what happens is that the cells invade the basement membrane. So they go beyond the basement membrane of the cervix, right? And usually with these patients, what are some of the risk factors? By far, the biggest risk factor is going to be any exposure to HPV. So do they have a history of human papillomavirus? That's one of the biggest exposures for these patients. Another one's having early sexual relations, so right, having sex early, multiple sexual partners, immunosuppression, smoking, low socioeconomic status, not following up with your pap smears, right? So how is this patient going to present? Postcoital bleeding is one of the big ones. Vaginal bleeding and discharge, and painful sexual intercourse, or dysmenorrhea. So diagnostics, you're going to see the abnormal cytology. They're going to be HPV positive, right? You can even see like a gross lesion whenever you're doing your cervical exam. So the treatment's going to be depending on the stage. If it's stage 1, it's usually conservative treatment. We can do simple or radical hysterectomy. If it's stage 2 and above, usually these patients need chemo and radiation. So the next one's going to be your cervical dysplasia. This one's a transient dysplasia, right? It's an abnormality in the types of cells in the cervix, and they tend to go away in 2 years. There's different types, right? Usually the most common and carcinogenic, like the worst one, is going to be HPV type 16 and 18, right? And usually type 18 is usually associated with adenocarcinoma. Well, so in regards to cancers, we have, for cervical cancer, right, we have squamous cell carcinoma and adenocarcinoma. By far, the most common type of cancer for cervical cancer is going to be your squamous cell carcinoma. So that's another thing that you need to know. So with cervical cancer, with cervical dysplasia, right, usually what happens is that they have a human papilloma infection that just causes this dysplasia, and it can lead into cancer. And then on top of that, they have all these risk factors, like they're smokers, they're immunosuppressed, they have HIV, right? And some of the risk factors, like we discussed, old age, African Americans and Hispanics are more prone to getting your cervical dysplasia. Another thing is low socioeconomic status. Why? Because they're not following up with their primary care doctors for those pap smears and HPV testing. Also, if they have increased number of sexual partners, right? Having sex early, like we discussed, smoking is a big one. Long-term contraception use is also a risk factor. And so what's going to be the diagnostic? We're going to do, usually with these patients, a colposcopy, which is going to be the best diagnostic procedure. That's going to tell us whether the, it's going to help us evaluate the abnormal tissue in the cervix, right? And it's going to help us stage it or look at the lesion, detect the lesion in case it might be cancer or not. So with these patients, what's going to be the treatment for cervical dysplasia? So it really depends on conization, right? Whether you need to do conization or not, like do you need to do a LEEP or cold knife? And that's just going to depend, right? So is there positive endocervical curettage? Does a pap smear tell you that there's adenocarcinoma in situ, right? Is there any type of discrepancy between the pap smear and the biopsy? So these would be some of the indications for conization for these patients. Next cancer we're going to be going into is going to be your endometrial cancer. So endometrial cancer, it's the most common gynecological malignancy. The mean age is between 63. Usually the majority of these patients are going to be older than the age of 50. And there's a lot of risk factors that can predispose a patient, a woman, for getting endometrial cancer. So some of the risk factors would be hypertension, obesity, nulliparity, which is mean a woman that has not had children. Having children is protective, as you can tell, against a lot of cancers like your breast cancer, in this case endometrial cancer. Why? Because you are having a disruption in the amount of periods that you're having, so those hormones that are being released. So in addition to that, other risk factors are diabetes, abnormal uterine bleeding. Also in a woman that's older, right, especially your postmenopausal woman, that's why we want to avoid estrogen use, unopposed estrogen use, because we keep discussing over and over again what happens is it starts making that endometrium grow, so that layer starts growing, but there's nothing that's coming in like progesterone to ensure that that endometrium gets lopped off or is equal or doesn't overgrow too much. So that's why we avoid hormones in general by themselves in women over the age of 40, or just postmenopausal women, right, over the age of 50, because they have that unopposed estrogen growth, which is going to make that endometrium abnormal, atypical, and very prone to becoming cancerous. Also, if a patient has a history of early menarche, late menopause, history of infertility, some of the medications that are also associated with endometrial cancer is going to be tamoxifen use also. If a patient has chronic anovulation like polycystic ovarian syndrome, and then a most common site of metastasis is going to be your lungs. So how is this patient going to present? So they're going to present with abnormal uterine bleeding. So it's going to be heavy or prolonged menses. Once again, this is going to be usually in your patients that are older, that are postmenopausal. So a woman, after they've gotten menopause, if they start bleeding, especially like large amounts and abnormal amounts, that's abnormal. If it's a few spotting here and there, that's fine, but we still want to investigate further. But if it's abnormal, heavy bleeding, then that's one of the red flags. Most of these women are going to be peri or postmenopausal, like we discussed. The patient's going to be complaining of bloating, early satiety, changes in bladder or bowel function. They can also present with abdominal, normal, abnormal vaginal discharge, lower abdominal discomfort, and some of the signs is you're going to see the enlargement of the uterus. So how are we going to diagnose these patients? We're going to do a sonogram. We can also do an endometrial biopsy. We only do this if the patient, of course, is symptomatic or has risk factors like we discussed, right? Another thing that we can do is a chest x-ray. It's going to help us check for metastasis. And how is this patient going to be treated? So if a patient has hyperplasia, so we've done the endometrial biopsy, right? And they have hyperplasia without atypia that we see, Usually these patients will refer them to OB-GYN. We can give them oral progesterone just to make sure that they slough off that growth. And we can also do a hysterectomy if needed. But usually the treatment is going to be depending on what stage the patient's in. So if a patient is in stage 1A, which is where the tumor invades less than half of the myometrium or endometrium, the treatment for these patients is going to be usually surgical resection only. So we can do a total hysterectomy, so getting rid of that uterus, with bilateral salpingo oophorectomy with pelvic and para-aortic lymph node dissection. So getting rid of the uterus and getting rid of both of the ovaries, and also ensuring that we get some of the lymph nodes to see if it's been metastasized. If it is stage 1B, this means that the tumor has invaded more than half of the myometrium, and this is usually surgery and radiation for these patients. If it's stage 2, which involves the tumor invading the stromal connective tissues, but it's only confined in the uterus, so it just stays to the uterus and hasn't gone anywhere else, these patients get surgery and radiation. If the tumor involves the vagina, the adnexa, and the patient has positive regional lymph nodes, then the patient gets surgery, chemotherapy, and radiation. And if the tumor involves a bladder mucosa with distant metastasis, this patient also gets surgery, chemotherapy, and radiation. So that's why it's really important that we catch these early before they start metastasizing outside of the uterine cavity, right? The next one's going to be ovarian neoplasms. So the most common type of ovarian neoplasm is going to be your epithelial cancer. This is something that they really like to ask. Remember how we were discussing the different types of cancers? We said squamous cell carcinoma is going to be the most common type of cervical cancer. For ovarian neoplasms, it's going to be your epithelial cancer. This is going to be the most common type. So this is very commonly found in both postmenopausal and premenopausal women with these patients. But in postmenopausal women, they're more likely to be malignant with your ovarian neoplasms versus premenopausal women, like your younger patients that come in with ovarian cysts, they're more likely to be benign. So some of the risk factors for a patient to develop ovarian neoplasms is going to be nulliparity, white race, so Caucasians, early menarche, and late menopause once again. Why? Because like we said, you have more ovulation cycles, you get more periods. Also, if the patient has a family history, if the patient has the inherited mutation of BRCA1 and or 2, or even Lynch syndrome, they're very prone to getting ovarian cancer. So just in general for ovarian cancer, how is the patient going to present? So they'll have signs of ascites. That's one of the big ones associated with ovarian neoplasms. They'll have bloating, so abdominal distension, change in their bowel habits, evidence of abdominal or distant metastasis. And some of the signs is if they're older than 50, right, and we were thinking about something that is malignant, then usually we'll see a nodular or fixed solid pelvic mass. It's also associated with your sister Mary Joseph nodules, which are the metastatic implant in the umbilicus. And how are we going to diagnose these patients? So first what we're going to do is we're going to do an ultrasound, right? We're going to see the blood flow within the mass. We're also going to measure an alpha-fetoprotein, a beta-HCG, and then an LDH for these patients, especially if they're younger than the age of 30. If they're between 30 to 35, we want to do the tumor markers for CA125, right? Especially if the patient has a family history of someone in their family having ovarian cancer. If the patient's older than 50, you're going to do CA125 and CA199. So this is once again those tumor markers that we get for these patients. What's going to be the treatment for these patients? So it's really going to depend on what is the size of the neoplasm. Is it just a regular cyst, or is it like a complex solid cyst, and how old is the patient? So if it's a simple cyst, we usually treat it based on how big the cyst is and how is the patient presenting with symptoms. So if a patient is premenopausal, usually the most common cyst that you're going to see is going to be your functional cyst, right? So usually with these patients, no treatment. You can repeat a transvaginal ultrasound in 6 to 8 weeks, especially if the patient is like symptomatic, or if the symptoms are persistent, or if that cyst is really large. But usually observation with these patients, we don't need to remove it. Now, if the patient's postmenopausal, in these patients, we're going to check a CA125 and then repeat that transvaginal ultrasound for these patients, right? We want to make sure that there's a normal CA125 and then that tumor is not growing. If it is, then of course we're going to remove it. If it's a complex cyst and the patient's premenopausal, we're going to remove him, especially if it's symptomatic or persistent. In postmenopausal, for complex cysts, we always remove him. If it's a solid cyst, premenopausal, we'll remove him. Postmenopausal, we're going to remove him, and then we would also consider chemotherapy because it's most likely to be malignant in these patients. Like I said, they're postmenopausal. So the next one's going to be vaginal neoplasm. So the most common type of cancer for vaginal neoplasm is going to be your squamous cell cancer. So squamous cell cancer is the most common type of cancer in what? Cervical cancer, vaginal cancer also, and then epithelial cancer, we're talking about ovarian cancers, right? So with vaginal neoplasms, the majority of them are usually due to metastasis. So it's either a cervical tumor, a tumor from the uterus, a tumor from the rectum, or a bladder that has metastasized to the vagina. And the mnemonic for this one's going to be your curb. So curb, C is going to be cervix, U is going to be your uterus, R is going to be your rectum, and then B is going to be your bladder. And usually the most common location is going to be the upper 1/3 of the vagina, behind the cervix. And some of the risk factors, by far the biggest one's going to be smoking is a huge risk factor for this one. If the patient has a history of HPV, especially your bad strains 16 and 18, right? So in addition to that, do they have any history of CIN, which is your cervical cancer in situ, right? Do they have a history of radiation or DEX exposure? And also, did they have sex at an early age? So early sexual relations. So how's this patient going to present? Usually they're going to be asymptomatic. If they do have symptoms, they're going to be presenting with vaginal bleeding, usually after menopause, and then after they have sex. They're going to have a watery blood tinged malodorous discharge, vaginal mass. They're going to have urinary symptoms like frequency, urgency, dysuria, hematuria. They're going to have constipation, melena. And what are we going to see on our physical exam? So with their speculum, we might feel a palpable mass on the posterior wall of the upper vagina. You'll see ulcerative lesions, blood, and malodorous discharge in the vaginal wall also. So what is going to be some of the diagnostic steps that we're going to do for these patients? We can do a lutein solution. What happens is that once you apply this on the area, it's going to turn any area that's abnormal black. And then we can do a punch biopsy. This is going to tell us that the patient has squamous cell carcinoma, right, which is going to be the most common type of cancer for vaginal cancers. We can do a colposcopy also. And treatment for this, usually it's going to be radiation and surgery. We can do laser ablation. And the thing about this one, right, to tell the difference between vaginal cancer is that if it extends into the cervix or the vulva, it's not a vaginal cancer, okay? The next one's going to be your vulvar neoplasia or vulvar cancer. Once again, the most common type are going to be what? Squamous cell cancer. So squamous cell cancer is going to be the most common type you're going to see. And the thing about vulvar cancers is that usually they come from chronic irritation from lichen sclerosis. And with these patients, the mean age is 65, so the patient's going to be older. So some of the risk factors is going to be the age, of course. So as the patient gets older, they're more prone to getting vulvar neoplasia. Once again, your HPV infection, so do they have a history of HPV, specifically your 16 and 18 types? Smoking, do they have any other history of invasive genital tract malignancy, any of your cervical cancers, right? Immunosuppression like HIV, lupus, and also lichen sclerosis are some of the risk factors for vulvar cancer. So usually the patient's going to have a history of lichen sclerosis, since we said there's a huge relationship between lichen sclerosis and vulvar neoplasia. They're going to have that itching of the vulva. You'll see lesions on the vulva visibly on your physical exam. And you'll also see enlarged groin nodes. The diagnosis for these patients is going to be a biopsy, right, with these patients. And if you do a vulvoscopy, you'll see acetowhite lesions. Treatment for this is just getting rid of the vulva, so that radical vulvectomy, and then ensuring that we get those nodes, so groin node dissection. If the patient is very high risk, then we're going to do chemoradiation with these patients. Next one's going to be lichen simplex chronicus. This is not cancerous. What happens with these patients, it's due to chronic scratching and rubbing. So the patient's chronically scratching and rubbing that area, because that vaginal area. Why? Because it's just really itchy. So what happens is that you start damaging that skin and you lose that protective barrier that you had. So it's usually going to be that itch scratch cycle. So it's very itchy. They're scratching it and they're just destroying that protective barrier. So this makes the vaginal area more prone to infection. So this patient's going to have that vulva that's very itchy, severe vulvar itching, especially at night. It's going to be worse. And on your physical exam, you're going to see a thick, lichenified and large rugose labia with or without edema that's either localized or generalized. And then, of course, we're going to do a biopsy on these patients. And treatment for this is just high-potency topical steroids and antihistamines. So you can do a vulvar biopsy just to make sure you rule out anything that might be malignant for these patients. So the next one's going to be lichen sclerosis. So lichen sclerosis can involve a lot of areas. So it can involve the scalp, the nails, the oral mucosa membranes, and even the vulva. What happens is that you get a mucocutaneous eruption with remissions and flares, and the patient is going to have symptoms of the vulva of irritation, burning, itching, contact bleeding, pain, and painful sexual intercourse, also known as your dysmenorrhea. The key to this one is how it's going to present on your physical exam. So you're going to see that lacy reticulated pattern of the labia and perineum, right, with these patients. The skin is going to appear thin, inelastic, and white with a crinkled paper appearance. And that's the key, right? And that's how it is on the question stem. It's going to be that crinkled tissue paper appearance. And with these patients, treatment is usually just giving them very potent corticosteroids. The next one's going to be your vulvar vestibulitis syndrome. What happens with these patients is that they have very severe pain on vestibular touch or attempted vaginal entry. So they have very tender, the vaginal area, their vulvar area is just very tender to pressure, and sometimes they can just present with erythema also. So usually with these patients, you're going to have pain with tampon insertion, biking, wearing tight pants, anything that's rubbing in the area, anything that's penetrating the vaginal area. A lot of these patients avoid sexual intercourse because they just have a lot of pain, so they'll be complaining of the introitoidal dyspareunia. On physical exam, you're going to see that the patient has the area that is going to be very tender, right? You might also see diffuse erythematous macules or even focal erythematous macules. And just for these patients, the treatment is going to be your tricyclic antidepressants, which is going to help with that pain, pelvic floor rehabilitation. So the next one and the next topics that we want to go over is going to be the disorders of the breast. So this involves both benign and malignant. So let's start with breast cancer. So breast cancer, one of the risk factors associated with breast cancer is going to be how old is the patient, female, right? Sex, more commonly found in females. What is the family history, first degree relative? Do they have the gene mutations of BRCA1 or BRCA2, right? Nulliparity, early menarche, late menopause. You can see this is very repetitive, right? Early menarche, late menopause. Do they have also radiation exposure? Do they have an advanced maternal age whenever they had their first baby? So with these patients, you're going to be presenting with a single non-tender, firm, immobile mass, usually in the upper outer quadrant. And it's more commonly to find it in the upper outer quadrant, although you can also see it under the nipple and areola. But usually the complaint's going to be in that upper quadrant area of the breast. On your signs, what you'll see is that you might see early changes that appear with mammographic changes, but usually no palpable masses. This is usually early signs, but your rare signs are the ones that we see a lot in textbooks, right? Which is going to be that nipple retraction, that pudor-orange, which looks like an orange, so that dimpling of the breast. You're going to see eczematous changes, also breast pain. You'll see a fixed mass, axillary lymph node enlargement, also ulcerations. You're going to see edema, especially if the breast cancer has gone into the lymph nodes. You'll have palpable supraclavicular lymph nodes also, nipple discharge. And whenever we think about nipple discharge, if it's unilateral, we're thinking more of a malignant cause versus bilateral. So if it's bilateral, not as malignant as if it was only unilateral. And also, what's the consistency of the nipple discharge? So with these patients, how are we going to diagnose them, right? Usually we'll do a fine needle aspiration, especially if we have a very high suspicion on our breast exam that this is malignant. So we'll do a fine needle aspiration, or we can even do an excisional biopsy, right? And then, of course, any patient that has a strong family history of breast cancer, just to make sure we do the genetic testing. So Another thing with these, right, whenever the patient gets a final aspiration, we also want to make sure that we get sentinel lymph node biopsy. We want to biopsy that lymph node just to make sure that it's not metastasized. Treatment for these patients, so usually it depends on the type of cancer, because once again, for breast cancer, there's a lot of cancers. We have some cancers that are receptive to estrogen, right? The ER positive estrogens or your HER2 positive. So for example, in a patient that has a cancer that is receptive, your estrogen receptor positive disease, right? Then in these patients, we can give them tamoxifen, right? And then of course, in regards to surgery, always go over breast conservation. So you always want to make sure that you save as much breast as you can. So you can do something like a lumpectomy. So ensure that you get rid of the lump, and then always make sure that you do that sentinel lymph node biopsy with these patients. So once again, in your question send, the answer is always going to be trying to preserve as much breast as you can. So you're not going to go rogue and remove the entire breast. No, start with a lumpectomy, partial breast mastectomy, and then if needed, the entire breast. But always, always, no matter if it's a lumpectomy or how small you go, always, always gonna get that lymph node biopsy also. And another thing with this one is that breast cancer is associated with a lot of other cancers. And if a patient has breast cancer, they have a very high risk of getting other cancers like endometrial cancer. And then of course, the opposite can be said also. If a patient has endometrial cancer, they're very prone to getting breast cancer. So the next is going to be your Paget's disease of the breast. This one's not a very common disorder, but it's one that's very likely tested. What happens is that this is a ductal cancer that presents as an eczematous lesion of the nipple. Once again, eczematous lesion of the nipple. So what are you going to see on your physical exam? You're going to see an eczematous eruption and ulceration that is arising from where? From the nipple, and it's spreading to the areola. This one's going to be very painful, itching, burning. The patient can have superficial erosion or ulceration. They're going to have bloody discharge or nipple retraction. Some of the signs that you're going to see is going to be a very scaling, crusting, and itching erosion, right? You can also feel a palpable mass with these patients. So what's going to be the diagnostics? We're going to do a full thickness biopsy, right? We want to make sure that we do a full thickness biopsy because we're looking for either adenocarcinoma cells or Paget cells that are within the epidermis of the nipple. And treatment for this is just wide local excision, right? Once again, we're going to try to conserve as much breast as we can, especially if they have negative margins. But the majority of these are high grade when we do find them. So the key for this one for Paget's disease is just going to be how it's going to present on physical exam. So this is the one that's going to have that pain, itching, burning. It's going to be an eczematous eruption and ulceration, and it's going to come from the nipple. And that's usually what kind of differentiates from other breast cancers and benign breast tumors, is that this one's very scaly, very, very itchy. It just looks really ugly. Next one's going to be your breast fibroadenoma. So this is a very benign breast disorder. Benign breast disorder, benign breast mass. Usually they go back and forth in regards to, they recommend women in general to do their own breast exams because sometimes it can cause a lot of anxiety. But I've been listening to podcasts where they go back and forth, where they do recommend them and they don't recommend them, like a self-breast exam. Of course, following up with your doctor, that's something else that is recommended every year, right? But like your own self-breast exam, it's very, very controversial. But this is one of the ones that a lot of younger women will feel, and they freak out because they feel mass. So fibroadenoma, very commonly found in your young patients, very commonly found in African American women. And the thing about this one, and how are you going to differentiate this from bad cancer like breast cancer and from your other ones like fibrocystic disease, is that this one's going to be a single one. It's going to be a single mass. This one's going to be round, firm, and it's usually very rubbery. So it's soft and rubbery. It's usually bouncy, also painless. It's really movable. It's also called like the mouse because you move it and it's able to move, very freely movable with this one. Versus cancer, right? Cancer is fixed. It's not movable. It's sometimes abnormal when you feel it. This one's just going to be round, very movable, very, very bouncy. It's going to be non-tender, and this one responds to hormones. So it'll grow in size sometimes even during pregnancy because it's very responsive to hormones. And usually it tends to go away in postmenopausal women. Why? Because postmenopausal women are not producing hormones anymore. And that's something that they really like to test. This one is responsive to hormones. So once again, postmenopausal women, you're not going to have it. I had a question once that asked, what are you going to educate this patient in regards to fibroadenomas, and just educate them that they should expect for them to go away once they become postmenopausal or once they hit menopause. So with these patients, what are you going to do? So just to ensure that it's not anything malignant, we're going to do this type of radiologic testing depending on how old the patient is. And this is a key for these. This is a key for fibrocystic disease, breast fibroadenomas. If the patient is less than 30 years old, so they're younger than 30 years old, you're going to do an ultrasound. Okay? You can also do a fine needle aspiration if needed, but usually ultrasound. Why? Because they don't have a lot of breast tissue. Versus a woman that's older than the age of 30, they have more breast tissue. So if you find any of these women get a mammogram, right? And then these women will get an excisional biopsy if needed, especially if they're BRCA positive, right? BRCA 1 or 2 positive, or if they have a strong family history. So once again, less than 30 ultrasound, greater than 30 mammogram. Make sure you know that. They really like to test that. So when you're reading the question stem, look for the number and the age of the patient. So usually with these patients, in regards to treatment for fibroadenoma, it's just really just educating the patient. They can take over-the-counter NSAIDs, right? And things like decreasing caffeine intake is really going to help with the pain. Okay, let's go into our next topic, which is going to be fibrocystic disease. This is actually going to be the most common one out of your benign breast disorders. So out of both breast fibroadenoma and fibrocystic disease, this one's going to be more common. And it's more commonly found in women between the ages of 30 to 50. With these patients, they're going to present with either asymptomatic or painful masses, and these are going to be bilateral. Versus fibroadenoma, it's going to be unilateral, right? Fibroadenoma is unilateral. Fibrocystic disease is going to be bilateral. And once again, this one also responds to hormones, so the size can fluctuate during the patient's menses. Another thing that distinguishes this one from cancer and from your fibroadenoma is that they're going to be multiple. Versus fibroadenoma, it's one. Breast cancer, it's one. These are going to be multiple, right? This patient is going to be presenting with breast pain. They can also have nipple discharge. Sometimes these masses are lumpy and bumpy, especially before the patient gets their menses. And on your physical exam, you're going to see that these are going to be very tender, and they're going to be bilateral. They're going to be very mobile. The patient may have discharge, right? And if it is, it's usually a thick gray-green nipple discharge, and the pain and the symptoms are usually worse whenever the patient takes caffeine. So once again, diagnosis for this, we can do an ultrasound with or without biopsy, fine needle aspiration, and then once again, it's going to depend on the patient's age. Are they less than 30? Ultrasound, greater than 30, mammogram. Treatment for these patients is going to be supportive, right? Once again, giving them medications like NSAIDs, tell them to decrease their intake of caffeine, tell them to wear supportive bras. And with these patients, I had a patient that had fibrocystic disease, and she was really young, and she had been having them for a very long time, and she already had all the babies that she wanted, and she just wanted to remove them because it was just so painful. And there's women that it's just very painful and they can't live with this. So once again, fibrocystic disease, bilateral, multiple. Fibroadenoma, single. So next one's going to be mastitis. Mastitis, you definitely need to know this one. You're definitely going to get a question on this one, I can guarantee you. So mastitis is very commonly found in your postpartum women. So women that just had baby, right? And the most common pathogens that is associated with mastitis is going to be Staphylococcus aureus, so Staph aureus. Why? Because Staph aureus is found all over our skin. So it makes sense why Staph aureus is going to be very commonly found. And this is very commonly found in your women that are breastfeeding, right? This patient is going to be presenting with fever, chills. They'll have flu-like symptoms, and the onset is usually acute. So usually with these patients, we'll give them antibiotics. On your physical exam, you're going to see very red, tender breast. There's going to be a firm mass. They're going to have breast pain, and usually it's going to be unilateral, right, with these patients. And it's going to be warm whenever you touch it also. So with these patients, Usually it is a diagnosis that is done in the clinic, so it's a clinical diagnosis. You can culture the material, right? Just if you suspect it's another bacteria, but the most common bacteria involved is going to be Staphylococcus aureus, right? Treatment for these patients is usually with dicloxacillin, right? Dicloxacillin, 250 to 500 milligrams every 6 hours for 7 to 14 days. If the patient's allergic to dicloxacillin, then you can do something like erythromycin. The thing about this one is that the woman can still breastfeed. So the woman can still breastfeed. So it's important that you educate the patient to continue to breastfeed and express milk, right? That's one of the things that they really like to test. So make sure that you know that, like, the patient's going to ask you, is it okay if they can breastfeed? Yes. With mastitis, it's okay to breastfeed, right? It might even help with it. And so what happens with mastitis is that you have that baby, right? They're latched on, they're breastfeeding, and so that trauma that they're having to the nipple is just causing trauma to the breast, and you have a lot of staph aureus everywhere, and so you get that area inoculated. So once again, mastitis, right, is just an inflammation of the breast, versus like a breast abscess. On the question stem, it has to say fluctuant. If it doesn't say fluctuant, then it is not it is not a breast abscess. So that's how you differentiate between these two, because I know I had a hard time differentiating between mastitis and breast abscess on your question stems. If you keep that in mind, and if you look for that in the question stems, you're going to do well. So once again, breast abscess is going to be fluctuant, mastitis is not. So going into breast abscess, once again, this is very commonly found in those women that are nursing their babies. The most common bacteria is going to be what? Staph aureus. And in this patient, you're going to see redness, tenderness, indurations, and then sometimes it'll say it's fluctuant, like I said, with these patients. And usually with these patients, it's going to be a clinical diagnosis, right? And the treatment's going to be usually with Bactrim, versus your mastitis, it's dicloxacillin. Bactrim is going to be their treatment for breast abscess, right? So the next one we're going to go into is going to be just structural abnormalities. So let's go into cystocele, which is going to be your bladder prolapse. What happens with these patients is that there's an anterior vaginal prolapse of the posterior bladder wall into the vagina with these patients. And this is very commonly found in any type of woman that has had multiple births, right? Because they get an injury to the pelvic floor during childbirth. So usually some of the risk factors is going to be pregnancy, especially if they had multiple pregnancy, vaginal delivery, right? If they're older, if they're obese, menopause, diabetics. And this one's more common than your rectoceles. So what are you going to see on your physical exam? You're going to see a vaginal bulge or fullness. The patient's going to be presenting with pressure and heaviness. They're going to say they feel like they're sitting on a ball, or they feel like something's falling out. It's going to be worse with Valsalva, and it's going to be better whenever they're in a recumbent position. With these patients, also they're going to have urinary incontinence. So if you can see, a lot of these patients have a lot of urinary symptoms, which makes sense, right? Because it's going to be what? Bladder prolapse. So they're going to be complaining of urinary incontinence. They'll have retention or straining to void. They'll have frequency, urgency, and retention. So it's going to be a lot of urinary symptoms in comparison to your rectocele and in comparison to your uterine prolapse. So that's kind of how you can differentiate this one. Because I know when I was studying for the exam and I was doing practice questions, these were the ones that I missed a lot. Your cystocele, your overuterine prolapse, your rectocele. And just knowing that cystocele is a prolapse of the bladder, you're going to have a lot of urinary symptoms. So with these patients on exam, right, you're going to tell them to do a Valsalva or cough, and you're going to do a pelvic exam, right? You're going to examine them in the lithotomy and standing position. Diagnostics, you can do the POPQ, which is going to be your pelvic organ prolapse quantification. This is going to tell you what is the extent of the bladder prolapse and are there any defects and where. You can also do an ultrasound, and you can also do the the Q-tip test. Also, you can do your cystourethrogram if needed, avoiding cystourethrogram. And treatment for these patients, well, the first thing that we want to do, right, is always prophylaxis. And that's always the answer. Remember how we discussed for PANS, they really like to do supportive before you start going into more invasive treatments. So usually with these patients, Kegel exercise, it's going to help strengthen that levator ani muscle and perineal muscles. Also, you can give them something like estrogen therapy. And Episari is also another good one for these patients. And last line, like say that they've tried everything. They've done the Kegel exercise. you've given them that estrogen therapy, right? You've given them a pessary and the patient is still not getting better, then you can do something like an anterior vaginal colpography, right? It's going to be what? Anterior vaginal colpography, because if you think about the anatomy, right, bladder is going to be anterior in regards to your rectum, anterior vaginal colpography. That's another thing that I really got messed up on in regards to the treatment. So if you just think about your anatomy, you'll get this right. So once again, anterior colpography, vaginal colpography, and that's only going to be in a patient that is just having really bad symptoms, like they can't go on with life, it's affecting their daily life, and or a patient that has failed everything else that you've tried first. But once again, first one is going to be your Kegel exercises, strengthening that levator ani muscle and your perineal muscles. And then after that, you can do pessary or estrogen therapy, right? And then go into surgery. So the next one's going to be ovarian torsion. This was very commonly associated with your ovarian cysts or any type of neoplasm that is located on the ovary, which makes sense, right? If you have a lot of weight on one ovary, it's very prone to twisting on itself. And with these patients, what happens? So if you think about the ovaries, you have those blood vessels that are going to the ovaries, you have arteries in your veins, and what happens is that ovary twists on itself. And if it twists on itself, right, how you think about it, if you go over a rubber band and you tied it really, really, really hard on your finger, it's going to decrease blood flow, right? And if you leave it there for a long time, you can lose that finger. Same thing with your ovaries. So it twists on itself and decreases blood flow to that ovary. So with these patients, they can lose their ovaries. So it's really important that we diagnose these patients quickly and we treat them quickly. So this patient is going to present you with that sudden onset of unilateral lower quadrant pain, nausea, and they're going to be very tender to palpation. They're going to have that guarding, right, on your physical exam. So what are we going to do for these patients? We're going to do a CBC. You'll see leukocytosis. Make sure that the patient's not pregnant, so rule out things like an ectopic pregnancy, so you can do a beta HCG. But the best one, of course, is going to be your ultrasound, right? Doppler ultrasound. And that's where you're going to check the blood flow to the ovaries. So with these patients, if there is no blood flow to the ovaries, then you're thinking about ovarian torsion. And treatment for these patients, go to surgery, right? Rapid surgical exploration. I can guarantee you're going to get a question on this one for this EOR. So it's really important that you know it, because it's really important just in general that you know how to pick these up, because a patient can lose their ovary. Just like men have testicular torsion, in women it's ovarian torsion. And it's very commonly going to be found in a woman, once again, that has a cyst, multiple cysts, or some type of neoplasm that is just creating a lot of force, making that ovary heavy, more likely to twist on itself, on its pedicle, constricting blood flow. So that's why you're going to do an ultrasound, look at that blood flow, and surgery for these patients. So the next one with these patients for this EOR is going to be rectocele. So rectocele is going to be a prolapse of the posterior vaginal wall and rectum, right? So it's the posterior versus cystocele was the anterior vaginal prolapse. This one's going to be a posterior vaginal prolapse. And what happens is you're going to see the contents protrude into the vagina. And once again, this one's associated with childbirth. You have some type of injury to the pelvic floor when a patient's giving birth. So usually with these patients, you're going to have a history of, for example, also even using laxatives. So they've been using laxatives for a very long time, or enemas. So they're going to have intraoidal bulging that's worse whenever they stand. And once again, these patients are going to have symptoms that are GI related, versus when we're talking about your cystocele, they're having urinary symptoms. With rectocele, they're going to have symptoms related to the GI. So they can have fecal incontinence, so loose of stool and flatus. They're going to have incomplete rectal evacuation, constipation, low back pain, because if we think about the anatomy, right, the rectum is located in the posterior area. Dysmenorrhea, which is painful sexual intercourse. And some of the signs for these patients that we can do is we can do the left decubitus position for detection, and usually it's going to be worse with Valsalva. Once again, diagnostics, we're going to do the pelvic organ prolapse quantification. We can do a lot of tests like anal manometry, transanal ultrasound, a lot of things, but usually these are clinical diagnoses. And once again, treatment for these patients, usually we try to do non-surgical, right? We try to avoid surgery. And once again, surgery is going to be last line for these patients. So we're going to use any type of medication that's going to slow the transit time. So bulking agents, laxatives, stool softeners, right, for these patients, because a lot of these patients complain of constipation. So you want to make sure that the patient is just not putting more pressure on that weak pelvic floor. If the patient has tried everything and they are still complaining of this and it's not compatible with their life, right? It's affecting their daily life. This is where we are going to do surgery. And what's the surgery? Posterior colpography, which is going to be repair of the posterior fascial defect. So once again, anterior colpography, we're thinking about cystoceles. Posterior colpography, we're thinking about your rectocele. So the next one's going to be uterine prolapse. So uterine prolapse is going to be loss of the normal ligamentous support of the uterus. So you have the uterus, and if we learned about anatomy, you have a lot of ligaments that are holding that uterus in place, right? And what happens with time, as a woman gets older, as a woman has a lot of babies, right? You're getting trauma once again to that pelvic floor. You start losing support from these ligaments that are supporting that uterus. So risk factors: older women that have had multiple babies, any condition that also increases that pressure in your abdominal area, obesity, constipation, right? If the patient's repetitively lifting, right, they're putting pressure on that abdominal area. So how is this patient going to present? Vaginal fullness or mass. And usually the symptoms are going to be worse after prolonged standing or usually later in the day. And usually they get better whenever the patient lays down. So another symptom that they're going to be presenting is lower abdominal pain, low back pain. They'll have urinary incontinence. Usually in the question stem, you'll see the patient sitting on a ball, right? Or they feel like something's falling out. And what you're going to do with these patients, you're going to do a pelvic exam. You're going to see a soft, reducible mass. Once again, diagnosis is going to be your POPQ test, and there's a lot of other additional tests that you can do. Treatment for this is going to be conservative. Once again, that's the first line, right? Your Kegel exercise or the first line, always, always, always. And then you can go into a vaginal pessary. And once again, your definitive, especially for your older patients that are not sexually active, you can do something like a vaginal hysterectomy. So going in there and getting rid of the uterus with sacrospinous ligament suspension. So once again, right, what's going to be the treatment is going to be your Kegel exercises or first line vaginal pessary, and then your vaginal hysterectomy if needed. All right, guys, so let's go into our contraceptives. It's going to be the next topic. You definitely need to know these because this is something that's very highly tested. You're going to get a lot of questions, especially for this OB-GYN exam. So it's really important that you familiarize yourselves with the contraceptives. Who are they appropriate for? What patient populations are they appropriate for, etc. That way you can choose the correct contraceptive for your patient. So in general, what do oral contraceptives do, right? So what they do is that they inhibit the ovulation. And how do they do this? They suppress that hypothalamic gonadotropin releasing factors. So what happens when they're suppressing that is that it prevents the pituitary secretion of the follicle stimulating hormone, so FSH, luteinizing hormones, and estrogens are going to suppress that FSH release. They're going to stabilize that endometrium, and they're going to prevent menorrhagia, so heavy bleeding. And this is why these oral contraceptives are very useful, like we discussed, in patients that have like menorrhagia, so your heavy bleeding. Now, what do progestins do? They inhibit ovulation by suppressing the luteinizing hormone, right? They're going to thick that cervical mucus, and they're going to make that endometrium environment not favorable for an egg coming in there and implanting. So usually with oral contraceptives, they're taking 3 out of every 4 weeks, right, within a month, and you take them daily. So out of the 3 weeks, you take them every day, and then you have that 4th week, and then after that, you start them again. So usually you take them every day. And what are some of the contraindications? So what patients are not candidates for oral contraceptives? And this is the things that you're going to look for in the question stem. Definitely if they're pregnant, right? Are they hypertensive? Smokers is a big one that they really like to test. So smokers older than the age of 35 years old, smokers older than the age of 35 years old, smokers older than the age of 35 years old are going to be contraindications for your oral contraceptives. Does the patient have diabetes, especially vascular involvement? Do they have any type of history of having coronary artery disease, strokes, right? Any type of disorder that makes them more prone to clotting, because just oral contraceptives in general make a patient more prone to clotting. Another one that they really like to test is going to be migraines with aura. So does the patient suffer with for migraines with aura? Do they have known or suspected breast cancer, right? Do they have any problems with their liver? Like, do they have cholestatic jaundice? Do they have hepatic adenomas? Why? Because just in general, oral contraceptive is very prone to causing hepatic adenomas. So if you already have one, it can exacerbate it even more. So definitely what you need to know for these is that they're going to be contraindicated in migraines with aura, smokers older than the age of 35, and any patient that is very prone to getting coagulation. So do they have a history of multiple DVTs? Do they have a history of strokes, cardiovascular disease, coronary artery disease? These are the patients that they are contraindicated in, and this is what you need to know because it's very highly tested. So with these patients, some of the adverse effects of oral contraceptives is just going to be that the patient's going to be complaining of breast tenderness, weight gain, myth, maybe not myth. I mean, I've heard podcasts where they go back and forth in regards to whether a weight gain is a true side effect of oral contraceptives. But of course, patients are going to be complaining of weight gain, breast tenderness, breakthrough bleeding is another one. Why patients don't like, and women in general don't like taking this, is because they get breakthrough bleeding. And then once again, it really increases the risk of a patient getting any type of cardiovascular disease and also making them more hypercoagulable. And that's why whenever you're studying for your exam, like in regards to your DVTs, you always want to ask, is a patient on oral contraceptives? Because it can make you more prone to coagulating. Why? Because of the hormones that they're getting, right? Certain hormones in general can make you more prone to clotting. So the next one's going to be Yaz, also known as drospirenone. This is going to be an anti-androgenic and anti-mineralocorticoid activity. So what it does is it causes potassium retention. And with these patients, it's usually used for premenstrual dysphoric disorder. So remember when we were discussing premenstrual dysphoric disorder, which is going to be the severe form of premenstrual syndrome. It's also used in premenstrual syndrome and also used in moderate acne vulgaris. And it's contraindicated in any patient that has any kidney problems, adrenal insufficiency, or hepatic problems, so problems with their kidneys. The adverse effect of this one is going to be hyperkalemia. Why? Because, like we said, the mechanism of action is that it retains potassium. The next one's going to be your transdermal patches, right? Your ortho-evra. This one is combined, so it contains both estrogen and progesterone. And like we discussed earlier, right, what does estrogen do? What does progesterone do? Usually with these transdermal patches, the patient's going to put a weekly contraceptive patch that is applied either to the butt, the upper outer arm, the lower abdomen, or the upper torso. And they get a new patch every week for 3 weeks, and then once again that last week it's patch free. So it's similar to oral contraceptives, except that you change that patch every week, and you do that for 3 weeks, and that last week you do not do it. And the thing with this one is that it has a risk of increased venous thromboembolism because it's going to be combined oral contraceptives, right? So anything that's combined that has estrogen and progesterone increases the risk of getting your hypercoagulation. And with these patients, some of the adverse effects is skin reactions, dysmenorrhea, breast tenderness, breakthrough bleeding once again with these patients. So if it's a woman that does not want any medication or oral contraceptive or just contraceptive in general, it's going to cause breakthrough bleeding, then in these patients, we definitely do not do ortho-evra. The next one's going to be NuvaRing. This one contains both also estrogen and progesterone, so it contains both of the hormones. This is going to be a monthly vaginal ring, and the thing with this one is that they need to be refrigerated, right? They can be refrigerated up to 4 months. And they are inserted within 5 days after the onset of menses. They're left in there for 3 weeks, and then they're going to be removed that last week to make sure that the patient bleeds, right? So with these patients, of course, they can remove them whenever they do have sex, but it's really important that they replace them within 3 hours. And some of the adverse effects of this one and why certain patients don't like taking them is because, once again, they have that breakthrough bleeding. And usually with these patients, you know, of course, the woman or the man is going to say that they feel it during intercourse. Your next one is going to be your seasonal, right, which is you're going to be continuous contraceptive hormonals to your oral contraceptives. Usually what happens with these patients is that they get a 3-month preparation of the drug. So they'll get 85 days of active drug and then 7 days of placebo. So they're taking it continuously. And with these patients, some the reason why some patients prefer this one over another one is that just some patients don't like having periods in general. So some of the things that the patient might be complaining of is that they don't have a normal menstrual period, right? Because it's not frequent. And if it is frequent, it's lighter. You're not able to predict it because you're taking that's contraceptives for 3 months, right? The patients are going to be presenting with amenorrhea, like we discussed. But this one does have less headache, fatigue, bloating, painful menstruation compared to like your other contraceptives. So now let's go into progesterone-only products. So these are going to be oral contraceptives that only contain progesterone versus the ones that we discussed that contain both progesterone and estrogen. These only contain progesterone. So let's start with the progesterone-only mini pill, also known as your mini pills. It's really interesting because I was listening to a podcast. I know I keep discussing this, but podcasts are amazing, and that's a way to learn. I was listening to a podcast the other day, and they were discussing the progesterone-only pill, and one of the doctors asked one of the OB-GYNs, is it really a mini pill? And they're actually not. They look like horse pills, apparently. So I thought that was really interesting. It's just called a mini pill because the amount of hormone it contains. So what does progesterone usually do? So like we discussed, it inhibits ovulation because it suppresses your luteinizing hormone, right? Because whenever we think about just the menstruation, right, you have that luteinizing hormone surge, and it suppresses the luteinizing hormone so you don't get that surge. It also thickens the cervical mucus, and it makes that endometrium environment very unfavorable to implantation. So with these patients, who are they indicated for? So it's very good for any woman that has a history of thrombosis or migraine headaches or smokers that are older than 35. So remember how I kept repeating that over and over again, that that's a contraindication for combined oral contraceptives? A patient that is a smoker, they're older than 35, they have migraine headaches, or they have a history of thrombosis, like a history of DVT, progestin pills are very good for these patients. Another one that's very, very commonly tested that I would definitely tell you need to know, wink, wink, hint, hint, is that progesterone-only pills are very suitable for women that are lactating. So if it's a woman that's lactating and they want a form of pregnancy control, then progesterone-only pills are really good for these patients. The thing about these, though, you have to make sure that you are taking them every day at the same time for them to be truly effective. So even if you're like off like a few hours or a few minutes, well, not even a few minutes, a few hours, it's not going to be as effective. And that's the same thing with your oral contraceptives, right? It really depends on the patient. Are they going to be compliant with the medication? Do they like taking pills every day? Some patients don't like taking pills every day. Some patients are just very, very busy. And so maybe they would prefer something like an IUD, like something long-term, right? That they don't have to worry about taking every day, especially those women that just are not wanting to have children anytime soon. Maybe an IUD would be perfect for them. Same thing with progestin. This one, you have to ensure that the patient's taking them daily, right, at the same time, because they can decrease the efficacy if you do not. So with these patients, the contraindications for progestin pills is going to be any patient that has breast cancer, once again, any patient that has any type of hepatic neoplasms, or they have liver problems, if they're pregnant, if they have unexplained uterine bleeding. And with these patients, some of the adverse effects that they might be complaining of is that these patients have a higher incidence of bleeding, amenorrhea, intramenstrual bleeding, so bleeding in between periods, prolonged periods, menorrhagia, and higher pregnancy rates also with this one. But once again, progesterone-only pills, good for your lactating woman with a history of your thrombosis or migraine headaches, or smokers older than the age of 35. All right, guys, so the next progestin-only product we're going to be discussing is going to be your Depo-Provera. So your Depo-Provera is basically a shot. This one contains, once again, only progesterone, and you can give it intramuscular or subcutaneous. Just keep in mind that usually with these medications, intramuscular is better than subcutaneous, just because of absorption. So with these patients, right, how often is this intramuscular injection going to be given? So it's going to be an intramuscular injection that's given every 90 days. It's given within the first 5 days after menses onset, right? And with these medications, it's good for a woman for whom an estrogen-containing contraceptive is contraindicated. So once again, these progestin only, this shot, it's going to be good for any woman that complains of a migraine, right? Some of the contraindications for your dual hormones. So it's going to be good for a woman for whom an estrogen-containing contraceptive is contraindicated. So migraine exacerbations, sickle cell anemia, fibroids also. The thing about this one is that it decreases the risk of ovarian and endometrial cancers. And some of the contraindications going to be any woman with unexplained uterine bleeding, breast cancer, if they have severe liver disease, right? Pregnancy. Once again, do they have a history or do they have active venous thromboembolism? And some of the adverse effects that the patients are going to be complaining is definitely by far the common one's going to be your weight gain, right? And breast tenderness, irregular bleeding, amenorrhea. Also, with these patients, also once they, in regards to fertility, the return of fertility for the patient to be fertile is going to be delayed up to 12 to 18 months with this medication after they stop using it. So with these patients, it should not be used longer than 2 years unless other type of hormonal contraceptives are inadequate. Why? Because these patients are at high risk for getting decreased bone mineral density. So just keep that in mind with these, right? So Depo-Provera, once again, it's going to be an intramuscular shot. You're going to give it every 90 days, every 3 months, and it's given within the first 5 days after the patient starts their menses, right? It's going to be good for any woman that has a contraindication to contraception, migraines like we discussed, sickle cell anemia, fibroids. With this one, they're going to be complaining of weight gain, and they should not be used longer than 2 years. Why? Because these patients are at risk for decreased bone mineral density. So let's talk about, so we're done with our progestin only products. Let's talk about barrier methods. So condoms, right? Diaphragms, cervical caps. So the thing about these is that they're inexpensive, right? You can get them over the counter. You don't really need them prescribed. They're cheap and they're easily accessible. And they protect you against STD. So a lot of patients that do use this are protected against like your HIV, gonorrhea, chlamydia, right, herpes. And the thing about this one is that it is reversible, but of course it really has disadvantages and it's really dependent on the user. So is the individual applying it correctly, right? And are they using it appropriately also with these patients? And then also some of the side effects with your barrier methods for women, right? Toxic shock syndrome, especially with your diaphragms and your contraceptive sponges. So the next one's going to be sterilization. This one is permanent, right? So it's permanent and irreversible. So it's something that we need to discuss with our patients, that if they are wanting to do this, to ensure that they know that this is going to be permanent and irreversible. The thing with sterilization, though, is that it does reduce the risk of ovarian cancer, right? And usually it's the most common used of method, especially in a patient that just does not want any children anymore. So some of the examples of this are going to be hysterectomy, right? Getting in there and removing the uterus, bilateral salpingo oophorectomy, tubal ligation, and vasectomies for men. So the thing about these in regard to vasectomies are very non-invasive for men. So whenever you have a couple and they're considering sterilization, just educate them in regards to, for women in general, it's going to be more invasive than men. Men, they can actually go in and out that same day in the clinic, versus women, right? You have to put them under anesthesia. You have to go in there laparoscopically. It's a lot more invasive than your vasectomies. So with sterilization, though, they still do have a risk of pregnancy. So patients have about an 86% risk of pregnancy, according to the test book that I'm reading, and 30% risk of ectopic pregnancy also with these patients. So just to let the patients know that this can happen. So the thing about these sterilizations is a lot of patients are going to regret them, right? The women are going to have menstrual irregularities, so they're going to have less painful menstruations, right? Next one we're going to go into is going to be your IUDs. So IUDs are very, very effective. And the thing about IUDs, really, it's not medication like your combined oral contraceptives where the patient has to ensure that they take a pill every day. Or for example, when we were talking about Depo-Provera, right? A patient having to ensure that they follow up every 3 months to ensure they get the shot. This one stays in for a very long time. It's a little bit more invasive, right? Because it goes inside the vagina, but these stay for a very long time. And The thing about this one is that there is a conception that people think that they have an increased rate of pelvic infections, but that's actually not true. So there's no increased rate of pelvic infections with these IUDs. And you have different types, right? You have your Mirena, you have your Skyla, your Paragard, and they tend to last a certain amount of time. So for example, Mirena, that one lasts 5 years. Paragard lasts up to 10 years, even though I've heard some podcasts say that they even last up to 12 years. Skyla lasts up to 3 years. And usually with Mirena, it's also really good for those patients that complain of very, very heavy menstruations. So for like Amenorrhea, Mirena is really good for that. And this one is reversible, so that's a good thing about this one. And just to keep in mind that just in general for IUDs, if the patient has an abnormal uterus size or contour or any type of abnormality in the uterus, they may not be effective in these patients. So ensure that IUDs are not effective with patients that have any type of fibroids, right, or any abnormal uterus. So what are some of the side effects that the patient might be complaining? After we place it, the patient might say that they have no period, so they might complain of a lighter, absent, like amenorrhea period. Also, you have a very decreased chance of exposing it. So for the IUD to come out spontaneously, especially during that first year and during that first month. And it's more commonly found in your patients that are younger. So if the patient's younger than the age of 25, uterine perforation is another one. But once again, this is not associated with PID, pelvic inflammatory disease. The other one you have is the Implanon. This one's up to 3 years of contraception. This is a one that goes into the arm, right? And this one is reversible. But with these patients, we do not use them for women who cannot tolerate unpredictable and irregular bleeding, because this one's very commonly associated with irregular bleeding. And then, of course, like we discussed, oral contraceptives, right? These are reversible, but once again, this is very dependent on the patient, and they're effective on how compliant the patient is with taking the medication. So that's why it might not be good for some patients that just don't like taking pills every day. And the thing about just oral contraceptives, it's contraindicated in breast cancer that is responsive to hormones. So like your ER positive cancers, it's contraindicated. And some of the things that the patient may be complaining of on oral contraceptives, like we discussed, weight gain, breast tenderness, amenorrhea, breakthrough bleeding, and these patients are at more risk of becoming hypercoagulable, right? So getting your DVTs. So let's go into a little more detail in regards to the long-acting reversible contraceptives, or IUDs, since this one, that's something that is very commonly tested. So let's go into our Paragard. So Paragard is one of your IUDs that contains copper, right? And so what happens is that it causes, or its mechanism of action, it's a local inflammatory response that it's induced in the uterus that leads to lysosomal activation. So there's this chemical reaction with copper and sperms that just makes sperms non-viable. And like we said, this one's good up to 10 years. I've heard some podcasts that say even up to 12 years. And some of the contraindications is going to be for sure a patient that is pregnant. And like we discussed, for all IUDs, any patient that has any abnormal contour of the uterus, right? Fibroids, it's contraindicated in these patients. Do they currently have an active pelvic inflammatory disease, or do they have a history of getting a lot of STDs? Like, do they have a very risky behavior for these patients? Also, other contraindications by far is going to be also Wilson's disease, right? Since this one does contain copper. So Wilson's disease is another contraindication. And then, of course, if the patient is allergic to copper or any component of the Paragard. Another thing about Paragard is that it's a really good form of contraceptive for a patient that just had, for example, unprotected sex in the past 3 days. So I know in regards to when you think about that, we usually think about, say, a patient that has unprotected sex, right? And they're not on any type of oral contraceptives or anything like that, and they're looking for a form of contraception. Usually we think about the medication that you can get actually over the counter, that you just provide them with your ID. So we think about Plan B, right? But another choice can be actually also your copper containing Paragard. So it's going to be your copper Paragard, and this one's actually effective even longer. So if a patient has had sex in the past 5 days, you can actually give this one. Versus your Plan B, it has to be given within like 2 days. Correct me if I'm wrong, please, but it has to be given within 2 days for it to be effective. Versus your Paragard, it can be given up to even 5 days, it can be effective. So if it's a patient that has passed that 2 or 3 day mark and they're not, Plan B will not work, then you can consider something like a Paragard. So keep that in mind. The next one's going to be your Mirena, right? This is a progesterone releasing IUD. So with these patients, it's going to be good for 5 years, right? And once again, same contraindications to the copper IUD, similar. Is the patient pregnant? Do they have a history of PID or a history of several STDs? Do they have risky behavior? Do they have a history of a prior ectopic pregnancy, right? Do they have acute liver disease or a liver tumor, benign or malignant, with these patients? And also, do they have known or suspected carcinoma of the breast? These are some of the contraindications for progesterone releasing IUD, which is going to be your Mirena. The next one's going to be your Implanon. This one also contains progesterone. And this one's good up to 3 years. Contraindications, same ones: pregnancy, a patient that has a history of being hypercoagulable, right? Thrombosis or venous thromboembolism. Does the patient have breast cancer? Do they have benign or malignant hepatic tumors? Because just in general, hormones can actually make them grow even more. So we're done with all of these. These are very highly tested, so it's really important that you know them. Like I said, Paragard, no, it's good up to 10 years. So if it's a patient that's wanting some type of contraceptive and they want it for a very long time and they don't like taking pills daily, then you can give them something like Paragard. And like we said, with Paragard, it's also going to be for your contraception for a patient that had unprotected sex in the past more than 3 days. Then you can consider something like also Paragard if they had sex more than 3 days in the past 3 days and they are not able to take Plan B because they just don't qualify in the time change, right? Oral contraceptives contain both progesterone and estrogen, right? The thing about this one is that it's really dependent on user. So is the patient going to be compliant, or are they going to be taking them every day? And with these, the patients are at risk for becoming hypercoagulable, right? Getting your DVTs, pulmonary embolisms, etc. But it is protective against certain cancers like your uterine cancer, for example. And then we have Implanon, right? We said that one's up to 3 years. That's the one that goes here in the arm. We have different IUDs. Like we said, we have our Mirena up to 5 years, Skyla up to 3 years. And of course, these are all going to be contraindicated if a patient has any type of abnormal uterus or if they have a history of fibroids, right? Sterilization is going to be really important that we discuss with these patients that this is permanent and irreversible. You have your progestin-only pills. This one's going to be suitable for lactating women. This is something that you need to know. Once again, if it's a woman that's lactating and they want some type of oral contraceptive, progesterone-only pill is going to be for them. So they're mini pills, the mini progesterone. And these are also going to be good for any woman with a history of thrombosis or migraine headache, or smokers that are going to be older than the age of 35, right? So these are the ones that are very commonly tested. So just make sure that you know these very well. So now that we're done with contraceptions, let's go into endometriosis. So endometriosis, what is it? It's basically where endometrial glands and stroma occur outside of the uterine cavity. So they're everywhere. They can be in the pouch of Douglas, in the abdominal cavity, everywhere. So they're not in the endometrium or the uterus. They occur outside the uterine cavity. So usually with these patients, right, how are they going to present? So it's very commonly found in your Caucasian females between the ages of 25 to 35. Not very commonly found in your younger patients, right, like your younger girls. And this is a benign inflammatory disease. Most common area that's going to be involved is going to be the ovaries, but like I said, this one can go anywhere. So it can involve the anterior and posterior cul-de-sac, the broad ligaments that are in the posterior portion, the uterus, the fallopian tubes, the sigmoid colon, the appendix, because this one can go anywhere. So what are some of the risk factors that increases a patient's risk for endometriosis? Nulliparity, prolonged endogenous estrogen, right? So a patient that had an early period. So they got menarche early. Usually when we think about, like, nowadays, a lot of girls are getting them very young. So when we think about ages like 8, 9, that's very early. Also, the BMI of the patient, lower BMI, late menopause once again, so expanding that amount of time that the patient has, for example, periods, right? In addition to that, how is this patient going to present? So usually they're going to be presenting with dysmenorrhea. That's one of the key words for this one. So it's going to be that dull, crampy pelvic pain that starts usually 1 to 2 days before the patient's menses, and it goes throughout the patient's menses. And I've actually experienced dysmenorrhea, and it's very, very painful. So it's going to be painful menstruation. It literally feels like you're giving birth sometimes because those cramps are just terrible. You feel them in the back. They're just very painful. So can you imagine a woman that just gets these every single time with their periods? I had a coworker that I used to work with before I started PA school, and she had endometriosis. And whenever her period came around and she was working, she was in so much pain. Sometimes she had to call in. So that's an example of dysmenorrhea and endometriosis. Another thing that the patient's going to be complaining of is going to be your cyclical pelvic pain. So it's going to be that worsening, sharp, or dual throbbing or burning pain. Another one's going to be your dyspareunia, which is going to be painful sexual intercourse. They can also present with GI symptoms like dyschezia, which is going to be, it's painful whenever they go number 2, right? Hematochezia. And why? So if you think about it in regards to endometriosis, remember we were discussing that there's growth of that endometrial gland that occur everywhere outside of the uterine cavity. So another area that can occur is in the pouch of Douglas, right? And that's usually like behind. And so that's why these patients can present with GI symptoms. So they can present with dyschezia, diarrhea, constipation. They can also have symptoms of urinary symptoms. So they can have painful urination, blood in your urine, urgency, frequency. And what is your physical exam findings you're going to see on this patient? So usually the uterus is going to be normal, right? You can feel, so the uterus is going to be normal size. That's what I mean. And when you do your pelvic exam, you're going to feel this fixed uterus. And sometimes it's even retroflex. So if we think about retroflex, and non-mobile. And that's usually what's going to be the keyword for this one. So fixed uterus, retroflexed, non-mobile. Also, you'll feel a palpable adnexal or ovarian mass. That's another one. Once again, like we said, these can occur, the endometrial glands and stroma can occur outside the uterine cavity, and the most common site is going to be the ovaries. So that's why it would make sense why you would have a palpable adnexal or ovarian mass. And some of the complications with this one is infertility by far. I know one of my classmates, my coworker that was discussing, she wanted to have children and she couldn't. She was finally able to have children, which I was very happy for her. But most of these women suffer from infertility. So the keywords for symptoms and what's going to give it away by far, when I'm reading the question stems, it's going to be that dyspareunia, that painful sexual intercourse, that dysmenorrhea. On your physical exam, it's going to be that fixed uterus. It's going to be retroflex also, and these patients also present with GI symptoms and urinary symptoms. So diagnostics, we're going to do a transvaginal ultrasound. If the question asks you what's your next step, it's going to be transvaginal ultrasound. If it asks you what's a definitive diagnostic test, it's going to be an exploratory laparoscopy. So once again, make sure that when you are reading the question, you are reading to see what is it asking you. So if it's asking you what's the next step and you're suspecting it's endometriosis, that's when you're going to do a transvaginal ultrasound. And what are you going to see? You're going to see an hypoechoic vascular androsolid mass with irregular margins. It's going to be spiculated with these patients. You might see those chocolate endometriomas also, something that's very commonly tested also. And in regards to your definitive diagnostic tests, right? Do we do this? Not really. But it's going to be your exploratory laparoscopy and biopsy. Once again, this is not required for treatment, and but this is going to be your definitive. Like you go in there and you visually look at the endometrius and just like the abdominal cavity. So once again, the best initial is going to be your ultrasound. The definitive is going to be your laparoscopy. So just look at what the question's asking you. And usually on your laparoscopy, you'll see like these blue-black powder burn lesions with these patients. So what's going to be the treatment? So it depends on the symptoms that the patient's having. So if it's mild to moderate, that means that the patient is, for example, it's not affecting their daily lives. It's not affecting them from being absent from work, being absent from school. So in my coworker's case, right, she had a severe case because it was actually affecting her from going to work. She had to be absent, especially during the times when she got her period, because she was just in so much pain, debilitating pain, and I would see her where she couldn't even get up out of the chair. So that would be an example of severe. But if it's mild to moderate, right, they just have symptoms, but it's not affecting their daily life. With these patients, we can give them NSAIDs, right? Another thing that can be given for these patients could be oral contraceptives, like we can do Depo-Provera and even some of the IUDs. So severe symptoms, so it's going to be, once again, a patient that misses their school, work, and they just cannot go on with life, or they failed initial therapy. Then with these patients, we're going to consider something like maybe like a leuprolide, right? Like a GnRH agonist, which is your leuprolide with oral contraceptives. And also, if, for example, they don't want to have children anymore, then we would do the definitive treatment, which is going to be your hysterectomy plus bilateral salpingo oophorectomy. So once again, severe with these patients, leuprolide with oral contraceptives, leuprolide, of course, if the patient wants to have children, and the definitive treatment is going to be your hysterectomy. So the next one's going to be infertility. So there's a lot of factors that go into infertility, and this one, they really like to test this one also. So just make sure that it depends on the male and the female. So not only does it depend on the female, but also on the male. Usually when we think about infertility, we think it's a woman's fault, but it's not. It can also be a men's fault. So keep that in mind also. So some of the risk factors for a female patient to have infertility is that you think about the risk factors. Is it a problem with their ovaries? Is that why they're infertile? Is it a problem with their cervix, right? Do they have any type of trauma to that cervix? Or is it a problem with the male? So let's go into each risk factor depending on the organ, right? And then on the sex of the individual. So ovaries, risk factors, we usually think about polycystic ovarian syndrome, which is the most common one. Also, does the patient have a history of radiation, ovarian failure? Also, do they have a history of pelvic infections, pelvic inflammatory disease, for example, any surgery to the pelvic area, history of endometriosis, them personally, or do they have a family history of endometriosis? In regards to uterine factors, we think about Asherman syndrome. So remember when we had discussed Asherman syndrome earlier, any type of just trauma to that endometrium? Do they have any structural abnormalities? Do they have a history of DNC? So once again, any type of trauma to that endometrium. IUD. Cervix, we think about any infections to the cervix, cervicitis, abnormal PAPs, right? History of HPV. And in regards to males, interestingly, one that I thought was really interesting is recent hot tub use. So apparently recent hot tub use can make a male infertile just during that time. Other risk factors for a male can be, do they have a history of mumps or orchitis, right? Chemotherapy, some type of surgery to the urogenital area, testicular torsion, lubricant use, steroids, do they use alcohol or smoke chronically, do they use marijuana? So what is infertility defined as? So infertility is going to be defined as inability to conceive after 1 year of unprotected sex. So that's what infertility is going to be defined as. And how do we diagnose these patients? So of course, with these patients, what we want to do is look at what the risk factors the patient has. So we'll start with an ultrasound. We can even biopsy the endometrium. We can do a pap smear, cervical cultures also. Look at the ovarian reserve, especially if the patient's older, if they're older than 35. Ovulation testing, so we're going to look at the luteinizing hormone kit, like are they Are they ovulating? Are they producing hormones also? We can do a hysterosalpingogram also to look at the tubes, at the tube patency. We can do chromoperturbation. So what's chromoperturbation? That's a procedure that's done during a laparoscopy to look at the fallopian tubes in order to see if they're patent or open. You can also do a hysterosonogram and a pelvic ultrasound like we discussed. For men, what we're going to do is, of course, we're going to look at their semen analysis. And we want their volume to be greater than 1.5 milliliters, a concentration of more than 15 million per ml. The pH is really important, so greater than 7.2. The viscosity has to be decreased, right? The vitality has to be increased, and they have to have a total motility of more than 40%. And also make sure that you look at the morphology of the sperm. Is it normal? And usually for women, the treatment's going to be usually with clomiphene citrate. So clomiphene citrate is going to stimulate those ovaries. So you can do that. You can also treat them with intrauterine insemination, right? IVF is another one. So intravitreal fertilization is another one if like treatments have not, if all the other treatments have failed. So once again, for infertility, look at men and women. Is it a factor involving the woman's uterus, the ovaries, the cervix? The men, we think about the semen, right? And when you're reading the question stem, usually how they like to ask you, it's a couple, they just got remarried, and for example, the woman has 3 prior children from her prior marriage, but the man does not. So, and they're trying to conceive. So in this case, you would suspect more of the male than the female, right? Versus if it was the other way around, you would suspect more of the female being the problem and not the male. So the next one's going to be leiomyomas. That's going to be a fancy word for fibroids. And the thing about just fibroids is that these are very sensitive to hormones. So they're very sensitive to estrogen and progesterone. So that's why they tend to grow during pregnancy. And this is going to be the most common type of solid pelvic tumor, very commonly found in African Americans. And the most common fibroid is going to be your intramural fibroid. So you have fibroids that can be located everywhere throughout the endometrium, but by far the most common one is going to be your intramural fibroid. It's going to be the most common one. So it's a benign smooth muscle tumor of the myometrium, and some of the risk factors, like we said, African Americans are more prone to getting fibroids. Also, does the patient have a history of early menses? So usually an age less than 10. Do they smoke? Do they drink? Do they have a family history of someone in their family having fibroids? So usually these patients are asymptomatic, but if they do have symptoms with these patients, they're going to be presenting with menorrhagia. This is going to be that excessive and prolonged bleeding. And this is how you can differentiate this between endometriosis, is that menorrhagia is usually exclusive for leiomyoma in comparison to endometriosis. So menorrhagia, what is it? Excessive and prolonged bleeding. The patient's going to be presenting with symptoms of pelvic pain or pressure in the pelvic area, right? They're going to be infertile. Physical exam, you're going to see abdominal distension. You can also see on your bimanual exam, you're going to feel like an enlarged mobile uterus with irregular contour. Why? Because you have all these fibroids in these patients. And these patients are very, very high risk for miscarriages. So the diagnosis for these patients, the first thing you're going to do is you're going to do a pelvic ultrasound, right? You're going to look at fibroids. And that's usually first line for any patient that has fibroids. And then you're going to do also a hysterosalpingogram. This is going to tell you and show you the contour of the endometrial cavity. And then, of course, in any patient that's older than 40, you want to make sure that you get an endometrial biopsy just to rule out carcinoma, endometrial cancer. So what's going to be the treatment for these patients? Usually it's going to be observation if the patient is asymptomatic, right, or if they're small. And then just follow up with them every 6 months. The first line medical treatment for these patients is going to be oral contraceptives for them, right? So oral contraceptives. You can also do GnRH agonists. These are very, very effective. And with these patients, another thing that you can do is myomectomy, especially for a patient that has tried medications like your GnRH agonist, it's not working, and these patients want to have children in the future. A myomectomy is better than a hysterectomy. So myomectomy, you're just removing that muscle of the endometrium, right? You're not removing the entire endometrius, just removing that muscle. That way the patient can have children. So read your question and see what it's asking you. If it's a patient that suffers from fibroids and they've tried everything and they want to have children, myometrium is going to be the best treatment for these patients. The definitive treatment, of course, is going to be your hysterectomy, because it's going to eliminate, once again, the symptoms and recurrence. So that's just removing that entire endometrium. So the next one's going to be your ovarian cysts, right? Ovarian cysts, specifically your endometrioma is also known as your chocolate cyst. I know I kind of discussed this when we were talking about endometriosis. So what's an endometrioma? It's an isolated collection of endometriosis involving an ovary. Usually this patient's going to be asymptomatic, right? They're just going to say that they have a mass and they're asymptomatic, or they can present with symptoms like irregular menses, frequency of using the restroom, constipation, pelvic heaviness, pelvic pain. And some of the signs you're going to see is usually how it's described on your question stem is going to be that brown, thick, tar-like fluid. It's like a chocolate-colored, syrup-like fluid. The first diagnostic test you're going to do is going to be a pelvic ultrasound, right? It's going to be the first line. Of course, make sure that you rule out pregnancy. So do a beta HCG with these patients. And then if you are suspecting cancer, like ovarian cancer, make sure that you check the tumor marker. So what's a tumor marker for ovarian cancer? CA-125. This is something that they really like to test also. So if it's a small chocolate cyst, usually with these patients, we can just give them something like oral contraceptives. This is going to prevent the patient from getting new ones. And you can just make sure you follow up with them, right? Repeating the ultrasound if needed. If it's large and the patient is symptomatic, then we can do something like a cystectomy. This is first line. Or oophorectomy, which is going to be definitive, which is just going in there removing those ovaries. And one of the reasons why, if it's really large and why we treat these, is that these can actually rupture and it can cause hemoperitoneum, so it can cause blood in the peritoneal cavity. So let's go into sexual assaults. So sexual assaults in children and in adults. So in adults, very commonly found in women between the ages of 16 to 24. How is this patient going to present? They're going to have problems with their sleep, decreased appetite. They can also present with somatic symptoms, like they're having chronic pelvic pain, abdominal pain, a headache, usually a chronic headache. They're going to have suicidal ideations, anxiety, depression, very decreased self-esteem, sexual dysfunction, and also they'll have a lot of PTSD signs. With these patients, it's really important that we just ensure that we evaluate and collect evidence up to 24 hours after the assault. We're going to report this to authorities and then make sure we're following up with these patients in 1 to 2 weeks. If they have been sexually assaulted, we also test them for all the STDs, your HIV, gonorrhea, and chlamydia, and we tend to treat them also prophylactically for this. So sexual assault in children, sometimes these patients, the children, they present non-specifically. They can have rectal or genital bleeding also with these patients. And with sexual assault in children, we want to make sure that we screen once again for sexually transmitted infections, evaluate for pregnancy with these patients, look for any signs of penetration, and then also, is the child presenting with a knowledge of sexual things that is just not, or sexual activity that is not appropriate for the patient's age, right? Do they inappropriately play with other children? Like, are they asking to touch another children's genital area or an adult's genital area? Also, physical exam findings, you can find a swelling or blue discoloration of the anus, which tells you that there's some type of trauma going on. With these children, we tend to evaluate and collect evidence up to 24 hours, once again, after the assault, and then we report them to CPS, Child Protective Services. So the next one's going to be spouse or partner neglect or violence. This is usually an abusive behavior, either emotional, physical, or sexual, that is being done by a person in an intimate relationship with the victim. Usually females are going to be more of the victims, while males are going to be more of the aggressors. And some of the risk factors is going to be any woman that's pregnant, lower socioeconomic status, being single, if they're younger, right, usually younger than the age of 35, divorced or separated? Is there any alcohol use or drug abuse in either the patient themselves or the partner? Is there any smoking in the household? And usually with these patients, how do we suspect this? It's just going to be injuries that do not fit with the physical exam. So it's going to be examinations or explanations for the injuries that do not fit with the physical exam. Frequent visits to emergency department. Once again, the somatic symptoms of a headache, abdominal pain, fatigue. During your physical exam, usually the patient's going to have minimal eye contact. The abuser in the room is going to answer all the questions. The injuries are usually going to be to the area that is central of the body. You also have bruises in various stages of healing. So the thing about this one is that there's a lot of screening tools you can do for these patients. You have your hits, hurt, insult, threatens, screamed at tool. You have your WAST tool, also women abuse screening tool, partner violence screen, PSV. You have your AAS screening tool, also abuse assessment screen. And the most important thing in regards to treating these patients is to ensure that we speak with the patient alone, right? And another thing that they really like to test with this one is the USPSTF, so the United States Treatment Preventative Service Task Force, in regards to screening for domestic violence. And what they recommend is screen all women of childbearing age for intimate partner violence, including domestic violence with these patients for any woman that's going to be childbearing, right? So once again, any woman that's childbearing, you want to make sure that you screen them for intimate partner violence according to the USPSTF. So the next one we're going to go into is going to be urinary incontinence, right? And there's so many causes that can cause urinary incontinence. So when we think in regards to the causes of urinary incontinence, we think about an overactive bladder, right? So detrusor overactivity, usually also an uninhibited bladder contraction that's usually caused because there's some type of irritation within the bladder, or loss of inhibitory neurological control of bladder contractions. Maybe there's some type of injury to the spinal cord, for example. Very commonly found in women. Some of the causes can be either a urinary tract infection, right? In men, prostatitis, atrophic vaginitis, bladder diverticulum, pelvic radiation therapy. And like we said, if there's any type of damage to the spinal cord, so loss of neurological control, usually from a stroke, dementia, spinal cord injury, Parkinson's disease, so something even up here in the brain. So how is this patient going to present with urinary incontinence? They're going to have loss of urine preceded by a sudden and severe desire to pass urine. Usually with these patients, they're going to be presenting with frequency, right? So frequency, urgency, and nocturia is one of the big ones, and common symptoms, and then also urgency. So usually with these patients, what's going to be the diagnostic test? We're going to look at the creatinine. It's usually going to be elevated. Avoiding diarrhea is also another thing that we can do for these patients, and then a cough stress test, right? So, and what does a cough stress test? It's usually going to show delayed leakage after coughing. And then we can also do a post-residual volume. So with these patients, usually what we're going to do is, in regards to treatment, is just ensuring that they avoid any diet that can trigger the patient to urinate even more. So alcohol, caffeine, also educating on schedule voiding, so going to the restroom and training their bladder, right? Also pelvic floor muscle training, especially in your older patients that just have a weak, like we were discussing earlier, muscles. And medication-wise, we're going to give them something like anticholinergics, like oxybutynin. That's one of the big ones for these patients. You can also give them something like TCAs, like imipramine. This one's going to help with the urgency symptoms. So let's go into obstetrics now. So let's go into pregnancies, normal pregnancy, abnormal pregnancies. So why don't we start with just normal pregnancies? So the first one we're going to go into is going to be your APGARs. So your APGARs, so what does APGARs stand for? So it's going to stand for appearance. So it's going to be the color of the baby, pulse, grimace, like what's their reflex activity, what's going to be their muscle tone, and then their respiratory effort. And usually this is going to be graded on a scale of 0 to 2. So 0 is going to be usually everything's negative, right? So the appearance of the baby is going to be blue, they're going to be pale, the pulse is going to be absent, grimace or the reflex, no response. The muscle tone is going to be limp, right? Respiratory effort is going to be absent, versus a score of 1 for appearance. The baby's going to be pink, the body's going to be pink, but the extremities are going to be blue. They're going to have a very slow heart rate, less than 100. In regards to grimace, they're going to grimace. For muscle tone or activity, they're going to have some flexion, and the respiratory effort is going to be slow and irregular. Versus a score of 2, the patient's going to be completely pink. Their pulse is going to be greater than 100. Grimace is going to be crying or coughing. Activity, the patient's going to be actively moving, and respiratory effort, it's going to be really good that they're going to be actively crying also. So a score between 0 and 2 in each of the 5 different categories are assigned usually at 1 and 5 minutes of life. And the thing about the score is that it only reflects cardiopulmonary and neurological status at those time points. It does not tell you whether the patient needs to be resuscitated. So that's one thing that you need to know, is that the APSCAR score does not determine whether you need to resuscitate this patient or not. If the score is less than 7 at 5 minutes, then you're going to assign a score every 5 minutes until the patient has a score of 7 or greater, or has reached 20 minutes of life. So let's go into just normal pregnancy in regards to the fetal position. So fetal position is the orientation of the fetus in the womb. So the orientation of the baby in the womb. And it's usually identified by the location of the presenting part of the fetus relative to the pelvis of the mother with these patients. So in fetal position, there's different positions, right? We have the vertex position, which is going to be the left occipital anterior position. This is where you have the occipital portion of the head against the buttocks that's facing anteriorly toward the left. This is actually the most common position in lie. So once again, it's going to be the LOA, left occipital anterior, or the vertex position. This is going to be the most common position in lie. You also have right occipital anterior position, where it is where the occipital faces anteriorly and toward the right. You have left occipital posteriorly, where you have the baby that's facing posteriorly and toward the left. Right occipital posteriorly, the baby's facing posteriorly and toward the right. And then you also have LOT, ROT. LOT is going to be the occipital faces the left, and ROT is going to be the occipital faces the right. Right? And we said out of all of these, the most common position is going to be your vertex position, your left occipital anterior. So multiple gestations, what are we going to do with the patient that has twins, for example, right? So with these patients, they get routine ultrasound screening, and then again at 18 to 20 weeks. With these pregnancies, these patients are going to present differently than a patient that had a single gestation. So with these patients, they're going to be presenting with more severe symptoms like pressure in the pelvis, nausea. By far, nausea, when we think about hyperemesis gravidum, we think about usually patients that have multiple gestations because they're very nauseous, they vomit a lot. They're really going to be complaining of backaches, varicosity, constipation, because you have more pressure, right, on the abdominal cavity. Hemorrhoids, why? Because once again, the patient, the pregnant woman is going to be straining whenever they're constipated, so they're very prone to getting hemorrhoids. A larger abdominal distension, and even difficulty breathing, which makes sense because you're putting all this pressure also on the chest cavity. Usually with these patients, they're going to have a uterus that's going to be larger than expected, right? They're also going to have excessive maternal weight gain, and polyhydramnios is more common in multiple gestations than your regular pregnancies. So how are you going to diagnose these patients? How are you going to follow up with them, right? So we're going to do a maternal serum alpha fetal protein, which is going to be elevated. You'll also do an ultrasound, and that's when you're going to see a baby, 2 babies on there, right? The hemoglobin and hematocrit and red blood cell are going to be very decreased compared to the blood volume. So usually these patients are going to be anemic, and the tidal volume is going to be increased. So with multiple gestations, we want to make sure that the pregnant patient is increasing their iron and calcium supplementation, right? Ensuring that they're also increasing their amount of vitamins that they're taking, their folic acid, high protein diet, right? Because these patients are going to be gaining a lot of weight. Also, want to make sure that we admit them at any first sign of suspected labor or preterm labor. And usually with multiple gestations, we always want to do vaginal delivery right? Unless it's complicated, they have a complicated pregnancy, then we're going to do a C-section. But usually it's going to be multiple vaginal delivery. Another thing with multiple gestations is that these patients tend to have a higher risk of getting a morbid course of pregnancy. They're higher risk for preeclampsia and eclampsia. They're at higher risk for gestational diabetes, higher risk for hypoglycemia. So just keep that in mind. So what about in regards to just the normal physiology during pregnancy? This is something I would know because this is very commonly tested throughout the EOR for this one. So make sure you know this one. So physiological changes, what's going to be increased, what's going to be decreased, so what's going to be up and what's going to be down. So let's go through them. I'm probably going to repeat it because repetition is a key. So what's going to be increased is going to be your coagulation factors. Your fibrinogen is going to be increased. Heart rate, so most of these women are going to be tachycardic. Cardiac output is going to be increased, which makes sense, right? Blood volume is going to be increased. Their GFR rate is going to be increased. Proteinuria is going to be increased. Their red blood cell mass is going to be increased, and their white blood cell count is going to be increased. What's going to be decreased? Albumin. Antithrombin 3 activity, systemic vascular resistance is going to be decreased. Hematocrit is going to be decreased. Hemoglobin is going to be decreased. Their BUN and creatinine is going to be decreased. Their ureteral motility is going to be decreased, which makes sense because they have a lot of pressure on that pelvic cavity. That's why they're also very prone to getting urinary tract infections. Gut motility is going to be decreased. Why? Once again, you're having a lot of pressure on that abdominal cavity, so that's why a lot of these women are constipated. And also their bicarb and CO2 is going to be decreased. So this is something that you have to know because this one's very, very highly tested. So know what is going to be increased and what is going to be decreased in these patients, right? Another thing is that a lot of these patients are going to be respiratory alkalotic and they're going to have compensated metabolic acidosis. So a lot of these patients are going to be hyperventilating. Some of the signs that you need to be familiar with is going to be your Chadwick sign and your Hagar sign. So Chadwick sign, what is it? So during pregnancy, the vaginal mucosa is usually going to be a color of dark bluish red and congested. And your Hagar sign, what happens at between 6 to 8 weeks, is where you see the firm cervix that contrasts with the now softer fundus and the compressible interposed softened isthmus. So it's going to be a soft fundus and compressible interposed softened isthmus. That's going to be your Hagar signs. So when it's, again, softening of that uterine cavity, right? And another thing that they really like to test is in regards to first pregnancies. A woman usually first perceives fetal movements between 16 and 18 weeks. Only in a woman that has their first pregnancy. In regards to the beta HCG, usually the beta HCG can be detected in the maternal serum or urine by 8 to 9 days after ovulation. And another thing that they really like to test is how often is the beta HCG doubling in a normal pregnancy? Because whenever we think about abnormal pregnancy, it's usually going to be higher or lower. In a normal pregnancy, the serum HCG concentration is going to be doubling every 48 hours. Some books say 1.4 to 2.0 days. But for example, Rosh says every 48 hours, the doubling time of the serum HCG is going to be doubling. So a plateau of the beta HCG is usually going to be hit at 16 weeks. And also with these patients, another thing is that what can you use to verify, or what's very accurate to verify the gestational age of a patient? So up to 12 weeks of gestation, the crown rump length is going to be what's going to be predictive of gestational age within 4 days. So once again, the crown rump length is going to be very accurate for gestational age in patients that are pregnant. Usually also patients are going to be presenting with quickening, which is where they feel the baby moving. That's usually between 18 to 20 weeks, and it's a perception of fetal movement. So there's, once again, 18 to 20 weeks quickening is when the mom's going to be feeling the baby. So real quick, in regards to the lung, this is another thing that they really like to test. And I know I had stated some of these earlier, but I just want to state it for repetition. So what are the respiratory changes in pregnancy? Like what's going to increase, what's going to decrease? the tidal volume is going to be increased, the inspiratory reserve volume is going to decrease, the expiratory reserve volume and residual volume are going to be decreased, the inspiratory lung capacity is going to be increased, the total lung capacity and functional residual capacity are going to be decreased, and the only thing that is going to stay the same is going to be the vital capacity in a normal pregnancy. So once again, vital capacity is going to be the only one that's going to be staying the same and not changing. So let's go into what are we monitoring during pregnancy depending on how many weeks the patient is. So if the patient is 6 to 12 gestational weeks, what we're going to do is we're going to look for fetal heart tones that are audible at 10 to 12 weeks. So usually the fetal heart tones are audible at 10 to 12 weeks. In addition to that, during 6 to 12 weeks for these patients, what we'll do is that we'll do a cell-free fetal DNA from maternal plasma, and this can be performed especially for patients or pregnancies that are at high risk for aneuploidy. So the cell-free fetal DNA from maternal plasma, what does it screen for? It screens for trisomy 13, 18, and 21. Also, during 6 to 18 gestational weeks, we're going to do a urine analysis, right? We're going to also make sure that we do a random blood glucose, we do a CBC, a red cell index, we test for syphilis, rubella, and antibody titers, we check for varicella immunity, we check the patient's blood group, Rh type, antibody screening for anti-Ro, right? Hepatitis B, surface antigen is another thing we do, and HIV. So these are some of the things that we perform for these patients. We also do cervical cultures for chlamydia and Neisseria gonorrhea. We can also do a Papa Nicolau smear of the cervix for these patients. And then, of course, all African American women, make sure that we screen them for sickle cell anemia. And if requested by the patient, we can also do chorionic villus sampling. This is usually done only up to 12 to 13 weeks only of pregnancy, okay? It's not performed in any patient that's less than 10 weeks. So keep that in mind. It's something that they really like to test. So if a patient wants chorionic villus sampling, it's only done up to 12 to 13 weeks. It's not done in any patient less than 10 weeks. So at 12 weeks, usually the uterus is going to be palpable above the symphysis pubis, and this is where the fetus tends to move spontaneously. At 14 weeks, you can actually tell the gender of the baby. At 16 weeks, that's when you can do the quad screen and amniocentesis. So at 16 weeks, you can do the quad screen and amniocentesis, especially in your patients that have a high-risk pregnancy, or if they have a history of, for example, someone in their family or a prior pregnancy that had like any chromosomal abnormalities like Down syndrome. 20 weeks is going to be your midpoint of the pregnancy. 24 weeks during these patients, right, 24 to 28 weeks, usually this is where we check the patient for diabetes, right? So we're going to do a glucose tolerance test. So we have to make sure we do that by 28 weeks, but you can do it between 24 to 28. This is something that's very highly tested, so I would know that. So once again, glucose tolerance testing is going to be done between 24 to 28 weeks. For 28 weeks, if a baby is born at this age, they have about a 90% of survival, right? And then at 28 weeks, this is where you also ensure that you repeat antibody testing for Rh negative patients. Only if their initial antibody screen for anti-Ro-D is negative, then you're going to repeat it. So you can also do a repeat CBC. You're going to screen for syphilis and HIV also. And usually the fetal position and presentation are determined during 28 weeks. 36 weeks, we're going to repeat the syphilis and HIV testing, and also, once again, get cultures for gonorrhea and chlamydia. 35 to 37 weeks, this is where we are going to do prenatal culture-based screening for group B strep in pregnancy. If the woman is positive for group B strep, then we're going to give them intrapartum penicillin. At 41 weeks, usually this is where we offer induction of labor for the patient, right? So weight gain in pregnancy is another one that's very commonly tested. So how much do you expect a patient to gain when they become pregnant? So in a normal pregnancy, in a normal BMI, the BMI of 18.5 to 24.9, usually the total weight gain is going to be 24 to 35 pounds. So they're going to be gaining about a 1 pound per week, right? Especially in your second and third trimesters. So once again, uterine size, this is something that's going to be very tested. So at 8 weeks, it's going to be palpable at the pubic symphysis. At 16 weeks, it's going to be palpable midway between the pubic symphysis and the umbilicus. And then at 20 weeks, it's going to be palpable at the umbilicus. So going on to prenatal diagnosis and care, the Nagel rule is something that's very highly tested. So make sure that you are familiar with the Nagel rule. What is the Nagel rule? It's the expected delivery date of a baby. So what you're going to do is you're going to ask the patient, the mother, when was their last menstrual period? You're going to add 7 days to the first day of their last menstrual period and subtract 3 months. So once again, last menstrual period, add a bear, subtract 3 months. So in regards to the fetal heart tones, like when are you going to hear them? Usually at 10 weeks, and it's between 110 to 160 beats per minute. And in regards to prenatal visits, usually it's going to be 4-week intervals, so every 4 weeks until 28 weeks. After that, it's going to be every 2 weeks until 36 weeks, and then weekly after. So once again, every 4 weeks until the patient hits 28 weeks of pregnancy. After 28 weeks, it's going to be every 2 weeks until 36 weeks, and then after 36 weeks, it's going to be weekly. So once again, gestational diabetes, mellitus, when do you screen for it? This is very highly tested, so that's why I'm repeating it again. It's going to be screened with labs at 24 to 28 weeks. And how do we screen them? We're going to use a 50-gram glucose load or a glucola and a 1-hour post-glucola blood glucose determination for these patients. And once again, if the patient has positive cultures of a group B strep, which is where we screen them during 35 to 37 weeks, we're going to give them intrapartum penicillin. So once again, this is very, very highly tested. So make sure you know this. So if a patient has had a previous infant with group B disease or has current group B strep, they have to receive intrapartum prophylaxis, right? Which is going to be with your intrapartum penicillin. So another thing that is going to be tested for these patients is when does a woman fly? So up to how many weeks is a woman able to fly safely? So up to 36 weeks is when the woman can fly safely. All right, so the next one we're going to go into is fetal aneuploidy. This is very highly tested also. So if a woman first seeks OB care after the 14th week of pregnancy, only the second trimester test can be offered. So you can only do the triple or the quad screen for these patients. Chorionic villus sampling, what is it? That's when you remove a piece of placental tissue to look at the fetal cells to obtain a fetal karyotype. This tells you how many chromosomes the fetus has, and it's only performed after an abnormal Down syndrome screening test. And it's usually performed once again in the first trimester because this one's associated with increased limb reductions, especially if it's performed in less than 10 weeks. So that's why we tend to perform this later. All right, so now let's go into normal labor and delivery. What does each one mean? So what is labor? So according to the textbook that I'm reading, for which I'm going to add the link below, it's a sequence of uterine contractions that result in effacement and dilation of the cervix and voluntary bearing down efforts that lead to the expulsion per vagina of the products of the conception. Delivery is a mode of expulsion of the fetus and placenta. Lightning is going to be the settling of the fetal head into the brim of the pelvis 2 or more weeks before the onset of labor. And then you have your Braxton Hicks contractions. So these are kind of like your fake contractions. These are going to be your painless uterine contractions that begin at 28 weeks of gestation. And they disappear with walking or exercise. That's why they're called fake contractions. And that's something that they really like to test you is in regards to a real true contraction in comparison to your Braxton Hicks or your false labor contractions. So why don't we go into just a contraction in general, right? So if it's a true contraction and the patient's actually going into labor, the rhythm is usually going to be regular. So they're going to have regular contractions. Also, the interval is going to be shortened and the intensity is going to be increasing. versus like your Braxton Hicks, which are going to be your false labor contractions. The rhythm's going to be irregular, the intervals are going to be unchanged, and the intensity is going to be unchanged. And like we said, this one usually gets better whenever the patient starts walking or exercising. Also, another thing is with your true contractions, every single time the woman has a contraction, the fetal heart rate is going to be decreased. Versus a false contraction, the fetal heart rate is going to be normal. It's not going to change at all. And there's not going to be cervical dilation with your false contractions, but there is going to be cervical dilation with your true contractions. So let's go into the mechanism of labor. So the mechanism of labor consists of engagement of the presenting part, flexion, descent, internal rotation, extension, external rotation, and expulsion, right? So it's really important that whenever a baby's born, we want to make sure that we clamp it. We clamped that cord, that umbilical cord. Why? Because if you don't clamp it, there's going to be excess excess blood, excess things going to the baby. So this is what can cause neonatal hyperbilirubinemia. Why? Because once again, you're getting that extra blood that is being transferred to the newborn infant. So let's go into our next one. Let's go into our dilation and station, right? And your effacement. So in regards to effacement, what is it? That's a process by which the cervix prepares for delivery. It's usually characterized by softening, shortening, and thinning, also known as your cervical ripening, right? So you have 0% effacement, which is where the cervix has not effaced at all. You have 30% effacement, and then you can have 100% effacement with these babies, and then 100% effacement plus dilation. Dilation is going to be how much does the cervix open, right? So usually when we think about one finger, it's going to be 2 centimeters. 2 fingers entering the cervix, it's going to be usually about 3.5 centimeters. So the patient's about 30% dilated. If it's 3 fingers, the patient's 50% dilated. And then 4 fingers is going to be 75% dilated. And that's usually what we would see like during my OB-GYN rotation, was a lot of checking how much the patient was dilated. And then station is going to be the relationship of the bony portion of the fetal of the head to the level of the maternal ischial spine. So it's going to tell you how far out the baby is. So for example, you have the ischial spine, right? You're measuring the station. Anything above that ischial spine is going to be negative. Anything below that, it's going to be positive. And you start counting from -1, 2, 3, 4, and then +1, 2, 3, 4. So let's go into, now that we've discussed a normal pregnancy, why don't we discuss some of the complications of pregnancies, all right? So let's go into the abortions. So what is an abortion? So abortion is a pregnancy that ends spontaneously before the fetus has reached a viable gestational age, which is usually before the 20 weeks of gestation. So we have different types of abortion. So why don't we go into our spontaneous abortion, also known as your miscarriage. And of course, for all these abortions, for like your threatened, inevitable, incomplete, complete, and septic, they all fall under spontaneous abortion. They're a type of spontaneous abortion. But in general, for spontaneous abortions, what happens with these patients and what are some of the risk factors? So the majority of them tend to occur during the first 12 weeks. There's fetal risk factors that can cause a baby to become miscarried. So if there's any type of chromosomal abnormalities, like trisomy 21, right? Is there any congenital abnormalities? The maternal risk factors are going to be a mother that's advanced, right? Advanced maternal age. If the patient already had a previous spontaneous abortion, smoking, any type of infection, also any type of like abnormalities to the uterus, right? So we're talking about fibroids, Asherman syndrome, which we discussed, which was trauma to that uterus. Also, gravidity, fever, prolonged time to achieving pregnancy, their BMI, like are they at a very low extreme or high extreme? Is their BMI less than 18.5 or is their BMI greater than 25? And how is this patient going to present? So they're going to be presenting with vaginal bleeding, pain, and then of course, depending on the type of abortion that we discussed, it's going to depend whether the cervix is dilated or not, or whether there is a passing of products of conception. So have they all passed or not? Are they still in the vaginal canal? So how are we going to diagnose these patients? Of course, we're going to do a BHCG, we're going to do a CBC, a blood type, antibody screen, and also an ultrasound. And usually treatment for these patients is just expectant management and ensuring that we allow like the abortion to occur, especially like in your complete abortions. If the patient is greater than 13 weeks pregnant, for example, then we might have to help the patient with the abortion. So it's usually your medical abortion. So you might have to give medications like misoprostol, which is going to be a prostaglandin, or mifepristone, which is going to be an antiprogestin. And then remember we were talking in regards to hormones. Progesterone is one of the hormones that is very helpful in maintaining that pregnancy. How I think about it is progesterone is progestation. So that makes sense why you would give a medication that is inhibiting progestin, which would be mifepristone. You can also do a DNC, especially during the first trimester, and then a dilation and evacuation during the second semester. Sorry. So let's go into each one. So the mnemonic I have for this one and how I memorized it was TIIC. So TIIC, and how I memorized it, another way is that, so TIIC is going to be threatened, inevitable, incomplete, and complete, right? So complete and threatened, says they're at the end, they're going to be closed cervical os. Anything in the middle, like inevitable and incomplete, are going to be open cervical os. Another way, and one of my classmates had said, which stayed with me, it might help you, is that your cervical os, anything, eyes open, right? So eyes open, anything that starts with I means that the cervical os is going to be open. So when we think about open cervical os, you're going to start anything that starts with I, so inevitable and incomplete. So if it's helpful for you, definitely use it. So let's go into the first one, which is going to be threatened. So all these patients with spontaneous abortion, the majority of them, if not all, are going to be presenting with abdominal pain or bleeding in the first 20 weeks of gestation, right? Because that's what a definition of an abortion is. And then we were discussing spontaneous abortion. So in threatened, the cervical os is going to be closed and there's going to be no passage of fetal tissue. Inevitable, remember I starts with an I, so what do I's do? Open. Cervical os is going to be open. The patient is going to be presenting once again with abdominal pain or bleeding in the first 20 weeks of gestation, and there's going to be no passage of fetal tissue. Incomplete, it's going to be abdominal pain or bleeding in the first 20 weeks of gestation. The cervical os is going to be open. And in regards to passage of fetal tissue, yes, there is going to be passage of fetal tissue. You'll see some products of conception that still remain in the uterus. And then there's going to be complete spontaneous abortion. Cervical os is going to be closed. There's going to be complete passage of fetal parts and placenta, and that uterus is going to be contracted. That's why it makes sense why it's going to be septic, right, with these patients. So what's going to be the treatment for each one? And then diagnosis. So usually diagnosis for these patients, we're going to do an ultrasound, right? For example, complete abortion, we're going to do an ultrasound. And usually the treatment for these patients, you really don't need to do an evacuation of the uterus, but we just want to make sure that we're monitoring the patient, right? There's also missed abortion. So missed abortion is going to be a retention of non-viable pregnancy for a prolonged period, so more than 2 menstrual cycles. And usually this patient is going to present with a smaller gestational size, and they're going to have no fetal heart tones. They're going to have no bleeding with this one, right? But they're going to have a positive pregnancy test or inappropriately rising beta-HCG levels. So how are we going to diagnose them? We're going to do a BHCG, a CBC for missed abortion, type and screen, check fibrinogen just to make sure it's maybe not something associated with a hypercoagulation disorder. And then an ultrasound, we'll see fetal demise and no cardiac activity. We can also see maceration. The signs we're going to see for missed abortion, the cervical os is going to be closed with these patients, and treatment is going to be resuscitation, observation, and just make sure we're observing them, like we said. The next one's going to be threatened abortion, like we discussed earlier, CBC, type and screen, right? And this one's also going to be observation in regards to treatment. Inevitable abortion, CBC, HCG, type and screen, ultrasound. As you can see, they're very similar. Resuscitation and observation also. Incomplete abortion, usually with these patients, we do expectant management, but you can also do surgery, especially if the patient's just really sick, right? And they're not able to pass it by themselves. Now, if a patient presents with a recurrent abortion, then we want to make sure that we test this patient and we do a full workup. So Usually when we think about a first abortion, we think about, remember when we were discussing like any type of chromosomal abnormality, like genetic causes. If the patient has had a second abortion, then we're thinking that it might be something autoimmune or any type of anatomical problem with the uterus. So in regards to autoimmune, maybe we're thinking about lupus, right? Antiphospholipid syndrome is another one, or anatomical problems like Asherman syndrome. And sometimes these patients just have, for example, some of the causes, like we can say, it's usually unexplained, or they have some type of hypercoagulable problem like factor V Leiden. So what is a recurrent abortion? It's defined as more than 2 consecutive losses or more than 3 spontaneous losses before 20 weeks. And what we want to test for these patients is going to be anti-cardiolipin, right? We want to make sure that we also check antiphospholipid antibodies. It's going to tell us whether this patient has like lupus or anything like that. We want to make sure that we karyotype both parents. And treatment is, we can give them hydroxyprogesterone. Once again, 17-hydroxyprogesterone, because remember we said that progesterone is progestation. It's really good for maintaining that pregnancy. And if the patient does have lupus anticoagulant and anti-cardiolipin antibody syndromes, then with these patients, we can treat them with like low-dose aspirin with unfractionated heparin. So the next one's going to be your induced abortion. So this is where there's a medical or surgical termination of an intact pregnancy before the time of viability. This is usually done with medications. For example, you can do either mifepristone and methotrexate, and you can also do misoprostol. So with induced abortion, if a patient electively decides to abort their baby, then with these patients, it's going to depend on what semester they're in. So for a first semester, up to 49 days gestation, and second trimester, usually it's going to be medical abortion, so it's going to be any of the medications that I discussed. If it's if the patient is greater than 49 days or greater than 7 weeks, right, it's surgical ablation usually recommended. So once again, first trimester, if you need to do any type of surgical, then you can do things like suction curettage using vacuum aspiration, second trimester, like we said. And then last line is going to be dilation and evacuation. So the next thing we're going to go into is going to be your septic abortion. So septic abortion is usually an abortion that's been infected. And how I think about septic abortion is going to be an individual, and then the question stems that they went to get an abortion with someone that was not anyone medically related. So it was not a doctor or anyone like that. And most of these places are dirty. They're not sterile, right? So that's how I kind of think about it. It's going to be an infected abortion. They went with an illegal abortions, or there was just not sterile. So this patient's going to be presenting with that bleeding sanguinopurulent drainage. So usually it's described like that strawberry milkshake discharge. They're going to be very sick appearing. So they're going to have fever, chills, abdominal pain. You may or may not see passage of product of conception. They're going to be tachycardic, tachypnic fever. The cervical os is going to be dilated, right? You're going to see usually a very soft and boggy uterus and a soft and dilated cervix. In regards to what we're going to do for this patient for diagnostics, CBC, beta-HCG, right? Type in screen, since a lot of these patients are bleeding out. We want to make sure we do cultures of the blood and endometrium, and then an ultrasound to see if there's any still products of conceptions that are retained, or some type of foreign body that was just left there during their the abortion, right? When they were trying to do the abortion. So treatment for these patients, broad spectrum antibiotics, right? Fluid resuscitation, uterine evacuation. Also make sure that we assess for any perforation. Make sure we control their pain, right? The next one's going to be ectopic pregnancy. So ectopic pregnancy, the most common site where the ectopic pregnancy can occur is going to be the ampulla. When we think about the risk factors, we think about exposure to DES, which is a type of drug which used to be used in the past. It's not used anymore. Cigarette smoking, tubal ligation, ovulation induction, prior pelvic inflammatory disease, or prior ectopic pregnancy, infertility, contraceptive IUD. And of course, the most common cause of an ectopic pregnancy, or more like what's the most common risk factor of an ectopic pregnancy, is going to be a prior ectopic pregnancy also. So how is this patient going to present? They're going to have abdominal pain and vaginal bleeding, nausea, breast swelling, and tenderness with these patients. Also, they're going to be presenting with shoulder pain. That's worse whenever they inspire. And with these patients, they're going to be presenting with unilateral abdominal tenderness. On your physical exam, the cervical os is going to be closed. Cervical os is going to be closed. You'll see adnexal tenderness. You'll feel some adnexal tenderness. And usually the uterus is going to be smaller than expected. So with these patients, how are we going to diagnose them? So we're going to do a serum beta HCG. We want to make sure that we repeat it every 48 hours. If it rises less than 50% in 48 hours, then it is considered ectopic, right? We're also going to do a gestational transvaginal ultrasound. And usually on your ultrasound, that's where you're going to see an empty gestational sac, or it'll say there's no intrauterine pregnancy on the ultrasound. The thing about ultrasound, though, what you need to take into consideration is that there's a HCG discriminatory zone. So what does that mean? It says that if the HCG is less than a certain amount, like less than 2,000, then you won't be really able to see the pregnancy on an ultrasound. So just keep that in mind in regards to your question. Is once again, if the beta HCG is less than like 2,000, you really won't be able to see visualize a true pregnancy on the ultrasound. And what's going to be the gold standard in general for ectopic pregnancy? It's going to be your transvaginal ultrasound, right? These patients. Another thing you want to do is get a progesterone. So remember, progesterone is progestation. So usually the patient's going to be having a progesterone very, very low. So it'll be under 5, which is not viable with pregnancy. And it has to be greater than 20 for, progesterone has to be greater than 20 for pregnancy to be viable. So the treatment for these patients, methotrexate, right? But before we do that, we want to make sure that we check the patient's liver and kidney function, right? So we're going to get these patients treated with methotrexate. And once again, we want to make sure that we follow up with these patients at day 4 and 7 days, then weekly after that, to ensure that the beta HCG is dropping and the hormones of the patient are dropping. So what are some of the contraindications for methotrexate? So it's going to be, of course, if the patient is unstable, if it's ruptured, if the patient's anemic, then these patients need to go to surgery. And usually if it's ruptured and ectopic, these patients are going to be presenting very, very weak. They're going to have that shoulder pain. They're going to have syncope, so a history that they passed out. They're going to be pale, abdominal distension with like rebound, right, shifting dualness, and they're going to be in shock. These patients need to go to surgery. So the next one's going to be gestational diabetes. Gestational diabetes. So some of the risk factors for gestational diabetes is going to be a patient that had a previous pregnancy that they had gestational diabetes in. That's one of the biggest risk factors. Also, if the patient has impaired glucose tolerance, is the patient currently diabetic right now? Do they have a family history of diabetes and any of their family members, like a first-degree relative? Also, in regards to that one, do they have a history of polycystic ovarian syndrome, multiple gestations, like we discussed, that multiple gestations are very prone and at high risk for developing gestational diabetes mellitus? So in regards to when are we going to screen them, I keep repeating this because this is very highly tested. So we're going to screen them between 24 to 28 weeks, right? And the reason why we're so aggressive about screening and treating these patients is that there's a lot of complications for a patient and for a baby that has a mommy that has untreated glucose, untreated high glucose, untreated gestational diabetes, that there's a lot of things that can happen with the baby. So one of the common ones is going to be macrosomia, which is going to be those really, really big babies. Preeclampsia, shoulder dystocia is because the baby's so big, when you're trying to take the baby out of the vaginal canal, you can actually injure those nerves that go through the shoulder. And polyhydramnios, and then stillbirth. So once again, we're going to screen them at 24 to 28 weeks for these patients. We're going to screen them with the 1 hour 50-gram glucose challenge. So we do the 1 hour glucose challenge between the 24 to 28 weeks, right? If it's greater than 130 milligrams after 1 hour, then we're going to do a 3-hour 100 gram glucose tolerance test. And this has to be performed within 1 week to confirm that the patient has gestational diabetes. And a diagnosis of gestational diabetes is made if that 100 gram glucose challenge meets any of the following criteria. If it's greater than 95 milligrams per deciliter and they're fasting, if it's greater than 180 milligrams per deciliter at 1 hour, if it's greater than 155 milligrams of deciliter at 2 hours, or if it's greater than 140 milligrams per deciliter at 3 hours. So if any of the following are positive, the patient, after a 100 gram glucose challenge, then these patients are going to be diagnosed with your diabetes mellitus. So if you do diagnose a patient with diabetes mellitus, make sure that we get the patient evaluated by ophthalmology and make sure that we do a fetal ultrasound and echo just to make sure everything's fine with the baby. So what's going to be the treatment for these patients? So of course, remember with the PANTS just in general, make sure that we are always doing nutritional counseling, ensuring that the patient has a good diet, right? And we're going to give the patient insulin. So insulin is going to be given for these patients because metformin is contraindicated. So insulin. Our goal fasting blood glucose is going to be less than 95 because we want to make sure that we avoid any type of maternal hyperglycemia. So once again, insulin is going to be the treatment for these patients, right? We're going to want a fasting blood glucose less than 95. Just OB-GYN is very, very particular in regards to what their blood glucose is going to be for patients with diabetes. They're very, very aggressive. So that's why it's at less than 95. And these patients get twice weekly NST starting, so non-stress testing, starting at 2 weeks. So the next one we're going to go into is going to be gestational trophoblastic disease. So gestational trophoblastic disease. So gestational trophoblastic disease is kind of an umbrella. From here, this is where you have the different types of molar pregnancies. So with gestational trophoblastic disease, right, there's a FIGO criteria, which means that they have to have this criteria to kind of be diagnosed with gestational trophoblastic disease. So they have to have an elevated HCG for more than 6 months after DNC, histological data for choriocarcinoma, 2 or more weeks by at least 10%, the HCG has to be increased. So a rise of 3 weekly consecutive HCG over 2 or more weeks by at least 10%, and then plateau of 4 or more HCGs over a 3-week period. So it's going to be gestational trophoblastic disease. So let's go into our molar pregnancies, right? So our molar pregnancies. And real quick, with gestational trophoblastic disease, you kind of characterize it into benign or malignant, right? When we think about benign, we think about just our moles. When we think about malignant, we think about choriocarcinoma, right? Invasive moles with these patients. So just make sure that you know that. So gestational trophoblastic disease is kind of like an umbrella. And then from there, you categorize them on whether it's benign or it's a malignant molar pregnancy. So just for molar pregnancies, let's go into each one. So we have our partial moles and we have our complete full-blown moles, and we also have our non-molar moles. So for molar pregnancies for partial mole, this is something that's very commonly tested, is going to be the karyotype that you are going to be seeing for your partial mole. And what happens with a partial or incomplete mole is that there is an organism that has 69 chromosomes, and it develops because it has non-viable fetal parts, right? So it's usually what an incomplete or partial mole is. And the karyotype is going to be triploid karyotype, so it's going to be 69XXY, 69XXX, and 69XYY. So what happens in regards to pathophysiology is that you have a fertilization of an egg by 2 sperms. So how to compare between a complete mole and an incomplete mole? An incomplete mole, what happens is that it's going to be secreting more HCG than normal, but not as much as a complete mole. A complete mole is going to be having a higher HCG level than an incomplete mole. This patient is going to be presenting with missed periods, vaginal bleeding. With an incomplete mole, the uterus is not larger than expected, and this patient is usually not going to have symptoms of increased HCG, so they won't have any symptoms of that. And most of these tend to result in spontaneous abortions during the late 1st and early 2nd trimesters. So once again, that's going to be for your incomplete or your partial for what you're going to see for these patients. And in regards to your complete mole, right, these do not contain fetal or placental parts. This one's going to be diploid. So you're going to see 46XX, 46XY. And what happens is that you have an empty egg that's fertilized by either one sperm or two, but it's just fertilization of an empty egg for your complete mole. So these patients are going to have a larger uterus. They're going to be presenting with preeclampsia, and also, like we said, this patient's going to have a very huge amount of beta-HCG. So they're going to be presenting with missed periods. They're going to have a positive pregnancy test. They're going to have vaginal bleeding, right? They're going to have symptoms of hyperthyroidism, so insomnia, anxiety, tachycardia, palpitations. They're going to be presenting with hyperemesis gravidum. Why? Because you have that beta-HCG that is driving all that. So they're going to have extreme nausea and vomiting, severe dehydration. So remember, we were thinking about hyperemesis gravidum. It's very common in your multiple pregnancies, so your twins, your triplets, and very common in your complete mole, so your molar pregnancies. And then you have your non-molar, which is no villi, and this includes your choriocarcinoma, your placental site trophoblastic tumor, which we're going to discuss also in a few minutes. So what are some of the risk factors just in general for a molar pregnancy? So if a patient has had a history of a previous mole, women at both age extremes, so very young, less than the age of 18, and of course your advanced maternal age. Also, another one is previous unsuccessful pregnancies, and usually these tend to present in general for molar pregnancies during 11 to 25 weeks gestation. Usually the average is going to be in 16 weeks. And these patients, like we discussed, they're going to be presenting with that vaginal bleeding. The complete mole is going to be having the hyperemesis gravidum, right? And for the complete mole, also, they're going to have a very large uterus that is going to be larger than expected for their dates with these patients. And how are we going to diagnose them? So we're going to do a CBC, right? We want to do a type and screen and a beta-HCG. And like we said, the beta-HCG is going to be super high, especially in your complete moles. It's going to be a lot higher than your incomplete moles. So the beta-HCG, you'll see probably like 1+ million, right? And we're going to do also a sonogram. So we're going to do a transvaginal ultrasound. And what are we going to see? Usually for your gestational, that's where you see that snowstorm or Swiss cheese, right? Snowstorm or Swiss cheese. And also is a free T4 and TSH. And like we said, these patients tend to present with symptoms of hyperthyroidism. So you're going to see an elevated free T4 and then a decreased TSH for these patients. So in regards to treatment, what are we going to do? So another thing we want to do, is we want to get a chest x-ray. We just want to make sure that there's not any type of metastasis going on anywhere, right? So, and then, so just make sure that we do that. So treatment for these patients, of course, is going to be dilation, suction, and curettage. We just want to make sure that we also follow up with these patients. So make sure that we put them on a contraception. We want to measure their serum beta-HCG weekly until it's not detectable anymore. And then they're going to have a monthly follow-up for 6 months. So the key for this one is going to be ensuring that we do dilation, suction, and curettage, ensuring that we follow up with these patients. So we're going to repeat that beta-HCG, right, 48 hours after evacuation, and ensuring that the patient is on an oral contraceptives, right? And we're going to keep measuring that serum beta-HCG weekly until it's undetectable, and then monthly for 6 months, right? So that was your complete and partial mole. These are going to be under that umbrella of gestational trophoblastic disease, but these are going to be benign, right? So these are going to be benign. So the next one we're going to go into is going to be our malignant causes, which are going to be your choriocarcinoma, for example. So choriocarcinoma, this is going to be the most common type of trophoblastic neoplasm after a term pregnancy or miscarriage. So what happens with these is that there's an aggressive invasion into the myometrium, and these tend to metastasize for your choriocarcinoma. So this patient is going to be presenting with irregular bleeding, spotting. This is the most common finding. Also, they're going to have continuous or intermittent, sudden or massive hemorrhage. And once again, this is very commonly to occur after a pregnancy. these patients. And in regards to diagnostic tests, we're going to do a serum beta-HCG level, which is going to be positive. And we're going to do a transvaginal ultrasound, a chest x-ray, and it's really important that we do not biopsy any of this, especially if they're in the vagina. Treatment's going to be chemotherapy with methotrexate, and these tend to metastasize to the lungs and vagina with your choriocarcinoma. So once again, this is going to be a non-molar pregnancy. We're going to do an ultrasound, right, chest x-ray, and just make sure that we do a CT scan with these patients. And treatment's going to be depending really on whether the patient's low risk or high risk. So if they're low risk, we're going to give them methotrexate. If they're high risk, usually we'll give them combination chemotherapy. So that was your, and then, sorry, real quick, what are some of the risks that we're discussing? So your risk score is going to be your age, right? Previous pregnancy, time since last pregnancy, pre-treatment serum HCG, what's the size of the tumor, what's the site, and how much has it metastasized with these patients. Has this patient failed chemotherapy, right? So anything that's greater than 6, usually they require a combination chemotherapy. Between 0 and 6, usually you can just treat them with a single agent like methotrexate. So one more thing I wanted to get into real quick is just the vaccinations. So what vaccines are safe in pregnancy? And the reason why I just went through this, and I just remember I had a question on this, so that's why I'm going over it. So make sure you know this is very commonly tested. So what vaccines are safe to give in a patient that's pregnant? So whenever we think about vaccines that are safe, it's going to be any vaccine that is not live, right? So any live vaccine, the majority of them. So hepatitis B is safe. Influenza, inactivated influenza, right? Not the live attenuated influenza. Inactivated influenza is safe in pregnancy. Your Tdap is safe in pregnancy. Meningococcal is safe in pregnancy. Rabies is safe. Pneumococcal is safe. And then once again, inactivated polio vaccine is safe. The ones that are contraindicated are usually the ones that are going to be live, like oral polio vaccine, which is a live vaccine. Your BCG vaccine, which is a live vaccine. Varicella, both live and attenuated, is contraindicated, and MMR is contraindicated in pregnancy. So just make sure you know that, because it's something that I also saw that was very commonly tested. So let's go into our incontinent cervix. So what is an incontinent cervix? It's basically where there is an inability of the uterine cavity to retain a pregnancy in the second trimester in the absence of uterine contraction. So sometimes the patient will just have a miscarriage, the baby will come out because that cervix is not strong enough to hold that pregnancy. So some of the risk factors is going to be any type of trauma to that cervix that is not making that cervix strong like it used to be. So any type of trauma like laceration, any conization, did the patient have prior like HPV, right? DNC, LEEP, also Mullerian abnormalities, colon disorders like Eisler's-Danlos, prior abortion. This is something that they really like to test. So make sure that you know this in regards to what are some of the risk factors for a patient having incompetent cervix. So we were thinking about any trauma to the cervix, right? History of HPV, history of even cervical cancer, right? Where they had to maybe excise certain parts of the cervix. And the big one by far is going to be any type of colon disorder, Mullerian abnormalities, Danlos-Ehlers syndrome. So make sure you know that. So how is the patient going to present? They're going to have usually presenting with painless cervical dilation during the second trimester. They're going to have absence of contractions, right? They're going to be presenting with pelvic pain, cramping, back pain, vaginal discharge, and they're going to be presenting with preterm premature rupture of membranes. So preterm premature rupture of membranes. How we think about preterm premature rupture membranes, so it's going to be the rupture membranes before 32 weeks of pregnancy. They're also going to be presenting with a prolapse and ballooning of the membranes into the vagina and then expulsion of that fetus. So how are we going to diagnose this patient? We're going to do a sonogram. It's going to tell us that there's a decreased cervical length, usually less than 2.5 centimeters or less than 30 millimeters. We're going to do a fetal fibronectin, which is going to be positive, right? And also with these patients, we just want to make sure that we educate them to avoid any type of coitus or any type of sexual activity that can further damage that cervix. And what's going to be the treatment? So it's going to be cerclage placement. This is going to help reinforce that weak cervix. So you're going to do a suture there, right? It's going to be a purse string suture with these patients. So the next one's going to be placenta abrupta. So placenta abrupta or placenta abruption is going to be a premature separation of the placenta from its implantation. And usually it's going to be a patient that's going to be in her 3rd trimester. They're going to be complaining of hypertension. They had some type of trauma, or even like through drug abusers like cocaine use. They're going to be complaining of painful vaginal bleeding. And that's the key for this one and how to differentiate between placenta abrupta and placenta previa. Placenta abrupta is usually going to be associated with some type of trauma or injury, patient in a car accident, drug abusers, uncontrolled hypertension, right? Where that placenta is just being detached from your from its implantation. Some of the maternal risk factors is going to be advanced maternal age, multiparity, so a patient that has multiple pregnancy, and then of course any type of trauma. Once again, any prior uterine surgery. Also, did they have a prior placenta abrupta? Also, polyhydramnios. And some of the signs you're going to see is going to be that woody uterus, fetal distress. The patient's going to be in shock, right? So they're going to be hypotensive. They're going to be tachycardic. And you're also going to see hypofibronogenemia. So this is usually associated with hypofibronogenemia. So with these patients, what are we going to do? So clinical diagnosis is going to be with an ultrasound, preferably a transvaginal ultrasound. We're going to do a CBC, check their fibrinogen, which is going to be low, right? Because they're going to be presenting with hypofibronogenemia. Do a type and screen, and also make sure that we're monitoring the fetal heart rate, right? And usually these patients are going to be very hypovolemic. They can go into what type of shock? So your hypovolemic shock, because these patients are going to be losing a lot of blood. Treatment for this is just ensuring that we do immediate delivery, right? Especially if the mom is not preterm, right? If they are preterm, then we try to avoid it. But if the mom is not preterm, then we try to induce labor with these patients. If the fetus is in distress, we're going to do C-section. If the patient is at term and they are not in distress, the baby's not in distress, then we're going to do a vaginal delivery. But usually it's just monitoring the fetus, hemodynamic stabilization, and then delivery. So with these, it's always going to be your ABCs, right? Airway, breathing, circulation. Give the patient fluids because they're going to be fluid down, hypovolemic, and then ensuring that we stabilize the patient, and then delivery. The next one's going to be placenta previa. This is where the placenta implants over the internal cervical os. This is the most common type of abnormality of placental implantation. Once again, risk factor is very similar to placenta abrupta. So any type of trauma to like the uterus itself, or like previous C-section, right, where you're going in there and you are physically cutting. D&C, smoking, prior placenta previa, multiparity, and advanced maternal age. This patient is going to be presenting with painless vaginal bleeding versus placenta abrupta is going to be painful vaginal bleeding, right? This one's going to be painless vaginal bleeding. Diagnostics is going to be with the transvaginal ultrasound. It's actually preferred over your transabdominal ultrasound. So on your transvaginal ultrasound, you're going to see the placenta that's very, very low. This is something that's very commonly tested, so make sure that you know this. It likes to test you in regards to which one's better, transvaginal or transabdominal. Transvaginal is going to be better. And once you do that transvaginal, you're going to see that placenta that's lying very, very low. We're going to do a CBC, coags, also make sure that we are monitoring the heart rate. And it's really important that with these patients, we do not perform a digital exam. So do not perform a digital exam because you can actually make the hemorrhage even more severe. So with these patients, in regards to treatment, right, it depends on how far along they are. If they're 37 weeks and they're bleeding a lot, then we're going to deliver them. If it's less than 37 weeks, then we want to make sure that we observe them, right? Make sure that the fetus is mature before we deliver the patient. So when are you going to deliver the patient regardless of the gestational age? Usually if they have a life-threatening hemorrhage, bleeding after 34 weeks of pregnancy, and of course if the fetus is just very severely ill. So another one I wanted to go into that's very highly tested is the different types of the placenta creta, right? Your placenta percreta and your placenta increta. So this is something that's very, very highly tested. So it's really important that we go through the difference through each one. So all of these that I've gone through is conditions where the placenta does not, so once again, it does not completely separate from the uterus after birth. Okay, so once again, this one does not separate from the uterus after birth. So of course, once a woman delivers her baby, you're expected for the placenta to come out, right? So this is the conditions where the placenta is just too fixely attached to the uterus. So let's go into placenta caretta. Placenta caretta is basically where the placenta attaches too deeply and too firmly into the uterus. So placenta caretta, right? Once again, that's where it attaches too deeply, too firmly into the uterus. The next one's going to be placenta increta. This is where the placenta burrows into the myometrium. The placenta percreta is where the placenta attaches and grows through the uterus, sometimes even extending into the bladder and into the intestines. So this one is really in there. So as you can see, we were going through the accreta, increta, and percreta. As we get deeper, they get deeper into the tissue. So one of the mnemonics that one of my classmates came out with, for some of my classmates, which is amazing, and hopefully it works out for you, definitely worked out for me for the exam, it's going to be that the placenta accreta adheres, the placenta increta invades, and the placenta percreta penetrates. Once again, accreta adheres, increta invades, and percreta penetrates. So if you can see, if you just remember the A for it adheres or attaches, right? I invades, increta invades, and P for percreta, it penetrates. So what's going to be the diagnostic for these patients, right? So usually with these patients, of course, we're going to do the physical exam, and usually the treatment for these patients is going to be either with a total hysterectomy, right? So C-section plus a total hysterectomy. Some of the risk factors for any of the patients getting any of these is going to be, of course, if they have any type of prior uterine scar, so any scar to the uterus, and of course, if the patient has any history of placenta previa. So let's go into our hypertensions during pregnancy. This one's something that's very highly tested also, so be familiar with what is gestational hypertension, what is chronic hypertension, preeclampsia, and eclampsia. So making sure you know the difference between these will help you out a lot during the exam. So let's go into your mild gestational hypertension. So usually this is considered mild, right? And usually these patients are going to be presenting with a blood pressure of less than 160/110 with these patients. And in order to ensure that we make a diagnosis of gestational hypertension, we have to have at least 2 readings of at least 4 hours apart. So you can't diagnose a patient with gestational hypertension just by 1 reading. It has to be at least 2 readings at least 4 hours apart. And usually with mild gestational hypertension with these patients, of course, is usually we just want to do our conservative for these patients. So of course, ensuring the patient doesn't get stressed out, and just ensuring that we kind of look out for signs that the patient is having any signs of chronic hypertension, chronic gestational hypertension, or that they're having signs of preeclampsia or eclampsia. The next one's going to be chronic hypertension. So this is going to be your hypertension that was present before the pregnancy. So once again, gestational hypertension has to have occurred when the patient became pregnant, right? So gestational, and usually it's going to be after 20 weeks. Versus a chronic hypertension is going to be a hypertension that the patient had before they became pregnant. So they were hypertensive before pregnancy and they got pregnant and they're still continuing with having hypertension. So once again, gestational hypertension is going to be hypertension that occurs after 20 weeks versus a chronic pre-existing hypertension is going to be hypertension that occurs usually before 20 weeks of pregnancy, and then also with these patients, they usually have a history of hypertension before the pregnancy started. So once again, hypertension for chronic hypertension is going to be a hypertension that has to be present before 20 weeks and persist at least more than 12 weeks postpartum. So once again, that's going to be the key. So if it's uncomplicated hypertension, like between 140 to 150 over 90 to 100, no treatment is necessary, just ensuring once again that we observe these patients. If they do have signs of organ damage, or if they have persistent blood pressure readings that are really high, like greater than 150 over 95 to 99, then these patients get methodopa or labetalol. And remember that ACE inhibitors and angiotensin receptor blockers are contraindicated in pregnancy. So that's something that you really need to know, because they try to trick you. They'll put an ACE and an ARB. And usually when we think about hypertension, right, we think about ACEs and ARB being treated for the patients that have hypertension. No, that's not the key. Or the treatment for patients with pregnancies are going to be contraindicated. So gestational hypertension. So like we said, this is going to be after 20 weeks and the patient's going to have no proteinuria. This is the most common type of hypertension a patient is going to have during their pregnancy. And some of the risk factors is going to be nulliparity. So if the patient has not had a baby before, it's their first baby. If they have a history of, for example, multifetal gestation, so once again, several babies, or is it current pregnancy, like is it multiple gestations, obesity, does the patient have a history of vascular disease, and with these patients, how are they going to present? So they're going to have a blood pressure that's going to be greater than 140/90. Once again, they're going to have no proteinuria or evidence of organ damage, because once they do, that's when they jump to the next class, which we're going to discuss. And with these patients, it's really important that gestational hypertension, we diagnose them, and we want to make sure we look for any red signs, right? Red flags. So we want to make sure that the patient's not in full-blown preeclampsia or eclampsia. So we'll get a 24-hour urine just to make sure that there's no proteinuria. We're going to do a physical exam, ask if the patient has any signs of systemic vascular resistance, like headache, visual changes. Do they have any right upper quadrant pain or epigastric pain, any bleeding from the vaginal area? How is the baby moving? We're going to also do a CBC, LFT, serum creatinine, and then a biophysical profile just to look at the baby. So with these patients, for the treatment, what's going to be our blood pressure? So if the patient has a blood pressure less than 160/10, usually these patients, we're just going to observe them once again. We'll tell the patient to ensure that they rest, right? So bed rest. And usually these patients, we don't really give them treatment. So once again, blood pressure less than 160/110, these patients don't not get treatment, but we want to make sure that we do have a goal of blood pressure of 130 between 150/80 to 100 diastolic. So systolic of 130/150, 130 through 50 over 80 through 100 diastolic. So what about a patient that has a blood pressure greater than 160/10? With these patients, of course, we're going to try to control the hypertension. So we're going to give them antihypertensive medications plus seizure medications to prevent the patient from going into full-blown eclampsia. So eclampsia we're trying to avoid. So what are some of the health maintenance, right, for these patients we're going to do? Just ensuring that we follow up with them weekly, if not like twice a week, measuring their blood pressure, and also ensuring that we get urine analysis to look for any protein, and also ensuring that the patient avoids any type of weightlifting. So preeclampsia, this occurs after 20 weeks in a patient that was previously normal, right? Usually these patients are going to have, in regards to risk factors, a history of a prior pregnancy with preeclampsia. That's one of the big ones. So once again, risk factors is something that's very highly tested. So make sure you know this in regards to risk factors for preeclampsia. By far the biggest one, of course, is going to be pre-existing preeclampsia. What about pre-existing hypertension, which is another one? Is the patient diabetic? Multiple gestations, like we said, these patients are very prone to getting preeclampsia. So those patients that have twins, for example, diabetics, chronic kidney disease, autoimmune disorders like lupus, advanced maternal age, especially if the patient's older than 40, and nulliparity. But interestingly, what is a protective factor against preeclampsia is smoking, which is really interesting. So in regards to diagnostic, the patient's going to have a new onset of hypertension, so they're going to have a blood pressure that's greater than 140/90. They're also going to be presenting with proteinuria, so they may or may not present with proteinuria, so just keep this in your back of your mind. So sometimes when you do a dipstick, they're going to be more than 300 milligrams of protein on your urine dipstick. So these patients have to have, once again, either a new onset of hypertension, so blood pressure greater than 140/90, plus with or without proteinuria, plus either one of these signs. So they either have to have a severe headache. For example, they're going to say that they have they're seeing dark things. So your scotoma, so they're seeing flashes, altered mental status, pulmonary edema, right upper quadrant pain, or LFT is going to be greater than 2 times the upper limit. Platelet is going to be less than 100,000. So they're going to have thrombocytopenia, renal insufficiency. And on your physical exam, you're going to see hyperreflexia. Some of the complications for these patients are going to be acute pancreatitis, right? So it's really important that we treat these patients, because If it's not treated, these patients can stroke out, they can get seizures, they can go into full-blown eclampsia, right? They can get placental abrupta, hepatic rupture, go into renal failure. So how are we going to diagnose these patients? Of course, we're going to do our LFTs. We're going to see that the AST is going to be twice the upper limit, and usually this is going to tell us that there's already some type of organ damage going on with the liver, right? The serum creatinine is also going to be very high. It's going to tell us that there's renal insufficiency, and this patient is going to have a platelet count less than 100,000. In regards to the treatment, it's going to really depend on how the patient's presenting. So if the patient has no severe features and they are less than 34 weeks pregnant, then usually we're going to do conservative management, right? But if the patient does have severe features, then these patients, we're going to deliver them, give them steroids, right, to just make sure that the baby's lungs mature. Also make sure that we monitor the baby and the mommy, give the patient a lot of fluids, and then also control the blood pressure. So if the blood pressure is greater than 150/100, remember we're going to be giving antihypertensive that are safe in pregnancy. So we're going to be giving IV labetalol or hydralazine. And then all these patients get magnesium sulfate. Why? Because we want to prevent this patient getting seizures and going into full-blown eclampsia. So if the patient is farther, like they're more than 37 weeks and they're presenting like this, then usually these patients, we're going to deliver them, right? And then urgent delivery is usually going to be done for any patient that has just severe headache, visual problems, upper epigastric pain, ultramental status. So if they're presenting with any symptoms or severe signs like the one we discussed, usually these patients get urgent delivery for these patients. So the next one's going to be preeclampsia with severe features. So like we discussed, this is going to be a patient that has any type of sign of end organ damage. So I know we had discussed preeclampsia regular. Now preeclampsia with severe features is going to be any patient that presents with signs and symptoms of severe organ damage, including proteinuria. And once again, this is going to occur when after 20 weeks with these patients. So they're going to have blood pressure of greater than 160/10. They're going to be presenting with protein in their urine, right? They're going to have evidence of end organ damage, so those headaches, right, like we discussed, right upper quadrant pain, that's how they'll say, or just any sign that is not only hypertension, but another sign. So another thing to keep in mind is that with these patients, once again, we only treat them if they're greater than 160/110. And once again, the prophylaxis we're going to give is going to be magnesium sulfate for seizure prophylaxis, and ensure that these patients, they deliver the babies. And another thing to keep in mind is another thing that they really like to test is magnesium toxicity. So how is the patient going to present with magnesium toxicity? So you have a patient that presents preeclampsia with severe features, or they even have full-blown eclampsia with the seizures. Then with these patients, you give them magnesium, right? So how is the patient going to present? It's telling you that the patient has magnesium toxicity. So they're going to have loss of deep tendon reflexes. They're going to be very they're going to have bradyapnea. So they're going to have a decreased respiration rate, less than 12 per minute. Also, they're going to have presenting with they can even present into cardiac arrest, right? So usually with these patients, we're going to give them calcium gluconate. So the next one's going to be full-blown eclampsia. So it's going to be a patient with hypertension, those severe signs, and on top of that, they're going to have a seizure. So that's what's going to differentiate your eclampsia from preeclampsia with severe features is eclampsia is going to have that seizure versus preeclampsia with severe features. It's just going to have that very high blood pressure with signs and symptoms of end organ damage. So once again, proteinuria. The other one's going to be your headache, right upper quadrant pain, epigastric pain. And eclampsia is going to be all that, but you're going to add on top of that seizures. So it's going to be, once again, onset of new convulsions or coma in a woman with preeclampsia, right? And usually this patient is going to be presenting with either what type of seizures? It's going to be your generalized tonic-clonic seizures. That's something that they really like to test. So once again, generalized tonic-clonic seizures. And they're going to have either that or new onset of coma. They're also going to have ankylosing. That's another one that's very commonly tested for these patients. But before they get into full-blown eclampsia, like we discussed, they're going to have those signs and symptoms of preeclampsia with severe features. So they're going to have that right upper quadrant pain. We said those vision problems, right? They might see blurriness, scotomas, like we discussed. And with these patients, what do we want to do? Of course, we want to make sure we do an EEG. With these patients, we can do neuroimaging. And the complication of why we are so, it's really important that we treat patients with eclampsia is that they can actually have cerebral hemorrhages. So the first thing we're going to do with these patients, ABCs, right, airway, breathing, circulation, also seizure precautions, and we want to make sure that we treat the hypertension, so we can do either nifedipine for these patients, and we also want to make sure that we give the patient medications, of course, for the seizures, and we're going to give them magnesium sulfate and then deliver these patients. So it's once again, control the hypertension, like with nifedipine, control those seizures or that systemic vascular resistance prophylaxis with what? With magnesium sulfate, and deliver the patient. And once again, look for the magnesium toxicity signs. The big ones, those decreased deep tendon reflexes. They're going to be presenting with a decreased respiration rate. You're going to see EKG abnormalities with these patients. So once again, you have gestational hypertension, just hypertension with these patients, right? So gestational hypertension, and these patients have no evidence of proteinuria or end organ damage. So gestational hypertension, after 20 weeks, the patient gets hypertensive, no signs of end organ damage or protein. Now you have preeclampsia. These patients are going to be presenting with a very high blood pressure, greater than 140/90, and then they are also going to present with either one sign, right? One of your severe signs. Like we discussed, pulmonary edema, right upper quadrant pain, thrombocytopenia, kidney problems, headaches, and then you have preeclampsia with severe features. So these patients are going to have a lot of signs of evidence of end organ damage. So like we discussed, they're going to have a lot of the thrombocytopenia, proteinuria, renal insufficiency. Their blood pressure is going to be higher, so it's going to be greater than 160/110, right? And then we have eclampsia, which is going to be preeclampsia. So all that we discussed, hypertensive, those multiple signs of end organ damage, and on top of that, you're going to add neurological problems like seizures and or coma. And with these patients, ABCs, right, control the hypertension, give them magnesium sulfate, and these patients, we're going to deliver the baby. So the next one's going to be your RH incompatibility. So RH incompatibility. So RH incompatibility, what happens is that it's usually on your question set going to be an RH negative woman who has not had RH antibodies, right? And they've had fetal to maternal transfusion of RH positive fetal red blood cells. So the mom's blood mixes with the RH positive of the baby, and then that's what causes autoantibodies with these patients. So usually a mother is going to present with a history saying that their previous infant had hemolytic disease or they had elevated bilirubin levels with these patients, with the babies. And so how are you going to diagnose them? So you're going to do an IgM initially, and that's going to be elevated, right? Usually you'll see fetal Rh positive, and once again, mom's going to be what? Rh negative. You're going to see that the mommy is going to be positive for anti-D antibodies on what type of test? Your indirect Coombs test. So that's another thing that you need to know in regards to this one. You're going to do an ultrasound for these patients, and you can also see fetal hydrops. So what is fetal hydrops? That's when you see abnormal accumulation of fluid in 2 or more fetal compartments that include ascites, pleural effusion, pericardial effusion, and skin edema. And if you do the Coombs test on the baby, it's going to be positive. So the direct Coombs test on the baby is going to be positive for these patients. So once again, make sure that you know this, right? So the mom is going to be Rh what? The mom is going to be Rh negative, and the baby's going to be Rh positive. And then that's how you have to have some type of mixture from the mom to the baby for the blood to mix in order for the mom to start developing those Rh antigens. So the mom's going to be producing these antibodies to the Rh positive antigens, right? And usually there's going to be some type of history where the mom has some type of event that sensitized it. So the mom, from a previous pregnancy, the mom developed already those antibodies, right? So that's why when the second pregnancy comes, the mom's antibodies are ready and they're ready to attack the baby. Some of the events that can sensitize a mom, right, in the first pregnancy can be things like spontaneous, complete or incomplete abortion, elective abortion, any type of trauma, like abdominal trauma, intrauterine fetal death, delivery of an Rh positive baby or ectopic pregnancy. So just real quick to go into the pathophysiology, right? So you have your first pregnancy, the mom is what? The mom's Rh negative and the dad's Rh positive. So then what happens is that, of course, the baby's going to be Rh positive. Why? Because the dad is Rh positive. And so what happens is that the Rh antigens from the fetus that is developing can either enter the mom's circulation and they're going to cause the mom to produce antibodies to Rh positive antigens, right? So the mom's already produced these Rh positive antibodies in the first pregnancy. So then you have the second pregnancy. So the mom already has these anti-Rh antibodies that are prepared and they're ready. And what happens is that that's when you have these anti-Rh antibodies that pass from the mom through the placenta and attack and destroy the baby's red blood cells. And that's what can cause severe hemolysis. So that's why the mom has to be sensitized some way. Her blood has to mix some way to be primed and create those anti-Rh antibodies. That way when the second pregnancy comes, they're ready and then they attack the baby. So what's going to be the treatment for these patients? We're going to give the mommy 300 milligrams of Rogam at 28 weeks routinely and also within 72 hours of delivering an Rh positive baby. Once again, how are we going to treat this? 300 milligrams of Rogam at 28 weeks and within 72 hours of delivering an Rh positive baby. So if the father is Rh negative, usually these patients don't need Rogam, right? Because it's very likely that the baby is going to be Rh negative. So once again, this is something that's very highly tested. So it's going to be an Rh negative mom, right, with a baby that is Rh positive. And usually we usually are worried about babies that might have Rh incompatibility with the mommy and daddy. If the mom is Rh negative and also if the dad is unknown, so if we don't know if the dad is Rh negative or positive, we still tend to do this prophylactically, just to avoid what? Hemolytic disease of the newborn. So this is something that's very highly tested, so make sure you know this. The next one we're going to go into is going to be labor and delivery complications. So what are some of the complications that can occur in labor and delivery? So we can think about breech presentation. This is where the fetal pelvis or the lower extremities engage the maternal pelvic inlet. So that's whenever the baby's being pushed out of the mommy, right? Instead of the head coming out of the vaginal canal, right, you're going to have the opposite. So you're going to have the lower extremities coming out or the fetal pelvis coming out through the maternal pelvic inlet. So there's a lot of risk factors for a baby to be born with breech presentation. Polyhydramnios is another one, so having too much fluid in the placenta, right? Uterine abnormalities, also abnormal placentation, if the mom is older also. And with these patients, how are we going to diagnose them? So we're usually going to do a physical exam. We're going to palpate the fetal parts over the maternal abdomen, or even by the pelvic examination, we can kind of see where is the baby at. And some of the signs that we're going to do in physical exam findings that we can do to confirm that the patient is at breech is going to be the Leopold maneuver, right? And for breech, there's different types of positions. So there's frank, complete, and footlong. So once again, frank breech, complete breech, and footling breech. So if it's a frank breech, usually both of the hips are going to be flexed and both of the knees are going to be extended. So once again, the hips are going to be flexed and the knees are going to be extended. So it's a baby like this, and their feet are literally like up straight. It's a baby like this. And that's how they're going to be coming out through the vaginal canal. And then you have your complete one, which makes sense because it makes sense that it's complete because both the hips and the knees are flexed. So the hips are going to be flexed and the knees are going to be flexed also. And then you have your footling. There's a really cool comic picture, and it's literally a baby going like this and doing a karate, like hi-ya with one foot. And that's when one or both of the legs are extended below the buttocks. So it's really important that you know this one, right? Your breech. So once again, instead of the head coming out of the vaginal canal, it's going to be the feet. And you can either have frank, complete, where everything's flexed, or your footling where there's like 1 foot out. So with these patients, we're going to confirm that the patient is the pregnant woman is having a breech pregnancy by doing an ultrasound. So it's going to differentiate between a breech presentation and a cephalic presentation. And how we're going to treat these patients. So the first thing we're going to do is, of course, once you do feel that and you do see that the baby is in a breech position, we're just going to observe them first. Sometimes they just spontaneously go back to the cephalic position. But if they have not gone back into the cephalic position, then with these patients, what we're going to do is we're just going to do the external cephalic version. So we're going to manipulate the fetus through the abdominal wall from breech to cephalic presentation. So that's what we're going to do with these patients. So the next one's going to be dystocia, and I apologize if I missaid this. So this is the inability to deliver the shoulders after the head has delivered. So remember that we said the most common presentation is going to be where the baby's head is coming out, so cephalic, versus a feet, which is a breech presentation. So if the head comes out of the vaginal canal, sometimes the head gets stuck and you're not able to deliver the shoulders. And it's really important that we deliver the shoulders appropriately, right? Because if we hyperextend it too much, then the baby can come out with like Erb's palsy, or you can damage that nerve that goes there. So with these patients, some of the big risk factors for dystocia is going to be your fetal macrosomia. By far, that's going to be one of the big ones. So those really, really big babies, right? That's why it's really a lot difficult to deliver these babies. Gestational diabetes, or just diabetes in general, because once again, gestational diabetes is highly associated with fetal macrosomia, like we discussed previously. If the patient has a history of shoulder dystocia and a prior birth, right? So with these patients, what are we going to do? So what we're going to do is that we're going to do a gentle downward pressure on the head. And if this fails to deliver the anterior shoulder from behind the pubic symphysis, then usually this is a sign that the patient has shoulder dystocia, right? We want to make sure that we avoid continuing to apply downward pressure on the head. Why? Because remember that we said it can damage those nerves, so it can damage that brachial plexus. And some of the complications, Erb's palsy, like we said, that's one of the big ones that we are very, very worried about. So some of the maneuvers that we can do to ensure that we get that shoulder out safely and we don't, of course, injure that plexus, right? Injure that brachial plexus, is that we can do something like the McRoberts maneuver. The McRoberts maneuver, what it does, it's a hyperflexion of the maternal hips. So you hyperflex the maternal hips, you flatten that sacrum, and you do a cephalic rotation of the symphysis pubis with these patients. So that's going to be your McRoberts maneuver patients. You can also do a Rubens or reverse wood screw maneuver. And usually with these, what you do is that you rotate the posterior shoulder and then you deliver the rotated shoulder. So there's so many maneuvers that you can do. By far, the most common one that's going to be tested is going to be your McRoberts maneuver. And what you really need to know about this one is that you have to be really careful with the shoulder, because if not, you're going to damage, once again, that brachial plexus. You're going to damage those nerves, and this patient can present with Erb's palsy. That's a complication. So just keep that in mind. Another thing, like I said, that they really like to test is that babies that are prone to getting shoulder dystocia is going to be a mom that has a history of gestational diabetes or macrosomic babies. So usually with these patients, treatment, like we said, it's going to be the McRoberts maneuver with these patients. Also, if a woman has a future delivery and they had a prior history of dystocia, then we can offer them C-section just to avoid this, right? And like we said, there's so many other maneuvers, like your Barnum maneuver, your Zavanelli maneuver, and Zavanelli is actually the last line maneuver. So let's go into premature rupture of membranes. Premature rupture of membranes. So some of the risk factors for premature rupture of membranes is going to be if the patient has a history of any type of genital tract infection, like BV. Do they smoke? Do they have a prior preterm premature rupture of membranes? Like how small is their cervix? If it's like very short, and they're very prone to getting a premature rupture of membranes. And with these patients, how are they going to present with your premature rupture of membranes or pre-labor rupture membranes. So with these patients, it's going to be any patient that's presenting with membrane rupture prior to labor. And what they really like to test you on this is the difference between preterm premature rupture membranes and just regular premature rupture membranes. This is something that's very highly tested. So it's really important that you know the difference. So premature rupture membranes is going to be any type of membrane rupture before labor, right? Versus preterm premature rupture membranes is going to be premature rupture membranes that occurs less than 37 weeks. So once again, premature rupture membranes is going to present with a patient that's presenting with rupture membranes greater than 37 weeks of gestation. So the patient's going to be presenting with gush or fluid, right, leaking from the vagina with these patients. And it's important that whenever a patient comes in like that and they're leaking fluid, it's a pregnant patient, we're going to avoid inserting anything. So avoid any type of digital exam. Why? Because you're going to be introducing bacteria into that sterile uterine cavity, and the patient can be at risk for chorioamnionitis, which we're going to discuss in a few minutes also. So some of the hallmark findings to differentiate premature rupture membranes from like anything else is by far the big one's going to be on your vaginal fluid, you're going to see ferning, and that's something that's very highly tested. So once again, ferning, so fluid ferning, and then you're also going to see the nitrazine paper, which is going to be blue. So you're going to see a blue nitrazine paper. So both fluid ferning and a blue nitrazine paper is going to tell you that the patient, that is amniotic fluid. So amniotic fluid, right, that tells you that the patient is in premature rupture of membranes. And what is premature rupture membranes? Greater than 37 weeks when you have the rupture of membranes. So why does the nitrazine test turn blue? Why? Because it's the amniotic fluid is alkaline. So that's why the pH is alkaline. That's why it's going to turn blue. Another thing you'll see is pooling. This is actually a key word that I keep seeing also on my question when I was practicing, is you're going to see collection of amniotic fluid in the posterior fornix. And another thing that is really interesting is that if you see a positive phosphatidylglycerol, that's going to indicate pulmonary maturity for patients between 32 to 34 weeks. So with these patients, what do you want to do? So in your premature rupture membranes, which is greater than 37 weeks, with these patients, what we're going to do is that if there is chorioamnionitis that we suspect, then these patients are delivered, regardless of how far along they are, right? If there's no infection and the patient is greater than 37 weeks, so this patient's in premature rupture membranes, then we can just manage them, right? Actively or expectantly. If the patient is preterm premature rupture membranes, so any patients that's less than 37 weeks, then with these patients, what we're going to do is just similar to delivery to preterm labor. So another thing that we do is that we also give the patients antibiotics and hydrate them. So we'll give them something with IV ampicillin. This is going to reduce the risk of amnionitis, right, and neonatal sepsis. So we'll give them something with ampicillin, usually with these patients. And then we can also give them tocolysis. This is going to help us prolong the interval of delivery to gain time for steroids to be administered, especially in your patients that are in PP-ROM, right? Premature pre-rupture of membranes. Preterm premature rupture membranes. So the next one we're going to go into is going to be preterm labor. Preterm labor. So some of the common causes of preterm labor is sometimes it's idiopathic. With these patients, there are risk factors. So preterm labor, some of the risk factors are going to be premature rupture membranes, like we discussed, right? Multiple gestations, any type of Mullerian abnormalities, smoking, substance abuse, and also short cervical length. And with preterm labor, it's just when the patient has contractions, but they're also having cervical changes. So usually with these patients, when we do the tachometer, you're going to see regular rhythmic contractions 5 minutes apart. And some of the physical exams you're going to see is the cervix can either be long and closed or the cervix can be dilated in the face. Both of them can actually occur. How are we going to diagnose this patient? We're going to do a transvaginal ultrasound, and that's where we're going to see the effacement and dilation changes of the cervix of at least 1 centimeter. We're going to make sure that we monitor the baby with a tokodinamometry. We're going to do a fetal fibronectin, right? This is going to help us rule out preterm labor. And with these patients, if the patient is in preterm labor and they're between 24 to 34 weeks, we're going to give the patient steroids. We're going to give the patient antenatal steroids. Why? Because remember when we were discussing in general, like when is a baby viable, right, to be born? Usually we try to maintain the pregnancy to full term. And the way that we can do that is by giving steroids. If the baby does need to be delivered, then what we're going to do is we're going to give the patient steroids. It's going to help develop those babies' lungs. So what we're going to do is we're going to treat with betamethasone, right? Especially like we said, if the patient is at an increased risk of delivering preterm, and this is going to help increase that pulmonary maturity. We're going to hydrate and observe the patient, and then we're also going to do tocolysis for these patients. So tocolysis, some of the medications that we use is going to be terbutaline, right? And you can also use magnesium sulfate. You can also use nifedipine. So it's going to be the next one. It's going to be prolapse umbilical cord. This is where you have descent of the umbilical cord into the lower uterine segment. So that umbilical cord is going to be descending, not where it usually is. And it can lie adjacent to the presenting part, which is known as your occult cord prolapse, or below the presenting part, which is the overt cord prolapse. So some of the complications of prolapse umbilical cord and why we need to make sure we treat it appropriately is that usually with these babies, the compression can be complete and you're not getting blood, oxygen, nutrients, nothing to the baby because that umbilical cord is being prolapsed, right? So usually the baby is going to be presenting with your variable fetal heart rate decelerations when the mommy is having contractions. So with those uterine contractions, you're going to have that variable fetal heart rate decelerations. If the compression is complete and it's been going on for a very long time, right? So full compression, very long time, the baby's not getting, like we said, oxygen or anything like that, then that's when you start seeing that bradycardia, hypoxia, metabolic acidosis, even death with these babies. So the treatment for this is, what we want to do is that we give tocolytics usually to prevent cord compression. So tocolytics, what they do is that they decrease the uterine contractions and they're going to relieve that pressure on that prolapse cord, right? Because whenever the mom has a uterine contraction, it's going to put more pressure on that prolapsed cord. So tocolytics are going to decrease the uterine contractions, relieve the pressure on the prolapse cord. In addition, tocolytics are really good. Why? Because they're going to improve that placental perfusion and blood supply to the baby. But once again, they're not first-line management, but just to make sure that you consider them if the delivery is going to be prolonged, right? Or it's a very, very long delivery, like we said, and also if it's a very hard delivery. But usually the treatment of choice is going to be a C-section, right? But if vaginal delivery is quicker, then we can do vaginal delivery. So the thing we want to do is we want to act quick, right? We want to make sure that there is not being prolapse of that cord, umbilical cord, because once again, we said that the baby can die. So fetal distress, how is the baby going to present when they're in fetal distress? So usually with these patients, with babies, right, the baseline fetal heart rate is usually approximately, the mean rate is rounded to an increment of 5 beats per minute during a 10-minute tracing segment for these patients. So in any 10-minute window, the minimum intraprenatal baseline duration has to be at least 2 minutes. And some of the things that have been associated with a diminished beat-to-beat variability is things like magnesium sulfate, right? But usually the most reliable sign that there is some type of fetal compromise is going to be your reduced baseline heart rate variability. So you have to see some type of heart rate variability. If you don't see any of that, then we're thinking about something's going on with the baby, right? So with these patients, some of the things that we measure is going to be your acceleration, contractions, variability, and then also baseline. So the baseline is usually normal is between 110 to 160 beats per minute. So that's going to be the baseline. Anything that's greater than 160 beats per minute is tachycardia. Anything that's less than 100 beats per minute is going to be bradycardia. And then we also look at the variability. So variability is going to be the ability of the heart rate to change above or below the baseline. So is there any variability? If usually with these patients, if we see no changes to the baseline, then that's considered absent variability. If we see a less than 5 beats per minute change, then that's minimal variability. Moderate is between 6 to 25 beats per minute change, and marked variability is going to be anything more than 25 beats per minute change. So that's going to be your variability. And then acceleration. After 32 weeks pregnancy, what you expect to see is going to be an increase in fetal heart rate by 15 beats per minute for 15 seconds over a 2-minute tracing rate. So those accelerations. Before 32 weeks, an increase in fetal heart rate by 10 beats per minute for 10 seconds over a 2-minute tracing is what you expect to see. So if you don't see any of these, then you are thinking that there might be something going on. And that's what we're actually going to discuss next. So fetal distress. And we look at that with the fetal heart rate, right? Because we're monitoring the mom's heart rate and the fetal's heart rate. And then also, what is the fetal heart rate in comparison to the contractions that the mom is having? This is something that's really, really highly tested. So it's really important that you know and you're familiarized with these findings. So the mnemonic for fetal heart rate, whenever you're reading them, is, and this is from Rosh review, is VEALCHOP, VEALCHOP. I thought it was a really good mnemonic, and it really helped me out throughout my exams. So VEALCHOP, V is going to be variable. So whenever we see a variable fetal heart rate, we're thinking about cord compression. If you see early decelerations with these patients, we're going to see, usually we think about head compression with these patients. If you see accelerations, O is going to be okay for your CHOP, and then late is going to be associated, or your late decelerations is going to be associated with placental insufficiency. So once again, variable decelerations, right? Cord compression. Early decelerations is going to be your head compression. Accelerations in general are good, and late decelerations are going to be a sign of placental insufficiency. So once again, this is something that's very highly tested in regards to when you are looking at your tracing segments, right, for the babies, and you're monitoring that fetal heart rate. So what are some of the causes of each one? So early decelerations, usually with these patients, it's when the baby's in, the mom's in active labor, right? And late decelerations, this one's the one that we have to look for because it's associated with uteroplacental insufficiency. So how do we treat this? So how we're going to treat it is that we're going to give oxygen to the mom, because the more oxygen you get to the mom, the more oxygen is going to be given to the fetus. You're also going to stop things like Pitocin. You're going to give IV fluids. Why? Because more fluids are going to be going to the placenta, so the baby's going to get more perfused. You're also going to place some mommy on the left lateral decubitus position. So you can roll the patient on the left side. And what is this going to cause? This is going to rotate that uterus off that inferior vena cava so there's going to be increased venous return to the placenta. So these are some of the maneuvers that you can do to treat things like uteroplacental insufficiency, which is associated with your late decelerations. And like we said, accelerations are going to be normal, right? Like we had discussed earlier. Bradycardia is going to be a fetal heart rate that's going to be less than 110 beats per minute. It's associated usually with magnesium sulfate, epidurals, placenta abrupta. Tachycardia is going to be a fetal heart rate baseline greater than 160 beats per minute. Usually we think about chorioamnionitis, some type of compromise that is occurring with the fetus. This is usually bad. And maternal administration of atropine or certain medications like terbutaline, right? So this is something that's very commonly tested. Once again, make sure you know these. So what you're expected to see is that you'll have a picture of just the contractions, right? And then you'll have a picture of the fetal heart rate. And what you need to know in comparison is just reading each one, right? So there has to be accelerations that are present, and usually they mirror the contraction. So you have the contraction and then you'll have the acceleration. That's usually normal. If there's a late deceleration, which means that you have the contraction and then the deceleration occurs after the contraction, like it's not mirroring it, this is where we think about those late decelerations like uteroplacental insufficiency, right? Or the variable decelerations, like there's an abrupt decrease in fetal heart rate, with these patients, then, like we said, we are concerned about cord compression. Let's go into endometritis. This is going to be an infection of what? The endometrium, very commonly found usually in women after pregnancy, right? So how is this woman going to present? The woman's going to be presenting with a fever, so greater than 38 degrees Celsius or greater than 100.4 degrees Fahrenheit. And it's usually going to be presenting, the woman's going to be presenting after they delivered a baby, so post C-section or vaginal delivery. They're going to be presenting with pain in the peritoneal area. They're going to be presenting with vaginal discharge. They're going to have lower abdominal tenderness. The keyword for this one's going to be that foul-smelling lochia. So foul-smelling lochia. They're going to be tachycardic, tachypnic. They'll have uterine or fundal tenderness. And like we said, also the fever. Diagnostics, we're going to do a gram stain to look at the bacteria that's causing this infection in the woman, CBC, and then a UA also. Treatment for this is going to be IV gentamicin, plus IV clindamycin. If the patient's very, very ill, they're super sick on the question stem, then you're going to give IV cefoxitin or IV meropenem. So once again, this one's very highly tested, so expect this one on this exam. So it's going to be a woman with endometritis. It's going to be a woman or an infection so the infection of the endometrium, it's going to be a woman post-delivery, post-C-section, post-vaginal delivery, and they're going to be looking really sick, right? Fever, peritoneal pain, that very foul-smelling lochia, abdominal tenderness, abdominal pain, endometritis. So what are some of the normal physiological changes we expect to see in a woman that has delivered a baby? So usually when we think about this, we think about the puerperium, Puerperium, and I apologize if I said that. And this is usually about 6 weeks after the woman delivered their baby, right? And usually what happens after this is that about 5 to 7 days, after the 5 to 7 days, the uterus starts becoming firm and it's not tender anymore. So it starts extending midway before the symphysis and pubis. So it starts going back to where it was previously, before pregnancy. And then by 2 weeks, usually the uterus is no longer palpable abdominally, and by 6 weeks, it went back to where it was before the pregnancy. Another thing that is very commonly tested is the discharge that a woman sees after they give pregnancy, so postpartum. So it starts with your lochia rubra. So your lochia rubra is going to be blood, you'll see shreds of tissue, and decidua. It tends to last for about 3 to 4 days. There's also your lochia serosa, which is mucopurulent, pale, malodorous. And then we have our lochia alba. This one's thick, mucoid, yellowish white, usually between the 2nd to 3rd week. And usually all these tend to go away by week 5 to 6 postpartum. The cervix is going to close, right? And it's going to start going into that transverse slit that we see on anatomy books. The vagina, the wall is going to go back to normal after the 3rd week postpartum. And the woman's going to start ovulating around 70 to 75 days after delivery, sometimes up to 6 months. Why? Because you have very high levels of prolactin, and that's suppressing that ovulation. The menstruation is going to go back to the woman as soon as 7 weeks in non-lactating woman. But if the woman's lactating, then it can be as long as 36 months. So that's a key, right? Lactating woman, 36 months. Non-lactating woman, they can expect to have their period as soon as 7 weeks. And it's really important that if it's a woman that wants some type of oral contraceptive, we try to defer them until 6 weeks after pregnancy. Why? Because just a woman is in a very hypercoagulable state, right? Those fluctuation of hormones, the fact that they're also not moving around as much. So we try to defer them until 6 weeks postpartum. Another one that's very highly tested is going to be your colostrum. This is going to be that pre-milk secretion. It's a yellowish alkaline secretion that's present in the last months of pregnancy and the first 2 to 3 days after delivery. And the thing about this colostrum is that it has so many vitamins and it's really, really good for the baby. So it has a lot of protein, it has vitamin A, immunoglobulins, right? Because that's how the baby is protected the first few months from infections, is that the mom passes those immunoglobulins to that baby. After a few months, then the baby starts producing their own immunoglobulins, right? But during that time, like right after birth, the baby depends on the mommy's immunoglobulins. And this is where they get it from, the colostrum, right? And just the mommy's also milk. Also, what else is associated in the colostrum? You'll have sodium and chloride content. And like we said, immunoglobulins are found in that milk. By far, the most common immunoglobulin that you're going to be expected to be found in milk is going to be IgA. So IgA constitutes about 90% of immunoglobulins in human colostrum in milk. So just make sure you know that. So once again, right, that colostrum is going to be that pre-milk secretion. It's like a yellowish secretion. It's present in the last months of pregnancy and the first 2 to 3 days after the mom has delivered. It's really rich in protein, vitamins, right? We said vitamin A, immunoglobulins, and that's why this is really, really nutritious for the baby. And like we said, there's a lot of immunoglobulins that are found in milk, but by far the most abundant one is going to be your immunoglobulin A. So IgA is going to be the most abundant one in both the colostrum and also the human milk. So the next one's going to be postpartum hemorrhage. This is something that's also very commonly tested. So make sure you know this. As you can see, I keep saying most commonly tested because these were some of the topics that I saw when I was taking on the exam, when I was taking questions, practice questions. These are some of the topics that they really like to test. So this one is one that you have to know. And what are some of the risk factors for a woman developing postpartum hemorrhage? So of course, how prolonged was their labor? So did they have a prolonged third stage of labor? How many deliveries did they have? So multiple deliveries. Episiotomies is one of the ones that's very highly associated with postpartum hemorrhage. Another one is fetal macrosomia, so that the size of the baby that can cause trauma to that vaginal canal. And the most common cause of a lot of blood loss in pregnancy is going to be your postpartum hemorrhage. So this patient is going to be presenting with vaginal bleeding, right? Usually greater than 500 milliliters. You're going to see an enlarged uterus, or you might even feel a vaginal mass. And the patient, and why it's really important that we treat these patients so that they can go into shock, right? They can become hypotensive, they can become anemic. And for these patients, we're going to do a CBC, coagulation studies like your PT, PTT, and platelet count. We just want to rule out any type of clotting disorder, BUN, serum creatinine, and type and screen in case the patient needs blood transfusions. So the treatment is really going to be based on what are some of the causes, what is causing this, which we're going to go through in a few minutes. So first, of course, we're going to do that physical exam, right? We can also give IV oxytocin. That's going to be for your urine atony. And also, we can do DNC for these patients. So what are some of the causes of just postpartum hemorrhage? So uterine atony, retained placenta, lacerations or uterine rupture, and then coagulopathy. So these are some of the things that we want to keep in mind whenever we're reading the question stem. Woman comes in, they just have pregnancy, and they're losing a lot of blood. Right? By far, the most common one is going to be uterine atony, but with these patients, make sure that we think about all these causes. So it's usually your 4 T's, uterine atony, which is going to be the first one, tissue, so retained placenta. The third T is going to be neotropic trauma, so lacerations, episiotomies, like we said, uterine rupture. And the fourth T is going to be clotting, so that's going to be any type of coagulopathy that the mommy might have. So with these patients, what's going to be the treatment, right? So since atony is one of the most common causes by far, usually what we do is going to be a bimanual uterine massage, right? And then compression, that's what we're going to do first line. And after we've done that, then that's when we can give medical treatment. And usually IV oxytocin is going to be your first line. So once again, atony is going to be the most common one with these women. And usually with these patients, you're going to try to massage, right, that uterus. And then if that does not work, then we're going to give them IV oxytocin. So that's going to be your first line medical treatment. So if it asks you what's the next step, you're going to massage that uterus. What's the best medical treatment? Then it's going to be your oxytocin, these patients. If there's any type of retained products, then you have to do suction and curettage just to remove anything that's retained. If there's uterine inversion, then we're going to reposition that uterus manually. And we can also give them medications like nitroglycerin, terbuline, magnesium sulfate. So the next one's going to be your episiotomy. So this is going to be an incision of the perineum. It can either be midline or mediolateral. According to ACOG, which is the American College of Gynecology, I believe, they recommend actually restricted use with episiotomies because there's so many complications that are associated with episiotomies. So these patients are more at risk for getting 3rd to 4th degree lacerations, which go deeper into the tissue, right? Can even extend to the anal canal. And these patients are at risk for fecal incontinence also. They will heal slower, very, very painful. And usually we only do episiotomies if, of course, there's a breech pregnancy, also those macrosomic babies, those really big babies. So once again, routine episiotomy is not something that we do a lot because there's so many complications that are associated with it. If you do decide to do an episiotomy, then of course after delivery, if you do cold compresses to the perineum, that can actually decrease the patient's discomfort and pain. Also, like after the episiotomy, once you've done that, like at home, just make sure you educate the patient in regards to doing cold or iced sitz baths, right? NSAIDs is another thing that you can give for these patients, especially like we said, this is very, very painful. You can either do midline or mediolateral. And here in the US, midline episiotomies are more common here in the US and in Canada, but mediolateral episiotomies are usually what they use in other parts of the world. But here in the US, midline episiotomies are the ones that are going to be done. And then, of course, depending on the laceration is going to be the degree that it is. So 1st degree, usually it involves a fourchette or perineal skin in the vaginal mucosa membrane. 2nd degree, it's going to be the fascia and muscles of the perineal body. And then we said, remember, the 3rd degree and the 4th degree, these are more severe. So 3rd degree is going to extend to that external anal sphincter, because if we think about the anatomy, you have the vagina, you have the rectum. The 4th degree, this one goes through to the rectal mucosa, and it includes the internal anal sphincter. So this one goes through everything. So just make sure that you know that. So which one of the episiotomies that we discussed, mediolateral or midline, is less commonly associated with these 3rd or 4th degree lacerations? Usually the mediolateral is going to be the one that's going to be not and having a less risk of your 3rd and 4th degree lacerations is going to be your medial lateral. The next thing I wanted to go over was just normal labor progression, the stages, like your 1st stage of labor, your 2nd stage of labor, and your 3rd stage of labor. This is something that's also very commonly tested. So let's go into each one. 1st stage of labor is going to be time from onset of labor to complete cervical dilation. So once again, when the labor started to when the cervix is completely dilated is going to be your 1st stage of labor. And that's divided into 2 phases. You have your latent phase and then you have your active phase. Okay. So your latent phase is going to be the first one. This is where you start seeing those cervical changes, and it ends at approximately 5 centimeters. So the cervical changes to 5 centimeters, that is going to be your late phase of stage 1. Your active phase is going to be where you have cervical changes from 6 centimeters until full complete cervical dilation. So this is something that's very commonly tested. 1st stage, once again, time from onset of labor to complete cervical dilation. Latent phase is going to be those gradual cervical changes up until 5 centimeters, and then active phase is going to be from your 6 centimeters until full-blown complete cervical dilation. Your 2nd stage is going to be time from complete cervical dilations to the fetal expulsion. 3rd stage is going to be time between the fetal expulsion until placenta expulsion. So this is another thing that's very highly tested. So make sure that you know that. So we are done with OB-GYN. Please let me know, as always, if I have any mistakes. As you can tell, I was going through certain subjects, and some of these subjects are not my forte. So if I had any mistakes, please let me know, comment below. That way I can add it in the description. Also, if you have any cool mnemonics for any students to learn certain diseases, I remember we were talking about veal chop, VEAL space CHOP. That's like a cool mnemonic that really helped me out in regards to the fetal heart rates, what they're associated with. If you have any cool ones like that, if you can comment below, it'll help other students out. And as always, like I say, we always want to make sure that we want to be the best PA providers that we can to ensure that we are providing the best treatment for our patients, and also to pass, of course, the PANCE, right? And then this end of rotation exam. So by watching this video already and completing this video, you are definitely taking a step more towards passing your PANCE and providing that best care towards your patients. As always, if you have any questions or any feedback for me, please comment below, and I will talk to you guys later. Bye.